Так, коллеги, мы запустили два стрима. Сейчас начнем проверять сначала русский, потом английский, поэтому попрошу пока какое-то время кого-то из переводчиков, Ольга или Анжелика, просто говорить. Так, коллеги, мы запустили два стрима. Сейчас начнем проверять сначала русский, потом английский, поэтому попрошу пока какое-то время кого-то из переводчиков, Ольга или Анжелика.
Floor. Mostly? On the floor. Yeah.
Adrian, I can't hear my interpreters in the stream, Russian stream. They're speaking, but I can't hear. Проверяем, слышно ли меня параллельно с переводчиками. Раз, два, три, раз, два, три, раз, два, три, раз, два, три, раз, два, три. Так, Ольга, спасибо большое. Можно пока помолчать. Я сейчас попрошу переводчиков, которые с французского на английский переводят, нужно проверить, что вы их тоже слышите. Потому что у меня рядом тут лежит телефон со стримом. Я выключила, простите. Так, сейчас проверяем, слышно ли перевод с французского на английский. Слышите что-то? Угу. Хорошо поняла? Да, сейчас объясняем, что нужно сделать. Да-да, ждем, когда люди, которые тут выступают на французском, мы будем переводить их на английский, а вы должны услышать английский.
Okay, all right. I can even go this.
Good morning, ladies and gentlemen. Good morning, ladies and gentlemen. Welcome to the second day of our international conference on the cooperation
Супер. Значит, сейчас я еще раз попрошу Ольгу или Анжелика кого-то поговорить. Последний раз проверю стрим и, в принципе, ждем, когда начнутся участники у нас. Так, да, отвечаю про вопрос французского оратора. Все правильно. Спикер выступает на французском. После этого мы в будке переводим его на английский. Вы получаете этот английский и переводите его на русский. Понятно объяснила? Супер. Все, давайте до последней проверка стрима и ожидаем гостей.
флешку куда скинуть с презентации? Я скидывал Алексею, я чуть-чуть ее поправил. Ну, в смысле, я ее чуть-чуть, не чуть-чуть поправил, она у меня была 16. Нет. Может скинуть кому?
Скинуть меня, но сейчас мы проверим.
А, хорошо, ну, в смысле, я все это.
So guys, could you please make some presentation on the stream to be sure that my interpreters can see it in a Zoom? Ольга, Анжелика, можете кто-то еще немножко поговорить, чтобы мы еще раз проверили? Говорю параллельно с переводчиками, говорю параллельно с переводчиками, говорю параллельно с переводчиками.
Одень и не снимай. По-моему, после разговора твоего он начинает заикаться через там минуту.
Да, посмотри, как работает Zoom. Как только один канал выходит, другой блокируется. Поэтому можно...
А тут же постоянно. Вот так ее слышно хорошо. Вот так слышно хорошо. А просто параллельно разговаривать.
Говорю параллельно, 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 говорю параллельно. Запустили вам презентацию, видите вообще в зуме? Там что-то происходит с ней по цвету. Супер, спасибо. Да, я вижу. Что она? А это вы можете настроить у себя в зуме, как вы видите. Да, это ваша настройка, не наша. Так, уважаемые переводчики русского языка, Анжелика, Ольга, спасибо вам огромное. Мы закончили тест. В 8:30 мы планируем начать, поэтому будем готовы. Всем спасибо. Еще раз прослушала вопрос, Ольга. Все, супер, спасибо.
Hello, good morning to all our participants. This is the English channel, and we'll be discussing about global health. And 1, 2, 1, 2, 3, English channel speaking. 1, 2, 1, 2, 3, testing, English channel speaking. 1, 2, 1, 2, 3, English channel speaking. 1, 2, 1, 2, 3, English channel speaking. 1, 2, 1, 2, 3, testing, English channel speaking. 1, 2, 1, 2, 3, English channel speaking. 1, 2, 1, 2, 3, English channel speaking. 1, 2, 1, 2, 3, testing, English channel speaking. 1, 2, 1, 2, 3, 1, 2, 3, testing, English channel speaking. 1, 2, 1, 2, 3, English channel speaking. 1, 2, 1, 2, 3, English channel speaking. 1, 2, 1, 2, 3, testing. 1, 2, 3, English channel speaking. 1, 2, 1, 2, 3, English channel speaking. 1, 2, testing. 1, 2, 3, English channel speaking. 1, 2, 1, 2, 3, English channel speaking. 1, 2, 1, 2, 3, English channel speaking. 1, 2, testing. 1, 2, 3, English channel speaking. 1, 2, 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 1, 2, 3, English channel speaking. Testing, testing, English channel. 1, 2, 1, 2, 3, testing, testing the English channel. 1, 2, 3, testing. 1, 2, 1, 2, 3.
Говорю параллельно с переводчиком, говорю параллельно с переводчиком. Раз. Говорю параллельно с переводчиком. 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 Говорю параллельно. Говорю параллельно с переводчиком. Говорю параллельно с переводчиком. Говорю параллельно с переводчиком, говорю параллельно с переводчиком, говорю параллельно с переводчиком. Говорю параллельно с переводчиком, говорю параллельно с переводчиком.
which is
Let's check. 1, 2, 3, 1, 2, 3, 1, 2, 3. I can't hear myself. 1, 2, 3. Please switch on the micro on the podium. Good morning. Yeah, thanks, good. 1, 2, 3, 1, 2, 3. What is? How it's working? Please, another one. 22. Anywhere you want. You can try. Yes. One, two, three. Okay. So the teleprompter. Okay. Okay.
And that?
The next one. The next one. So what number is it? 28. 28? 26? 23. Okay, next one. Yeah, you're welcome. Okay. Is it 26? Okay, thanks.
This is the other side, right? Mic check, mic check, mic check, 1, 2.
One, two, three, 1, 2, 3.
Check 1 2. Check 1 2. Check 1 2. Check 1 2. Mic check 1 2. Mic check 1 2. Russia. So this is what she has. One. Mic check, mic check. Mic check, mic check.
Okuggyamu obuntu obwo bwakwegendereza bulungi nnyo abasizotenya baliwa abali ku
Mic check, mic check, mic check, mic check.
omukyala yabadde asabye live feed bagenda kola live feed omukazi gwatusaba live feed
1 2 3. 1 2 3. Mic check, mic check.
more. Nayenga, the best thing, which for me, if I stay in a society for 6 months, that language is done. Just comes. Because there is also grammar,
Check.
tenses.
English 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Verbs and nouns.
English 1, 2, 3, 4, 5, 6, 7. It should now be okay. It should now be okay. Adrian, 1, 2, 3. Adrian, 1, 2, 3.
Hello. Mic testing 1, 2. Can somebody who is controlling the lights ensure that the lights are not blaring the way they are? They are really very strong. Somebody on the lighting system, thank you. Thank you very much. That's much better. This light. Let's take our seats because this session is already on according to the time and would like to start and finish on time. I would like to encourage those who are outside to move into the conference room so that we start. Thank you. May I invite the presenters to come over and take their seats. May I invite the presenters to come over and take their seats. Thank you. Thank you. Money. Oh, please take that seat. Thank you. Thank you very much, presenters who have responded. Would like to encourage those who have not yet taken their seats to come over. The presenters for this session, you are most welcome to take your seats. Speaker Andrew from CPHL, you are missing. Andrew, come and take your seat so that we can begin. Good morning, everyone. Would like to call this session into order, and we start this session because of time. Would like to try to run this session and keep time. One of our presenters is not here, but we shall begin with those who are around. The session has two parts. Part one is early detection and rapid response to infectious diseases. And then part two is prospects for cooperation. We are privileged this morning to have two moderators. I would like my colleague from the Russian side to introduce himself, then I introduce myself, then I go through the program.
Спасибо большое, уважаемый господин сопредседатель, профессор. От российской стороны сопредседательствует на этой сессии Смоленский Вячеслав, заместитель руководителя Федеральной службы по надзору в сфере защиты прав потребителей и благополучия человека. Роспотребнадзор. Спасибо.
Okay, thank you very much for that introduction. So, because this is a cooperation, I'll be introducing the African colleagues to go and present as introduces the Russian colleagues to present. So, on that basis, the program will run as scheduled apart from where Andrew is supposed to present, so we might skip that unless he arrives in time. That said, the last session will be between me and my co-moderator to present. I'll be presenting, and then he will come to respond to the presentation. Without wasting more time, I would like to take this opportunity to thank all those who are prepared and they are ready to present today. But I would also like to thank each one of you for making it in time. It's now time for us to start, and I hope this becomes a very productive session. I take this opportunity to welcome Dr. Francis Kakoza, who is going to present on globalization of One Health approach and in reference to COVID-19 pandemic. Dr. Kakoza, I do not have your CV, but I know you're a very highly researched person, and I would like you to introduce yourself when you take the podium and you start your presentation. You're welcome.
Thank you, moderator. Thank you, moderator. Good morning, participants. My name is Francis Kakoza from Makerere University. My training is in lab science, public health, and a PhD in molecular epi, and currently undertaking my postdoctoral studies. I'm going to share with you a topic on globalization of One Health approach for early identification and response to disease outbreaks at Makerere University. Okay, thank you. So Makerere University is one of the oldest universities on the continent and recently celebrated 100 years of existence. And through Makerere University, there's been set up of different organizations to support its agenda. So under the different organizations that have been set up, there is a global health security program, which has a focus of strengthening health systems in Africa to prevent, detect, and respond to infectious diseases, with a scope on lab biosafety, epidemiology, informatics, IPC, case management, and medical countermeasures. So through that program, the focus is mainly around preventing avoidable epidemics, detecting public health emergencies, and responding in time to avoid spillover. Okay.
IT, can you help the presenter? The remote is not moving the slides. IT, thank you.
Yeah, so before the COVID-19 pandemic, Makerere University invested a lot into the global health security agenda. And what I'm going to share with you show the investment from Makerere University to ensure that there was some level of preparedness for COVID-19 in Uganda. So the first one was on policy and legislation. And here, Makerere University, working with its partners, facilitated the development and implementation of the National Action Plan for Health Security. And this included the National Action Plan for Health Security 2019 to 2023, and then the joint external evaluation, which assessed the capabilities of the country in preparedness. And there we have the Honorable Minister and the US Ambassador launching the NAPS at the key meeting in Uganda. The second was about the amendment of the Public Health Act. So Uganda had an act that was about 87 years old. And in that act, there was no good alignment to responding to public health emergencies. So working with the Ministry of Health, Ministry of Agriculture, Animal Industry and Fisheries, and other stakeholders that are in One Health, the Public Health Act was amended to align to COVID-19 response, which also will support the other aspects. We have also worked with Resolve to Save Lives, one of our other partners, to help set up a 717 matrix, which supports the timeliness framework for outbreak response that we used during the COVID outbreak, and we're also using with the many other outbreaks. And Uganda is the chair of that 717 Alliance. It's a bloody thing. Can I'm struggling with this. Can I have one that just works well? The next area that is on One Health was to also support government of Uganda develop a national action plan for AMR. And this proved very important because during the pandemic, there was a lot of misuse of antibiotics. And this plan, so this plan really helped to inform the rational use of antibiotics, surveillance of resistance in the regional referrals, and also setting up stewardship structures that can be reviewed and support the operations. Next. Here again, under biosafety and biosecurity, the government developed a national biorisk management curriculum And this program supported to train rapid responders to COVID-19. And also, next slide, please. No, the previous slide. Thank you. The training program that helped to equip a lot of healthcare workers with the skills to handle highly dangerous pathogens, and also working with the Uganda National Council of Science and Technology, developed the National Pathogen Inventory, which helps to map which pathogens are where in the country. Next. The other initiative was mainly on COVID-19 vaccine uptake among national prioritized groups and strengthening pharmacovigilance and data. And here, working with the US CDC, we supported a lot the government of Uganda to ensure there are mechanisms of how the vaccines get closer to the local populations, and also how there is targeted vaccination. And through this work, it has been expanded to look at the vaccine evaluation studies on the continent. And this is work that Makerere University is doing with the Africa CDC, with the coverage of over 15 African countries to evaluate the vaccine effectiveness, the impact of COVID on healthcare systems in Africa, develop a biorepository of COVID samples on the continent, and also support strengthening the National Institutes of Public Health. So this is work funded mainly through the MasterCard Foundation to the Africa CDC and working with partners on the continent, including Makerere University. The other aspect was on strengthening lab systems, and mainly this was in accreditation, supporting accreditation of the National Microbiology Reference Lab to support early detection. The lab became very integral in the detection during the outbreak, and the capacities supported even in Ebola and cholera and many other outbreaks. Next. The other initiatives have been around the rollout of the electronic integrated disease surveillance and response system to ensure that facilities can have early warning systems and also can have the ability to, in case they pick up any alert, they can be able to transmit it in form of a message to the core center, and the EOC can be able to deploy. Next. Here we have the launch of the Regional Public Health Emergency Operations Center in the West Nile. This is bordering the DRC Congo and South Sudan, and we have the Director General and the Minister launching this EOC, which was very pivotal during the outbreak. Here, it's the establishment of novel models for case management diagnostics. And this is a huge investment into regional referral that trains healthcare workers to be able to have the skill set to be deployed in different settings of outbreaks. They became very important during COVID-19, and having them deployed at the National COVID Treatment Center through the trainings that we had, but also to support the research. Again, there shows the work and the evaluation studies. Next. In addition, there was also strengthening emergency medical services, which supported a lot of evacuation, including triage kits, surge EMS teams, a call center that became very pivotal during the response. During also this, we worked with different stakeholders in One Health to develop Wash Alert, and these are mainly self-sustaining water systems in facilities that sometimes can be infused with chlorine, and healthcare workers can be able to access it for hand washing to reduce on transmission in facilities. So with that, I want to thank the partners we work with, the US CDC, MasterCard Foundation, Africa CDC, WHO, DAI, Fleming Fund, Mott McDonald, Resolve to Save Lives, Pfizer, that are exceptional partners that have really supported this work.
Thank you very much.
And thank you.
Give him a hand clap. You have actually saved time. Thank you for preparing such a precise presentation. Well done. And I think the message here is the government's involvement in capacity building to responding pandemic outbreaks. And we've seen real life examples and involvement of the community, involvement of stakeholders, and then professional bodies and organizations. Thank you very much for that presentation. I would now like to take this opportunity to welcome our next presenter, who is none other than Andrew, who will talk about lessons learned from the deployment of Type 2 Rapid Response Mobile Laboratory during the 22 Ebola Sudan disease outbreak. Yeah, you are most welcome. Alrighty, help us load that presentation.
Yes, thank you so much, Chair, and good morning, everyone. Once again, it's beyond an honor and pleasure for me to take us through the lessons that we learned from the deployment of a Type 2 Rapid Response Mobile Lab during the Ebola Sudan outbreak in Uganda. We all well know from the presentations that we've had yesterday that the WHO Afro region has registers the highest burden of infectious disease outbreaks. And to be specific, in 2018, Uganda registered the highest number of outbreaks on the continent. And obviously this is due to its geographical location in the Congo Basin epidemic hotspot or zone, the yellow fever belt that we spoke of yesterday, the meningitis and the filovirus triangle, plus also the encroachment to the habitats of these host reservoirs of the pathogens, having the highest refugee hosting capacity at 1.5 million, plus also the improved diagnostic capacity in Uganda that enables us to detect most of these outbreaks on time. Something key to note is that in the past 20 years, we've had over 30 filovirus outbreaks, and Sudan is one of them. Just as we shared yesterday, you cannot fight an enemy blindfolded. You need to know where they are hiding. Therefore, the most effective way for us to stop these outbreaks is by breaking the chain of transmission of the infection. And the laboratory is very crucial when it comes to breaking the chain of transmission, to know where those who are infected, and in fact, to break the chain of transmission, you're supposed to test and test and test, and then isolate those cases. One of the three attributes of a quality laboratory result is timeliness. And the deployment of a Type 2 Rapid Response Lab during the Ebola Sudan outbreak, the box-based mobile lab, just as you can see in the pictures, was one of the best practices because it assured timeliness of diagnosis, and also it assured cost effectiveness because we spared the resources that could have been used for movement of samples from the epicenter to the central testing laboratories. The deployment of this Type 2, the box-based mobile lab, the equipment in a box, that's why I'm calling box-based mobile lab, followed guidance that is stipulated in WHO guidance for use of rapid response mobile labs, and also the East African Community's Mobile Laboratory Network manuals. And this involved, firstly, from requesting for admission. Obviously, just as I stated yesterday, the Public Health Emergency Operations Center coordinates the laboratory outbreak response activities. So the request for the mission, the specifications of the assignment are given, and then we plan to deploy. Obviously, in the process of planning to deployment, there are some key activities, including field visits. If you can see the third bullet, comprehensive planning, I hinted on it, then mobilization of the resources, the technical personnel and consumables, and then now the field visits to the epicenter. The field visit to the epicenter to assess the suitability of the available working space of the Type 2 Rapid Response Lab. Maybe something very key to note is that with the Type 2 Rapid Response Lab, you are supposed to be given a allocated space or an infrastructure that will house the Rapid Response Lab. And thereafter, we did a risk assessment, process mapping, risk assessment of the available allocated space. We mapped up the process, then did infrastructure modification, mainly the plumbing, the electrical, the air conditioning works to ensure that we heighten the infrastructure capacity to be in position to hold these equipment. Thereafter, we transported the Type 2 Rapid Response Lab in the boxes. You can look at our boxes there, and then transported in the, we have 2 of those vehicles, and then we installed, did calibration of our equipment, did method and equipment verification, and then did some review and update of critical data and by risk management protocols and documents, because it was our first time to respond to such a high consequence agent using the Type 2 Rapid Response Lab, and did orientation of the personnel on key protocols, quality, biosafety, data, and etc. Then a dry run, and then commissioned, operated the Rapid Response Lab, and decommissioned at the end of our tour. Key to note is that we spent 3 days to set up this Mubende Rapid Response Lab, following the infrastructure modifications that I hinted on. And in the 7 months within which it operated, we tested 3,282 samples and confirmed a total of 73 out of the 142 nationally confirmed Sudan cases nationally. Maybe something key to note was the turnaround time, is that from the time of receipt of the sample to results, it was, we had the lowest time as 4 hours and the highest 6, and the median turnaround time was 6 hours from the time when we received these samples in the lab. Yes, also we are able to establish a basic quality management system to assure quality, and participated in WHO proficiency testing scheme, 2 rounds with 100% satisfactory score. And also something very key to note is that no laboratory personnel contracted Ebola Sudan. And also we didn't have any biosecurity incident, including loss, unauthorized access, theft, or misuse of the samples. We had quite a number of challenges. Kindly help me. Previous slide. A number of challenges, including delayed and costly deployment of the Rapid Response Lab due to the infrastructure modifications. Just as I emphasized, we had to do infrastructure modifications before we set up the Rapid Response Lab. So we delayed to set up 3 days, and also the infrastructure modifications. Also, these modifications that we do from allocated space to the other, the gains are short-lived because later the infrastructure that we modify is demolished. Also, we had some biosecurity concerns due to lack of burglar proof of the windows for the space that we allocated in Mubende, plus also no CCTV cameras. There was also a challenge of maintenance of a constant supply of consumables for testing, quality management systems, and also infection prevention and control. In my conclusion, the deployment of this Rapid Response Lab during the Ebola response of 2022 significantly reduced the turnaround time to an average of 6 hours, and this aided case detection, confirmation, isolation, which are very crucial when it comes to stopping or controlling an outbreak, and also prognosis of patients. Also, something key to note is that interpillar partner coordination, collaboration, and communication. These were very key for us to mobilize resources. And we think that if we address the challenges that I've hinted on the previous slide, it will enable us to enhance the efficiency and effectiveness of the rapid response labs in the future outbreaks. Thank you so much for listening to me.
You're most welcome. Thank you. Thank you. Again, another stunning presentation demonstrating the capacity that the country has built in response to Ebola outbreaks. And I think these are the lessons that we'd like to share with the rest of the world, and more so going beyond this. If we're able to diagnose this with an average of 6 hours, we are now saying, are there better diagnostic criteria and methods? And we need to look at the science behind that. Thank you very much, Andrew, for that good presentation. I would like at this juncture to invite my co-moderator to invite our Russian counterpart to present.
Vasily Kuklev, with the leading sciences in Russian Anti-Plaque Institute Microbe. He has very extensive experience in working with mobile labs during the Ebola outbreaks and other use of mobile anti-epidemic labs and in other circumstances, including Lebanon and other countries. He also was a part of the team which, together with WHO, developed, based on the Russian experience, WHO guidance on rapid response mobile labs, which Andrew just mentioned in his presentation. So I want to, it's proud for Rospotrebnadzor, this Vasily Kuklev and his colleagues was a part of the team who developed this and first ever classification of mobile labs. So I would like to give the floor to Vasily Kuklev, who will present the Russian experience and use of rapid response teams. Thank you.
During yesterday's sessions, there had been spoken a lot about Russian rapid response teams. And today and now I would like to speak a bit more, to elaborate more on this topic. And I will continue in Russian.
The rapid response teams, which are part of Rospotrebnadzor, which is the federal agency in charge of surveillance. These rapid response teams have a long history, as a matter of fact, and we're going to be speaking about that. I want to take out a few key moments of which we'll be talking about, and the first one is the mobility. It's one of the main principles of our mobile response teams. And they were created to be able to eradicate, to overcome health emergency in both the Russian Federation and even outside the Russian Federation. And one of the key elements of the global system of response, it is a response to biological threats in Russia. As I already said, we have a long and big history from the very beginning of the 20th century, where the first type of such teams was created. They have been changing, they have been transforming, getting new technologies integrated, and up to now where we have a modern example of these rapid response teams. And right now they have particular tasks that are concrete, and we have even moved to broader spectrums of tasks and multifunctionality in their work. The main sphere of activity for these rapid response teams includes localization and eradication of these outbreaks for infectious diseases. And the most important for us is actually the dangerous infectious diseases. Other activities involve laboratory diagnostics for the infectious diseases, the temporary personal strengthening of public health structures in those places and in the periods where it's necessary, especially during crisis. And of course, one of the main activities is also ensuring epidemiological welfare during mass gatherings with international participants. So our experience that we have accumulated over a long period of time which has been taken through particular structures and experience. And as you have already mentioned, in the 1960s of the previous years, it is where there was eradication of 160 outbreaks of highly dangerous infectious diseases. We also made sure to ensure epidemiological welfare in the territories where we experienced natural catastrophes. For example, in Armenia, in Lebanon, in the 2020, in the natural catastrophes in Libya. And of course, we also ensure epidemiological welfare in the zones of humanitarian catastrophes. And in that this was very important. And of course, most recently, we have also been ensuring epidemiological welfare in mass gatherings. It is important to understand that it was that Andrew gave a presentation before, and it was very nice of us to notice certain things that were similar. And so that shows an integration of both our responses and our understandings in the global understanding. And so we have guidelines that have been created by the World Health Organization, which were created in 2019. And these are guidelines on classification of rapid response mobile laboratories. And this was taken by the official administration of World Health Organization. And we are very happy to see that it's being applied even in these days. And of course, in this sphere, we continue to develop. For example, we have also created minimum standards for the rapid response mobile laboratories. And this is geared towards the areas of biological safety, logistics and support, quality management systems, and of course, laboratory information systems. So these minimum standards were tested, approved by international scientists. And it's important to also note that this was mostly done in the city of Kazan in Russia. And the position of the World Health Organization was favorable to us, and it was recognized. And we hope that it will be officially applied before the end of this year. So we want to speak a little bit about the system of classification for these rapid response teams according to the World Health Organization. So there are 5 types of these rapid response teams. Of course, from the minimum up to the maximum. And the Raspotrebnadzor has these mobile laboratories in particular formats, as you can see on the slide. And this comes from the type 1, which is a transport case where we have collections of equipment. And these are normally only used to improve and increase the biosafety in particular areas that they are deployed. The second type, as you already heard from one of the former presenters, this was also tried out in the Congolese Republic. And it is based on a pneumococcus or inflatable tent. And so with this mobile laboratory type 2, we're able to use different types of investigations and microbiological research, real-time PCR, and we are able to test bacterial and viral etiological agents. And this laboratory can be transported by any kind of transport. It can be enclosed in about 27 types of standard cases. And so for this type, there is no need for a particular specialized type of transport. The third type, which is also existing in history, it is a mobile laboratory of epidemic reconnaissance and detection. And so it is in the format of a microbus. It is totally mobile, and it can be able to move to any particular place that it, even in remote areas, it can be able to get there. And so from the period of 2006 up to this current date, we have been able to create about 3 generations of this type 3. And it also, as we already mentioned, works with real-time PCR tests, ELISA, rapid tests. And so it already, in its work, it already encompasses autonomous energy, ventilation, and the navigation systems together with the heating are also autonomous. And this type 3 laboratory is already being used by a number of other partner states in Middle East and even in other countries in further areas. The fourth type is a little bit bigger because it is based on a truck system, KAMAZ truck. And here there are very many opportunities for even improving of improving, especially when we talk about express diagnostics that can be carried out with this type. And now we talk about the most modern, or let's talk about the biggest that we have at this current moment. It is called the mobile complex. It is a model of laboratories which has maximum biological possibility. It can be able to work in different climatic conditions, in the hot and in the cold, and it is more modernized than the previous ones that we've talked about in terms of its technology, especially as pertains to screening. It can work with the satellites. And so these kinds of mobile complexes are right now in only 5 of institutes in Russia: Microbe, Stavropol Institute, Rostov, Volgograd Institute, and also Irkutsk. And so these also act as places for training people who will be working in these teams. And the documentation which regulates their standards and allows them and allows us to be able to carry out scientific research with these laboratories. Something important here to note is that these mobile laboratories have a very wide range of usage. And depending on the scale and the features of an emergency or a crisis, they work as big complexes. And this can be in the form of either personnel that are deployed, or even in the technical resources as the equipment. It can be a full scale, depending on the type of emergency that it's being responded to. I believe, like we all know, or we are all here, these rapid response teams have a particular use, and they did a lot of work during the COVID-19 pandemics in Russia. And this was, for example, in Moscow, in other regions. In other regions, these rapid response teams were able to cover the areas where the laboratories were not present. So I want to remind us about the main principles for the work of these rapid response teams. This is the mobility, autonomy, multi-profile nature, of course the technology that is used, being able to give the widest range of biological safety, being able to have combinations and modules towards a particular task, and of course the universal programs for training of personnel who work with these different laboratories. So apart from the work that these teams have been doing on the Russian Federation, there have been many missions that have been taken outside Russia. For example, the work in the epidemics in the Republic of Guinea, in the Ebola epidemic. We also had a mission to Lebanon, and we particularly got a lot of experience from this mission. We also had work during the COVID-19 catastrophe, and also you can see in the photographs down, in Congo we also worked on within the outbreak of acute intestinal infections. That was in 2023. So in the same way, the experience of these rapid response teams, we continue to develop and to even increase our possibilities together with our partner states. We continue to take education and training for different personnel. And we are continuing to register specialists from Russia and even from other countries that are ready to work in these mobile teams. And an important part, of course, is the practical training that we carry out. The practical training that we carry out in different countries, in particularly the Commonwealth of Independent States. And these include people from Asia, Europe, and other places. Thank you so much for your attention.
Tomorrow we will have extensive session devoted to mobile labs, and what Dr. Kuklev couldn't cover today, he will be able to explain tomorrow. We will also have information stand outside in the hall, outside this conference room, which explains also the capabilities of mobile labs. And also Dr. Kuklev didn't mention that this year we will organize another international field exercise with the use of mobile lab in Russia, in one of our cities on the river of Volga. So I think you all will get invitations to come and to see how it works and how it can be exploited. Thank you, Dr. Kuklev, again, and I will go back to my co-chair, Professor.
Thank you very much, co-moderator, for handling that session very well, and thank you very much, presenter, for that. I take this opportunity to invite our next presenter, none other than Paul Buyengo, but represented by another person who will introduce herself. The title of the talk is Feasibility of Virtual Reality-Based Training for Optimizing COVID-19 Case Handling in Uganda. You're most welcome.
Right, thank you very much. Good morning to you all. My name is Elizabeth Katwesije. I'm a physician. Currently, I work at the Ministry of Health, and I support infection prevention and control and case management. I'm going to be presenting the results of this pilot study that was done during the heat of COVID. It was carried out from 10th August, 27th November in 2020. It's not working. Next slide, please. As we are all aware, Uganda is one of those countries that is at the epicenter of disease outbreaks. We have frequent outbreaks in our setting. We've recently had an Ebola outbreak. We have ongoing viral hemorrhagic fever outbreaks, COVID-19 and others. And infection prevention and control practices are very key for the healthcare workers. We've had ongoing trainings, both classroom and facility-based, to always ensure that healthcare workers are up to date with the IPC practices and skills. But this does not come without challenges. This is a practical-based subject that requires someone to be able to have practical sessions, hands-on, repetitive, to be able to have that confidence to offer healthcare in case of an outbreak. And to be able to do these skills repeatedly would be expensive because you require PPE, but also there is the disadvantage of not being able to practice this in a real-life setting. For example, taking a tour through an Ebola treatment unit to understand how it's performing, would not be able to do this through a real-life setting in the outbreak because of the risk of infection. So this study was aimed at trying to see if we can utilize other safe ways to offer training of healthcare workers, and we utilized virtual reality technology to assess and train in IPC and try to assess if we're able to build skills utilizing this mode of training. Next slide. Virtual reality is the use of computer technology to create a simulated environment that is able to immerse the user to have a near-life experience of the circumstance and context. And we're able to have training scenarios simulated in this environment, which allow practice before getting into a real-life scenario. And it's engaging because the trainee is able to control this on their own, and you're able to do it at your own setting. Hence, issues of infection spread, like during COVID, when required social distancing, can really be ensured. So this pilot study, we looked at feasibility of utilizing virtual reality technology in IPC training and the methods that were used. The Ministry of Health already had approved COVID-19 IPC training materials that were transformed into a virtual reality curriculum, benchmarking on the traditional modes of training, which usually include a classroom didactic training to introduce participants to the key concepts, observations, and then practical hands-on. Next slide. So in the pre-pilot phase, we had a team of 10 multidisciplinary experts. These included physicians, medical officers, and IPC specialists from the Infectious Diseases Institute, various departments, who reviewed the materials as they are being transformed into the virtual reality platform to ensure that we do not change or misrepresent the previously existing curriculum. And we're able to get feedback from these 10 experts before rolling out to a larger group. We targeted to train 60 participants due to the availability of resources at that moment, including the space at the laboratory. And 55 participants were trained. These were frontline healthcare workers from Kampala and Wakiso facilities of various cadres, including laboratory experts, clinical officers, medical officers, nurses, and pharmacists. And we were able to train these in 10 cohorts, and each cohort had a maximum of 6 trainees because we had 6 VR headsets, but also the space and the social distancing required at that time. And each cohort was able to go through the 2 phases of the trainings that will be highlighted on the next slide. We had virtual reality experts who are available at all times to assist participants navigate the platform. We had planned to have 3 phases of the training. The initial phase was the introduction, which was on a platform called Enduvo, where we had sessions that would orient the participants on the theoretical COVID-19 aspects, things like modes of transmission, how the infection is spread, the infection prevention and control precautions in theory, and then there was a more practical engagement in a phase 2 where we are utilizing 360-degree videos, and these are videos that are more than the usual 2D videos in terms of assisting the participant to appreciate more in 3D, but also appreciate more in a real-life experience. At that time, we were not able to have interaction during the videos, but there were knowledge checks that were embedded in it. The phase 3, which was the last phase, was the virtual reality full immersion that had been planned to have participants utilize the VR platform, but be able to perform practical aspects like putting on and putting off PPE, washing hands and the like. But at the moment that was not performed because the equipment did not arrive in time, although this phase has also been developed, as we shall see in the subsequent slides. This is just a demonstration of the experience. In the middle there we see a participant with the headset and the equipment, highlighting the interaction with the platform and some of the screenshots that were taken in the different platforms. On the right there is practical for donning and doffing, but we are only able to demonstrate this on screen since we had not developed this skill at the moment. The course had different evaluations. We wanted to assess if there had been any knowledge acquisition, and there were multiple choice questions that were used to assess this for every topic in the different platforms. But we also had an online individual survey that was used by participants to evaluate how they felt about the course, utilizing the technology for learning, and their ability to utilize this platform, but also if they would recommend the course to a colleague. And the results, these were the participants, different genders and cadres, as has been highlighted. Next slide. This is a summary of the statistics scores. On the left, we have the scores after the assessment for the 54 individuals that concluded the training. And most of the participants scored more than 80% in the course questions. And on the right, we're just having a comparison with an untrained cohort, just to highlight that the blue bars are a pretest from a classroom training that had been done for IPC before, but comparing it with the assessment scores from the VR training to demonstrate that there was some knowledge gained. And the course evaluation, 97.7% of the trainees strongly agreed to refer this to a colleague, and over 90% agreed that this training was very good and that they were able to utilize the platform to gain knowledge and skills. The major motivation for this study really was to determine the feasibility of virtual reality to utilize as a training mode, which we had not done in our setting. And the key lessons identified from this, from the feedback of participants, is that being in the virtual reality environment eliminated external distractions. They were able to concentrate, and the platform was usable, and they preferred to have it extended to even other courses so that they are able to participate and interact with different scenarios at your own time, and be able to practice skills more often than if you're required to have it in a structured classroom, or you'd require equipment and other supplies, like if you're going to be taking off PPE and putting it on. Next slide. And most of the participants agreed about the learning means, but this was not without any challenges. Next slide. The biggest limitations, one was at the time we had inability to modify the content because the platform was just being developed and it was an externally hosted platform, so the back end was hard to access. But also the quality of the videos was poor, given we didn't have a soundproof room, but also enough space to record the videos. And then the project did not have some professional cadres like video producers to ensure that the videos are produced to the perfect notch. And we had delay in shipment of the required gadgets, so the phase 3, which was the full immersion, did not take place. The key recommendations from that study, one was in terms of scalability, to develop an internally owned platform that can be adopted to various needs of different topics or courses, to acquire a studio for proper recording of these scenarios, and to bring on board different experts to be able to record and produce better videos, but also to follow up and ensure that we have developed the skills for the VR immersion practical phase 3. In conclusion, the new virtual reality COVID-19 IPC course was feasible and was successfully conducted. And the research or innovation project was made possible with support from the government of Uganda through the Makere Research and Innovation Fund, and additional support, both technical, structural, and equipment, was provided by the NIH, the Infectious Disease Institute, and the Makere University. And since then, there's been developments to this platform. The team has worked on developing the platform to use in capacity building for viral hemorrhagic fever case management and basic life support. And some of the key features that have been developed is the 360 videos are now interactive, that we're able to have checks in the system. For example, if you're doing a procedure and there's a requirement before that, there is a check that will come and you're not able to progress. So that at the end of the day, if you pass through the whole phase, you've been able to go through the required steps, and you can always go back and forth as required. And now there is also local capacity available to develop the virtual reality immersion phase.
You have 2 minutes to go. Thank you.
Thank you. This is just a highlight of the viral hemorrhagic fever training. Videos have been made from one of the standard treatment units that was put up in the last Ebola outbreak. And the structures there may be temporary, but if we have these videos shot, we are able to have this material available for the healthcare workers to utilize at their own time, but also continuously. And if there is any change in the setup, as may be required as new evidence comes up, we are able to change that in the setting so that we may not have to get every healthcare worker to come and visit the treatment unit to appreciate how it's set, patient flow, and healthcare worker flow. And then finally, this is just a demonstration of the basic life support training, which is also based on skills that require repetition, and 360-degree videos have also been shot and available for this. I've also come along with some of the virtual reality tech experts that are around, and some gadgets are around for demonstration if needed. Thank you very much.
Well done. Thank you for ably delivering on this topic, and we've learned a lot, particularly the alternative way of building capacity. I would like to hand over to my co-facilitator to introduce the next presenter.
Thank you, Professor. I would like to introduce Dr. Naidionova, Ekaterina from Scientific Research Institute Microbe, Anti-Plague Institute Microbe in Russia. she also will deliver presentation on training of specialists, which is, sorry. Another presentation, please, because it's another title. But while you're looking for the presentation, so Ekaterina has extensive experience in working in Africa, especially in Guinea, and joined Russia-Guinea Scientific Research Center in Kindi. So I think more than for 7 years already, maybe 8. And no, it's not again.
Not that presentation, that will come after her.
Okay, you can. Вы можете начинать? Yes, please start. So, and if we'll be finding the presentation, which entitled, I think, about training and biosecurity training. Yes, how? Как называется презентация?
Подготовка.
Okay. Training of specialists in biological safety and rapid response to emergency situations. Forgive me for this technical hiccup. We have already listened to many different speakers about the experiences of different countries in the combating of the causes of these particularly dangerous infectious diseases. And of course, we've talked about the diagnostic equipment and also the scientific approaches. But I would like to say that that behind all of this, we see normal people that are there. And so the main goal that we have is not to allow infection to move to particularly dangerous infectious diseases to move out of the laboratories. And so we have to always be ready towards this question of biological safety and also operative response towards such emergency situations. We already listened to the presentation about the history of the anti-plague institute in Russia. And it is this institute that continues to do research on these particularly dangerous infectious agents. And this institute already has about 126 years of history. So this history really starts from the Russian Empire. It moves towards the Soviet Union time, and even now in modern times, this institute is getting bigger and bigger and increasing in the number of research works that it does. And so one of the main parts that develop during this development is the training of specialists. So it is important to note that over 126 years, we continue to train specialists who can work in areas with dangerous infectious diseases, and specialists who have practical experience and skills. So what does this training include? So it includes the training of microbiological substances, for example, in anthrax, cholera, intestinal infections, and of course, it also involves the practical experience in carrying out the laboratory works. In the modern times and the modern approach, we also continue in this direction, and our work involves traditional methods of already considering the experience that has been gathered over these 126 years. And so the first thing that I want to speak about is the using of conventional principles during the time of training. We receive specialists that have been properly trained to be able to combat any diseases in the areas where it is necessary. So what are the objectives of the training in the modern times? The first is to be able to develop unified training programs for the conducting of different research and with the pathogens in these infectious diseases. We are also able to create mechanisms to reduce the risks of infection in the laboratories for our trainees. And a big part of our work also involves the hands-on approach, the practical work. We also do improving of methods for assessing the level of knowledge, skills, and practical abilities. And even right now, we are going ahead to involve the state-of-the-art information technologies. And this is able to help the teachers and the students and the employees to test their level of knowledge and understanding. And of course, this is together with the modern informational technologies. These are methods of bioinformatics, and these are all parts of our training. What are the principles for the building of these practical skills in the modern world now? So this only happens during full-time training with daily training for our trainees. And so this training is undertaken by very highly specialized experts. And the instructors usually take up about small groups for about 2 to 3 people or even one person. So this mastering of the work takes place in 3 stages. The first one is the working with non-infectious material processes. And so it involves the fluids, culture, media, and also from animals. And it is on this stage that we work. So it is at this stage that we're able to get a more tactical understanding of how the pathogens are spread. And the second step is working with opportunistic microorganisms. And it is on this stage that we are now actually working with infectious microorganisms on this second stage. And of course, the last step, which is the final step, is now the working with dangerous pathogens. It can work with vaccines, with etiological agents. And why is this useful? This is useful so that we can be able to harness maximal reduction of the risk for our trainees. So in our institute, we have 5 training sets of methodical approaches towards training. So the hands-on approach is done at the institutes, and all these institutes have a license and authorization to work with pathogens and dangerous infectious agents. They also have equipment for training and working with the trainees in the diagnostic laboratories. And so they also have proper supply of all the equipment that is necessary for the training, and this training of specialists is with expertise in the full range of the laboratory territories. During these trainings, we also have workshops and solving of different situational tasks where they have to solve the tasks in order to simulate real epidemic events. And this always depends on what task has been prepared with them. And so the involvement of the training of the specialists who have experience in research is so that they can ensure that maximum knowledge is passed on to the trainees. And this is in the fields of immunology and genetics. And so, of course, there's also this step, or the stage, I can call it, of distance learning technologies that we are also including in our training. This includes electronic educational aids. It has almost more than 100 video lectures, more than 60 educational video files. We are also able to include 2D and 3D educational materials. And we also have electronic testing materials, which is able to test the level of knowledge for the trainees. And of course, this knowledge and training is also in other countries and also exists here in the Republic of Uganda. So there's a stage that we also have that involves the operational procedures. And this is now particularly speaking about specific work, which we do for the staff of the mobile laboratories. And so the education here is done by people that have already gone through the courses or the education with the mobile laboratories. And so those that work in the mobile laboratories are the ones that carry out the training for others. And this is in the field of engineering, laboratory diagnostics, and this is particularly on the different developed programs. This has been going on for about 5 years already. And we have been able to register universality of our specialists in different fields, for example, disinfection, engineering, and autoclave operators. And this is also done as annual exercises for our rapid response teams, as has already been spoken by one of the previous speakers. Thank you so much for your attention. Merci.
I'll give floor to my co-chair, Professor.
Thank you very much, co-chair, for leading us through that, and thank you very much, presenter. That was good. In the next presentation, it's actually mine, and the two of us are going to share this presentation. IT, please. So, I'm going to make a proposal for a model that will take us forward. And it will have 3 components. There'll be a component for funding, a component for research, and a component for emergency response. IT, please. That presentation was already there. So I'll be making proposals, and then my co-chair will be making responses. Yesterday I did introduce myself. Next slide, please. Yes, just run through so that we finish that. I did introduce, but for those who are not here, I did introduce myself as a medical doctor who is a professor in clinical and infectious disease epidemiology. I work with both Busitama University and Bali Clinical Research Institute, represented by those 2 pictures. And my efforts are mainly training, research, capacity building, and knowledge translation. So the scope of this presentation, like I'd already started, we shall go through introduction and then talk about the pillars of this model, and then propose a funding model going forward, and then the research model, and then emergency response model. Then we shall learn from some of the successful stories or success stories and lessons that we have already derived, and then the direction for this model, and then we shall conclude. So by way of introduction, there are basically 3 things that I try to summarize. That disease outbreaks pose a significant threat to public health and global security. And over the last 1 day, we've been able to demonstrate that. And also from our background to recognize in our own countries and ministries of health that this is indeed a problem. But we also recognize that effective research and emergency response are critical to mitigating the impact of these outbreaks. So we have 2 parts already there. That one, we need effective research, and then we need that hand in hand with emergency response in order to control or mitigate the impact of these outbreaks. The third one is that this model now aims to enhance collaboration and funding opportunities in research and emergency response. And why we are particularly talking about the enhancement is because in each of our settings, we have some response of some sort, but would like to make sure that these are enhanced or we strengthen the capacity. This conference today is a milestone, and is built on the summit, the Russia-African summit that took place in July last year in Moscow. And there is a picture of 2 visionaries, the President of Uganda, His Excellency President Museveni, and the President of Russia, His Excellency Putin. And based on that vision, we are now able to say, okay, we are holding this conference, but the model should have at least 3 pillars. The first pillar that I have proposed is that this is a collaboration. So it is not directed from one end, but it's a collaboration. And we had this yesterday clarified. The second one is that we aim to strengthen research capabilities, surveillance systems, and emergency response in Africa. And we are doing this collaboratively, learning lessons from Russia and lessons that are already here in this room that have been presented. And that this model emphasizes partnership. As you can see, the two leaders representing Russia and Africa are talking about partnership, knowledge sharing, and resource mobilization. I should say this type of partnership has no politics in it. We are just scientists doing good things for our communities and our people. So we have a funding model, and in this model, we have a few things that we'd like to respond to. Okay. That one, how are we going to talk about funding? The first aspect is that we'd like to look at government grants. So the grants from Russia and the grants from each of our African countries should come to a pool, and then we resource that pool for research, emergency response, and capacity building. The other one are research grants. We would like our counterparts in Russia to be able to share with us the available research grants that we can participate in, particularly to advance knowledge in a collaborative way. Then we are talking about the role of international organizations, including Africa CDC, the WHO, and others, that will be able to put in money to this initiative to stimulate the activities that we are talking about in this conference and also in the resolutions that we have. The research model that we are talking about has already been alluded to, but just to summarize it, we are talking about epidemiological studies that will be able to describe the distribution and the determinants of disease, as has been shared in this conference. But we are also going to talk about vaccine development. One of those I did mention yesterday, that this idea of responding by building a vaccine factory or enabling research when we have an epidemic is already too late. We should be able now to profile the antigens and the antibodies of the common infections in Africa so that we start working towards those vaccines ahead of time. And the coming of this idea of having a facility in Africa for vaccine development is very timely. Then the other one are diagnostic tools. At the moment, when there is an outbreak, we pick a sample and quickly rush to South Africa or CDC Atlanta. I already condemned this yesterday that in this era, this should stop. And we should now be able to talk about development of the relevant diagnostic tools that should help us to respond to outbreaks in our settings. The other one are therapeutics. We need to be able to develop therapeutics. And these are from synthetic materials or synthetic chemicals, but also from extraction of natural therapies. Because there are those that are not yet explored or exploited. And we need research to get into this area so that we are able to identify therapeutics that will help populations at risk. In terms of collaboration, we think that this collaboration should maintain the momentum of the government involvement, ministries of health, the academia and research institutions in Africa and Russia, so as to maintain the collaboration the way we would like it to move on. Just on your left, on your right, there is what we try to do, trying to map the outbreak of black water fever right up to the community level. And here we used geographical position system to be able to demonstrate where the most cases were so as to inform targeted intervention. In terms of emergency response model, I am proposing that yes, we build on joint capacity building of rapid response teams. We have a lot of experience coming in from Russia that we need now to infuse and do knowledge translation and capacity building in Africa. We need to be able to share the available resources, but if that is not possible, we need to build a facility which coordinates the essential medical and laboratory supplies, so that where there is an outbreak, we should be able to reach out to such a facility and say, we need these supplies in order to respond to an outbreak in any corner of Africa. We need to strengthen the laboratory infrastructure. At the moment, we are talking about the mobile labs. As you can see, our Minister of Health, who launched that mobile lab. But we need to see how effective these are. And for the one that has been donated to Uganda government, I would like to propose an merger of the academia, Ministry of Health and the government so that we see how all of these are working together, first to inform the evidence, but also to make the very effective use of this ambulance, these mobile laboratories. The other one is communication and coordination efforts. We would like now to tap into those countries that have already gone ahead with the Russia-Africa initiative, so that now we coordinate with those and see if we can learn more lessons from them and also replicate such success stories where they are not. In terms of success stories, this conference alone is a success story. That an idea was achieved or conceived in Russia in July last year, and now we are here having one success story on its second day, moving to the third day. But this should not stop here. I am proposing that we either make this annual or we make it a one event after every 2 years, so that we come together in a room like this and be able to share resources, lessons, and research. The second one is what I've already alluded to, is laboratory infrastructure for surveillance and mobilization of communities for response to emerging and re-emerging infectious disease outbreaks. We already have a successful story of mobile laboratories in Western Africa. We have one being launched during this conference here in Uganda. We would like to see more of this go even to places that do not have this, but more importantly, to link the three arms into this mobile laboratory capacity. That's the academia, the ministries of health and government, so that now we are able to have evidence from academia informing the laboratory performance and the government trying to push this into implementation. The other one is benchmarking. I did benchmarking on European and Sub-Saharan African model of funding, and I noted that there is a lot of limitations. One of those that we would like to condemn in this is where the European leaders lead in research on African conditions. My proposal is it should be joint, and not only joint, but should give opportunity to African scientists leading in finding solutions to African problems. In the direction of this model, there are 6 points that I'm proposing. One, strengthening of research and capacity building initiatives, and this has already been demonstrated, and we welcome what Russia has done to African African countries. Two, integration of digital technologies for enhanced surveillance and data management. This is when we shall be able to enhance the 717 approach in response to epidemics. Then we are talking about collaboration with other regions and stakeholders to broaden impact. I'm already making a call that for where these success stories have been in West Africa, they should now coordinate with East and Southern Africa to make sure that this collaboration from other regions informs the way we are delivering this collaboration in the regions that are starting. Then establish the Africa-Russia Secretariat. Now that we have hosted a successful conference in Uganda, I'm proposing that let the Secretariat for Africa be in Kampala in Uganda. And this is not for selfish reasons. It is just that we need to initiate a coordination mechanism to take these efforts forward. And then number 5, I'm talking about establishment of initial capital fund, which should be declared and made available to all African scientists, governments, and response teams. And then finally, we need to jointly develop collaborative research projects that should enable us move this initiative forward. In conclusion, I have proposed a model. And it's a model based on enhanced collaboration, capacity building, research innovation, rapid response, infrastructural development, sustainable solutions, regional impact, global health security, empowerment and equity, and continued collaboration. Mr. Chairman, sir, I'll stop here and invite you to make responses to these proposals. Thank you very much.
Thank you, Professor. Co-chair, Professor. First of all, thank you for this systematic overview and very constructive and systemic proposals for future collaboration. If I may, to react to your proposals, which are, I think, very extensive and very looking forward from where we are now. So, if I may, I'll continue in Russian to make sure.
So, what concerns concerning the new scientific potential against against epidemics, any country, in any region, and in the country. So the support towards this cause is just. And it is a very key moment when we talk about biological independence and biological safety. Of course, it also involves biological research and response towards epidemics planning and our response to outbreaks. So here we totally support that kind of undertaking. We support it from the Russian side. So it's not only about giving opportunities and also operative, but also creating an atmosphere for partnership between us. So of course the resources to Africa are unlimited, and we want to be able to offer internal help to the countries and also in the field of research. And we believe that this will lead to good consequences, but because sometimes it happens that the person that funds the opportunity is the one that determines the priorities. But we want to create opportunities that are important for even our fellow African countries. And even in the future, we want to be able to create opportunities not only for ourselves, but even outside our borders. And so this approach of priority, setting right priorities needs to be looked upon, and to define the most important, and to define the most useful approach. So what's important for the research? We need infrastructure, like we already said. We need personnel who will be doing this. And all these parts of the project are important. And the Russian Federation as itself has been a pioneer in this combating of infectious diseases. And this was also discussed in the Russia-Africa Summit in 2023. And also the priorities are geared towards that same effort. You talked about a fund. So this proposal needs to be also taken into consideration from the perspective of our finances, or our financing institutes. They are the ones that fund and finance our activities in the work that we work together, even with Africa. But I want to state that the fund is actually a forum of funding. But all the same, as I already said, we are going to discuss this point further, because I know that it's a long process when we talk about this funding process. It could take 1 to 3 years. And we agree on the amounts of funding. We agree on how it will be allocated. And all this takes some time. So we're going to already begin on this process, even right from today. And we want to start with the program that we have already been discussing about, and look at the possibilities here in Kampala the possibilities that the institutes in Russia can also participate in, and also the possibilities that we are ready to be able to support together and work together on. You particularly talked about the mechanisms of emergency responses. That is very important, and it also is one of the key moments of our cooperation in outbreaks. We talk about mobile laboratories, we talk about the teams of anti-epidemic response. Of course, we've said that there's already some experience in African countries, and we are ready to support these experiences, not only on the territory of African countries, but also in Russia. And this will be also in the transfer of mobile laboratory technologies, but also to create some kind of an ecosystem of a sort, so that we can be able to give help to particular countries depending on the logistics. And I believe that this direction or this endeavor has a lot of perspective in the future, especially when you look at the fact that we'll be moving together and working together in this area, together with also the leadership of our two different countries. And I believe that we can actually create a roadmap for us, so that we can create support systems to see how this all can work together, and to even start training in the Russian Federation, and to also be able to do training in the African countries on this point. And I think this is very important. I also support the proposal to have these conferences on a regular basis. We want to also confirm that that such events are very, very important, and especially when you're looking at the future of our future cooperation. Let's say about one time in 2 years, or 2 times in 2 years, we can always have such a conference or a forum on the African continent, and it's our position that it has to be here. So I want to come back now to the point of mobile laboratories that we talked about also in research. The mobile laboratories that we are presenting for response to outbreaks, they are going to be very crucial for monitoring, for immunologic research in particular regions of our partner states, to be able to do monitoring of natural catastrophes, and also biological status of the populations in these countries, and also to be able to take different kinds of research. So it's multifunctional. It's a multifunctional instrument, the mobile laboratory. And also I want to talk about another endeavor, 6 points. The 6 points that you laid out is also a very important part that you laid out. So we're definitely going to study each and every one of them, and they can become a basis or a foundation for the planning of our future programs. Let's also come back to the proposal about the secretariat in Africa. Of course, this is a very good proposal about how it will be created. Not necessarily about where it will be, whether in Kampala or somewhere else, but this also needs to be decided upon by the countries of Africa, and for us, we'll be working with the proposals that you'll give us, and of course this will need a regular so it will need regular interaction between us. So thank you so much, and I believe that our future discussions will be fruitful, and I'm also grateful for the way that I've seen how you are prepared towards all this work. Thank you so much.
Very much for responding to this proposal. Overall, I can summarize that there is nothing that has been rejected from the proposal. The second thing about the Secretariat that has been welcomed, it now depends on the African countries to agree or disagree with the proposal that has been put. And those of us who are here, maybe you'll have to go to the scientific committee and kindly let us know your feelings about this so that we move on with this. With this, I would like to thank my counterpart for making responses that have been positive. Thank you very much. This particular session did not have a question and answer, but feel free to contact any of the presenters who will be able to answer your questions during the tea break that we are going to have straight away. As we conclude on this session, I would like to let Professor Mwaka know on the Uganda or on the African side, you are the next chair. So I'm handing over this to you. And so you have the responsibility to mobilize people to come back here soon after the health break. As we mentioned that, I'm also letting the Deputy Director of St. Petersburg Research Institute, none other than Valdar Me, that you'll be the chair for that session. As we close, I would like now to welcome you to a tea break or a health break, which will now last 15 minutes. 15 minutes start now, and I close this session. Thank you very much.
So back in the room at 10:30. Yes, we are back in the room at 10:30 for the next session. So, please.
Dear colleagues, we have some few changes in the program. And so we're going to have two presentations. So we're going to have two more sessions that will be listened to before the panel discussion today. They were supposed to be after the panel discussion, but they'll be before the panel discussion.
Okay, I think we shall now have to get started. Myself and my co-chair, the Russian counterpart, shall be leading this and guiding the process of the discussion. We will do a little bit of shifting over a few things. For example, the panel discussion we shall take towards the end of this particular session. And so the presentations will remain in their order, except that we shall move the panel discussion towards the end. And so again, Amos Deogracius Mwaka is my name, a professor of medicine, Gulu University. And my colleague will introduce himself.
Let me introduce myself. My name is Vladimir Ditkov. I'm Deputy Director for Research in St. Petersburg Pasteur Institute. Thanks.
Thank you very much, ladies and gentlemen. We know there are infectious diseases that existed and they disappeared. There are those that have persisted. There are those who were and re-emerging. And then there are new infectious diseases that we are experiencing. We are discussing the new and the re-emerging. And our first presenter is Alexandra. Alexandra, you are welcome. You have 20 minutes.
Greetings to you, dear colleagues. Allow me to share with you the organization of anti-plague measures in the Russian Federation. The presentation, please. I would like to begin with the definition. So, sanitary epidemiological survey has been taken a long route from the very beginning, from its origins up to its application into the modern systems. And so in the 2005, there were two understandings that were differentiated, and that is epidemiological surveillance, which is the prophylaxis against epidemics, and it was put in a different category, and epidemiologic country control was also done differently. So our understanding is one and the same, but the epidemiological surveillance is a system of constant dynamic and multidimensional monitoring of epidemic processes on a particular territory. And this is in a certain period of time in order to bring about prophylaxis against emergency and outbreaks. So in different countries, there are different approaches to epidemiologic surveillance. So it can be proactive or even passive epidemiological surveillance. Let's talk about passive. We understand that it is just registration of cases of infectious diseases. And so we are able to see the the cases of infection of a person. But when you talk about the active, it talks about all the possibilities of infection. So we talk about epidemiological surveillance, microbiological, immunological, genetic, and other types of monitoring for surveillance. And this also involves the collection of data and materials on the same topics of epidemiological and microbiological surveillance and monitoring, and also the receiving of results and the prognosis of these particular infectious diseases. So it's on the basis of these results that we're able to create preventive measures against infectious diseases. And of course, the mobilization of resources and the continuation of active monitoring and surveillance is also being done from the Russian Federation. So the sanitary and epidemiological supervision in the Russian Federation is carried out by Rospotrebnadzor in Russia, and it has very many centers for carrying out this work in the Russian Federation. And these include centers for monitoring. It's able to have different sanitary institutions. We also have scientific organizations, anti-plague institutions, and hygiene and epidemiological centers that are constituent in territories of the Russian Federation. And we also, all these centers are on the basis of the scientific understanding of infectious diseases. And of course, we also have different other analogs of these systems in the Russian Federation. Some of the tasks of this is prophylaxis. That is the main task, prophylaxis against the infectious outbreaks. So the organization structure. So all the institutions that are involved in this epidemiological surveillance are at different levels in our country. So it's important to note that there are cycles of epidemiological surveillance, and each step is seen in these different institutions. And as you can see, there are different levels depending on the abilities and the possibilities. And this is seen in about 22 institutions of Rospotrebnadzor. And we also have 55 reference centers in the Russian Federations. And each of them has particular functions that it carries out, for example, monitoring and surveillance in our country. It's important to talk about the fact that this epidemiological surveillance in Russia depends on the type of the threat that is being faced in the territory. So sometimes it could be natural foci of infectious diseases, so that we try to reduce the risk of infection for these epidemics. And so it also depends on the infectious morbidity among the population. And a very important group it is the new types of infections. It can be either new infections for a particular territory, or it can be re-emerging infections for a particular territory. And so epidemiological surveillance is very important in such settings also. As we speak now, we have a very wide network of surveillance. And of course, the main task for all of this is to be able to prevent the spread beyond the borders of particular infections. We also have a very wide set of genomics that plays a part in the surveillance. And this helps us to be able to do early detection of causative agents. When we speak about plague, in the Russian Federation, plague has always been a particular infectious disease that presents a threat to our welfare. And so in the beginning of the previous century, we had very many outbreaks of plague. But with the invention and integration of anti-epidemic measures, we are able to have sanitary epidemiologic welfare that is increasing in the country of Russia. And so, but this disease of plague still remains an actual problem even in Russia. And we sometimes also have about 11 We sometimes have up to 11 natural plague foci in our country, in about 14 territories of Russian Federation. And so there's also what we term 5 transboundary plague foci that also exist in the countries nearby Russia. And as I already said, the task of monitoring and prophylaxis is one of the main things that we have as in our institutes, anti-epidemic institutes. So, for example, we have the Anti-Epidemic Institute. We have different institutes that are actually involved. For example, 5 of them. And within them, we also have plug stations that are in them, 12 anti-plug stations. And this is a combination of science and practice and practical knowledge that allows us to form a basis for prophylaxis against plague with a scientific foundation. So it's very important to also note that in the previous year, this system of anti-plague control measures was able to get to a particular milestone thanks to all the accumulated knowledge over the previous years against the plague infection. When we talk about epidemiological surveillance of plague in Russia, we have a particular unique system of monitoring the outbreaks, and this is organized especially around the natural catastrophes. So among these surveillance systems, we have epidemiologic surveillance and also episotological surveys. So in epidemiologic surveilling, we are able to assess the foci of these outbreaks, but when we talk about we also talk about the population that is affected when we talk about this epidemiological surveillance. And it's on the basis of this monitoring that we are able to do prognosis for the different infectious diseases in the future years. And we are able to also go ahead and plan appropriately for the possible outbreaks that might come. And this is always carried out, as I've said, in the foci, where we have sources of these infections. And we are able to have also rehabilitation in the territory programs of rehabilitation in those natural foci. These are some of the preventive measures that we have. And this gives us a very good score on our permanent preparedness to be able to train healthcare personnel to be able to be ready to be deployed in these areas against plague infections. And of course, as you may know, this is quite a very big work, but it's all geared towards reducing the infection rate. So when we look at the aim of effectiveness of this surveillance, we try to use modern equipment. When we talk about the process of the monitoring itself, we actively employ the use of mobile laboratories, which have been widely used in the system of Rospotrebnadzor. So these mobile laboratories allow us to have autonomous work in any geographic location, in any location, and it is on this basis that they allow us to have a bigger range and a bigger scope for laboratory diagnostics in with the use of different methods also. Another place whereby we use this new technology, it's in the storage and analysis of data. Right now there's a big work that is being carried out by our organization, especially natural foci of epidemic outbreaks. So when we look at the past, they used to use papers and rudimentary ways of collecting data. But right now we're able to collect more information in epidemiologic data. We're able to get better surveys, and the results of genomic studies are also able to be carried out, and this has been a great help and also a very necessary measure in analysis of data. We are also at this age improving our modern technologies in diagnosing these infectious diseases. And we want to now move into the direction of thematic diagnosis. And here we particularly use machine we use machine learning and also artificial intelligence to be able to get better and accurate results, and also to reduce the possibilities of negative results. We want to also speak about the sanitary epidemiologic welfare. It's important to talk about the cooperation that we have with other partner states. So without this cooperation, it's almost impossible to reach the milestone that we would have reached. And so we work with the neighboring countries, our different partners, and we've been working with them for some good time. As we speak right now, we have been able to get very good results from these cooperations. And the directions that we have, or the tasks that we have, it is to strengthen the material and technical base of our specialized institutions and to reduce the complications of plague infections. So the countries actively help us, our partner states actively help us, and we also help them with equipment, with data, and also with deployment of mobile laboratories. And so this international cooperation has been taking place from 2015 with our neighboring countries. We have been able to deploy more than 30 mobile laboratories. And another direction of our cooperation is in the area of strengthening the human resource capacity, and we've been able to create or to train more than 2,000 specialists. And of course, another one is to be able to have conducting expeditions to monitor the foci of different plague outbreaks in different countries. And we have had already 25 joint missions, expeditions, on monitoring the cases of plague. And it's important to note that between our countries or among the countries, we continue to actively also work on international documents that allow us to work even better and in a more systemized manner. So we also want to talk. So all that we have been able to achieve is partly due to our international cooperation. We want to also talk about the risks for plague, not only in the countries where there are natural foci, but also where it could spread in the world. We already know that every year we're aware that we have cases of plague at least once every year, and in the past year we were able to register more than 5,000 cases of plague. And of course, one of the most actual risks that we have and problems is the spread of this plague. So in Russia, we have been able to create epidemiological sanitary measures for awareness about plague. And as we speak, we actually have almost 45 plague foci that we took, 45 plague foci that we use for awareness. And also, we also have a system that is able to enable us to assess the risks of infection. And of course, in real life, we are able to get information from social media, from the internet, and from outside the country. And we are able to analyze this information, we are able to confirm this information, and this system that we have created itself autonomously is able to mark all it's able to mark categorize the risk areas using colors, as you can see there. And so we are able to analyze the data and to be able to carry out quarantine in particular areas, isolation where it's necessary. And so depending on the category, if it is yellow or red, we know that in red there will be a high risk of infection in that particular area, and the system itself already is able to propose systems of of control measures. For example, quarantine measures that would be very helpful in such areas. Of course, this improves the effectiveness of the response towards the outbreaks. And on top of that, we are able to improve our anti-epidemic control measures. And this makes the analysis much easier for us, both at a federal level and national level. And it's also important for us to look at the fact that the epidemiologic welfare in its entirety is not possible without international cooperation. And we want to work together with stakeholders, or we have been working with stakeholders, to improve this epidemiological surveillance against outbreaks. And of course, here at this moment, our partners are able to use the experience, the large experience that we've had in our combating these outbreaks, all the efforts that have been moved towards anti-epidemic measures in the context of international cooperation, the results, all our partner states can be able to use all this experience, the abilities, to be able to have better response towards threats against our biological safety. And I believe that this international cooperation will continue to the goodness of both our countries and also to epidemiological welfare. So thank you so much for your attention.
Dear colleagues, as we told, we have some changes in the presentation order, and now we ask Dr. Yalu Waningana, Minister of Public Health of Namibia, to take a floor, please, if you are here. Dr. Yalu, are you here? Ah. Это неудобно будет убедиться на фоне.
And then how do I move the slides? Okay. Good morning. I was actually not expected to present now, but yes, I will do presentation. My name is Iyalo Mwaninganga, as mentioned. I'm Deputy Director for Epidemiology Division, and I'm currently presenting this presentation on behalf of the response team for CCHF outbreak, which happened last year in May. So this is the presentation outline. And as you can see, that is the background about the CCHF. It's a family of the viral hemorrhagic fever. And it is well documented in all outbreaks globally that the case fatality can range from 9% and as high as 50%. And our historical background on CCHF, as far as in 2017, we had a couple of outbreaks, and you could see that in all of them, they involved adult males, and In addition to it, you could see that the case fatality sometimes ranges from 100, but in average, historically, from where the ministry has been responded in those past 6 years, it has been at around 50%. Can't see properly. Okay. So this is the objective of the presentation. We want actually to look into to characterize the outbreak by person, place, and time, and also to identify the drivers of CCHF and determine the drivers for this transmission, and also design the targeted interventions. We would also want the response also aim to establish the prevalence of CCHF organism in the livestock, especially in the affected regions. So this is the setting, that is the map of Namibia. The case that was reported was in Omaheke, which is neighboring Botswana. And because we don't have isolation facilities appropriate for the viral hemorrhagic fevers, the one which is being repurposed is in Windhoek, in the capital city. So the case was transported to Windhoek, something that we are not proud of, and we are busy working on it. But just maybe for your information, this case, when was transported, the clinicians have not ruled out viral hemorrhagic fever. So they were still under assumption that it was something else. So that is the sequence of events. So on the 8th, it is documented that from 8th of May, the patient started with the symptoms. And then on 15th of May, the patient presented with severe form of bleeding and altered level of consciousness. And on 17th, the patient was referred. Actually, on the 15th, he came to the private dental clinic for the bleeding under the gums. Presented on the 17th, the patient was not feeling better, and the situation was getting much chronic. And then on the 17th, the patient was referred to Windhoek, at a private hospital, still not suspecting hemorrhagic fever, until the visiting specialist who was called on call was called in and realized that they are dealing with hemorrhagic fever. And immediately the patient was transferred to the state hospital where we are having isolation facilities. On the 18th, under the suspicion of CCHF, rapid response was activated. Contact tracing among the high-risk contacts was initiated. And unfortunately, on the 18th, before the patient passed on, the blood samples were taken. The patient passed away on the 18th. And by the 22nd, we received the confirmation because the sample was taken to South Africa. It's not moving? Okay. So, like I've said, after the confirmation, declaration of outbreak was done. And then identification and monitoring contacts has been ongoing. And in addition to it, the field assessment, looking at the origin of where the case came from, the field assessment at the farms of livestock was done by the veterinary services. From the 1st to the 14th of June, all contacts were discharged, and treatment of livestock was done in the affected regions. Declaration of end of outbreak was on the 19th. However, other follow-up activities followed, like the University of Namibia, in collaboration with partners, they did a zero prevalence, rapid zero prevalence survey to establish the prevalence of CCHF in the livestock. And then as a procedure for management of outbreaks, we had an after-action review. So those were the methods that were used during the outbreak, as they are lined up there. And then we are moving to in the results section. The case profile is an adult 47 male Caucasian. His occupation is involved in transporting the livestock. It's his livelihood. Like I have mentioned before, between 16 and 17, he presented to the dental clinic with bleeding under the gums, and later on the day afterwards started presenting with other severe signs that are suggestive of hemorrhagic fever. In terms of the surveillance and laboratory, we have to deal now with two regions. The origin of where the case came from, and then where the case was transferred. And the unfortunate situation was that the CCHF was not ruled out at the point of diagnosis in the private health facilities. As a result, because of that situation, we accumulated a lot of contacts, and it's one of the lessons learned if we are to deal with a hemorrhagic fever. If everything goes wrong upon detection, and detection or confirmation of diagnosis is delayed, the more contacts are you likely to accumulate, and becomes costly and expensive and time consuming. So for Hobabus, which is in the Maheke region, we actually call this place as cattle town, because the economy is driven and livelihood is driven by cattle farming. So in Hobabus, as you could see, we have accumulated close to 21 contacts. And in Windhoek, where the patient was transferred from one facility to another, here we are talking of the ambulance drivers, paramedics, the casualty staff. So everyone who was involved without knowing that it was a CCHF. So that was the total number of contacts. There were 56. And then because of strict monitoring, any sign, if the patient is not feeling okay or spike in fever, this patient will be automatically isolated and presumed a CCHF case. So we had 4 of those ones. Luckily, none of them, after testing, the test came negative. Okay, this is what I've mentioned. So in terms of the seroprevalence, we were supported by our partners and University of Namibia to do what they call an ELISA form of multiplex test. It's a rapid test. It's not used for diagnostic, but it's more for screening, but it was at least able to identify and, for us to establish the magnitude of the problem in terms of the CCHF vector, CCHF hosts. So this is the test that was done. And as you could see from the results, it was we were not surprised, but even though we were not expecting such high positivity rate in cattle, in the sheep, and also positivity rate, you could see the map there is indicating where the farms were sampled. Actually, the farms were not sampled. We just look at where the case came from, where the case has been transporting cattle, and then all those farms were included in the study. And those are the result, and you could see that there is a high prevalence of the zero convention of CCHF among the livestock. And this poses a great threat to the, risk to the farming community. In conclusion, looking even at the historical data and the patient profile, there is no doubt that the adult male involved in the farming, most of them are in a middle income bracket, are at higher risk of acquiring CCHF, because it's not just in this region, it happens every 2 years, once in a while, and it usually involves this group of the population. The virus is circulating. It's evident that the vector is there. The risk of human infections through tick bites, it's quite evident. In terms of exposure, healthcare workers are at the elevated exposure, especially, and it's made worse by the late detection. And for us, CCHF, we use it as a drill for severe form of hemorrhagic fever, and it's a concern for us that we are able to accumulate such a big number of health workers. So possibly colleagues from DRC, Uganda, when we are going to do our contingency plan, we're definitely going to invite you and also test these plans. The surprising thing about contacts for CCHF throughout all outbreaks, the zero conversion is actually zero. It's actually zero. And we are looking at it because we are applying the viral hemorrhagic fever protocol in terms of duration, in terms of isolation, quarantine of the contacts. But I think we need to look and do a study and align our findings as we are managing the contacts. I can give you an example. For one private health facility, it has to close because everyone was a high-risk contact. The same is even for the private facility to lose the staff. It is really not economical, so it's something that we need to look at. So these were just interventions that I've mentioned before. So it was unreported cases of CCHF, and contact tracing was done by surveillance. There were samples that were taken from presumably symptomatic contacts, but at the end of the day, the CCHF was ruled out, and capacity building on surveillance and case management on CCHF was done using virtual platforms as well as physical platforms. Animal health did extensive of work because they did assessment of livestock, ticks, and they did treatment, they did education. The education for farming community was done, and information on how to manage the tick bites. As you could see, close to out of a total of 4,885 cattle and our 1,700 sheep were actually treated, sheep and goats.
2 minutes reminder.
Yes, okay. And then that is the coordination and leadership. So there were some interventions around activation of National Health Emergency Committee. Guidance note was provided for all health facilities in the country to be on alert and how to manage. And we did not really put incident management system in place, but we used that model to activate other pillars to respond, not just limited to the regions affected, but throughout the country. Infection prevention, those were some of the interventions. From biosafety, quarantining, isolation, universal precaution standards, and I'm happy colleague who presented on IPC trainings. We have realized that in our health facilities, not just in Namibia, we are not practicing universal precaution, so that whether any form of bleeding comes, the health workers are supposed to abide by it. That is a gold standard, whether the patient is having CCHF or not. And in this way, we can actually prevent hospital-acquired infections as well. There was a dignified burial. With CCHF, we're having designated burials as well. This was risk communication. So these are some of the challenges that we have identified, especially under lab. From the presentation, you could see that we don't have the capacities, in-country capacities to test. So there was a delay in confirmation, and it is one of the weakest link in the response, because we could not, the remains of the patient were supposed to be buried within 24 hours after confirmation, but it took us longer. We need support with training, SOPs, guidelines, biosafety, mobile laboratory, and establishment of public health lab, which should be embedded in the NIPHI, and I'm happy to announce that our cabinet 3 weeks ago approved the establishment of the National Public Health Institute with the idea of putting the public health lab in it. There are other challenges as well with regard to the SOP development. Surveillance, yes, we need to develop a contingency plan, because currently that we are using is for Ebola of 2014. So we have decided as a country to develop contingency plan for viral hemorrhagic fevers, and with focus on CCHF as a module, because we have realized that the transmissibility is completely different from other hemorrhagic fevers. And also contact assessment and studies that I've mentioned around contacts. And I forgot. Okay. And with EPR as well, epidemic preparedness and response, our public Environmental Health Act does not really cover us legally to deal with issues around burial, around isolation, around mandatory quarantining of contact. So we have to deal during the response, instead of dealing on technical issues, we have to deal with legal issues surrounding the isolation and quarantining and burial as well. So we want to revise our act so that the provision is made, and it's made, and public health measures can be implemented easier. This is just for others. And this is the acknowledgement to all the partners and colleagues. I'm just presenting the work of the entire team, but these are the entities that were involved in the overall response. I thank you.
Thank you, Dr. Yalo, for the interesting presentation. Please take a place in the podium.
Thank you. Now we are getting to particularly dangerous viral infections. Very dangerous. You are welcome, Mikhail.
Greetings to you, dear colleagues. Allow me to relay my thanks to the organizers of this conference, but because this is a very big honor for me. I am a staff of the Rospotrebnadzor under the Center for Virusology, and we mostly study particularly dangerous infectious agents. Allow me to talk about very dangerous viral and viral infections that circulate in our country. I want to start with something very simple, and that is that viruses are the most common form of life on our planet. And of course, our planet could even be called the planet of viruses, because we even have bacteriophages that are in the numbers of about 10 to the power 31. And if you look at the microscopic nature of these things, you will see how many and how they are and how spread out they are. It's important to also notice that so we are also able to, the spread of antibiotic treatment has also reduced most of these infections. And this is also based on the current ICTV taxonomy release, where the data that you can see on the graph talks about the frequencies of some of these emerging and re-emerging infections, as you can see there. And according to me, I think it's the biggest evidence about the existence of virusology. And of course, as you might expect, viruses are all around us and they're not far from us. And of course, this is the reason for some of the big outbreaks in the previous times that we have seen. And most of these outbreaks that sometimes we see also have viral origins. As has already been spoken yesterday, today in the current times, the modern times, we have a very, very big number of infectious diseases, and this is as a result of many factors. We have factors, for example, the global international air travel that is changing, changes in the population projections, changes in our environment, for example, the climate, and these are always things that can cause natural catastrophes to take place. And we also have increase of population, as has already been spoken about. And I know that there are strategies being taken even towards this endeavor, not only in Russia, but in Africa. It's important to also talk about how Africa has a particular unique natural environment. And as you can see, these are some of the causes of some particularly dangerous infectious diseases. And as you can see on the map, you can see particularly hotspots, global hotspots for emerging outbreaks for these emerging diseases and re-emerging diseases. And these hotspots are on the African continent and mostly in Western Africa, but also in countries in Asia. When we look at when we talk about the most dangerous, when we talk about biosafety levels, the BSL-4 is the highest and the most complex biohazard. When we look at it, we see how all these pathogens are mostly viruses in this level. And these create outbreaks. For example, arenavirus, we can see it, and it's mostly spread on the territory of the African continent. And we also have it as something that is even new to the international level. We have flavivirus, for example, flavoviruses, for example, the Crimean Congo hemorrhagic fever virus. And as you can see that we can also include even viruses that are spread through the natural outbreaks that take place in different regions. And this also can actually include the viruses that have been spread during the 20th century. When we look at the pathogenic groups, pathogenicity, depending on the pathogenicity, we classify them depending on their degrees of pathogenicity. And in Russia, we start from the most pathogenic, and in BSL-4. And you can see that on our graph. For example, we can see in red color, we see sometimes bacterial agents, for example, plague. But we also see viruses, for example, the monkeypox virus, which sometimes can create very strong epidemics in the world. We also have apovirus, which is in the second pathogenicity group according to the BSL-3, according to the international classification. I want to begin talking with a virus that I think is the oldest it did not, of course, affect much of the humankind history. So we are talking about smallpox. It was one of the first outbreaks that I think is documented. It occurred about 6,000 years ago. And according to archaeological studies, you can see that people suffered from it in the 3rd millennium BC. And it has been also continuing throughout the history of the humankind with different outbreaks happening. For example, there was an outbreak that happened in Siberia, and it actually had a very big mortality where people died. And even up to the 20th century, this virus has continued to pose a problem to us with an increase of spread and increase of scope. According to the modern classification, this virus for smallpox is from the family of Poxviridae, and there are 13 species that we actually have, and they are divided into these 2 clades. For example, Eurasian African orthopox viruses, and the second class is North American orthopox viruses. And so the genomics of these particular viruses have particularly big sizes. For example, we can see here approximately 186 to 228 kilo. And they're also encoded with a number of proteins, as you can see, with 233 of them in. And so this is considered one of the biggest viruses in terms of size, of course. And as you can see in this picture, it also presents with a number of genomic structures. We all know that the virus for smallpox is the only known virus which was vaccinated fully, and in 1958, we remember that in Soviet Union, there was a program that was started for the global eradication of smallpox, and this increased the interaction between the whole world on this topic of smallpox. And it was completely eradicated from the whole world. But we still have, laboratories whereby the viruses of this smallpox continue to be kept and studied. And so you can also see the Declaration on the Global Eradication of Smallpox in 1979. We need to also say that this smallpox virus still continues to be dangerous for people. And for example, we continue to see outbreaks of zoonotic vaccines from these orthopox virus strains. We see it in Pakistan, in Bangladesh, in Nepal. For example, buffalo pox under the group of orthopox viruses. And these create really big epidemiological outbreaks when we talk about the number of people that are affected. We also have among this classification Alaska pox virus, and we are continuing to actually open now new laboratories and new studies into the virulence and spread of these orthopox viruses and also their effect on humans. And so in 2022 to 2023, we had a global outbreak of monkeypox and monkeypox in humans. And this outbreak was realized in almost 111 countries, of which are members of the World Health Organization, and a number of people, towards 85,000, were confirmed cases of this monkeypox virus. So when we talk about now this monkeypox virus concretely, it was first discovered in 1958 in Copenhagen. And this was from a monkey that had been carried from Africa to Copenhagen. And of course, this was the first incidence was in Democratic Republic of Congo, and we also know that this monkeypox is particularly endemic in most of the countries of the sub-Saharan Africa. And in 2003, we registered the first outbreak, which was outside Africa. And this was in the United States that we registered it. I think that I'm not going to also continue all the other outbreaks that have happened ever since, but beginning from this year, so from the time that it was discovered in Africa, we have registered more than 4,000 outbreaks of this monkeypox, and we continue to notice it in certain countries, for example, in DRC, in Cameroon, in Liberia, and in other African countries. And as I've spoken, we still continue to study these orthopox viruses, and this is with the help of certain methods of detection and differentiation. For example, PCR as a molecular genetic methods, and this is particularly one called real-time PCR, vector PCR BOO. And this is able to enable us to detect a wider range of these strains of these orthopox viruses. And we have also been able to register a protocol that is based on the genomics of this orthopox virus. We've talked about the molecular genetic methods, but there's also a serologic methods of identification and differentiation of this orthopox virus. And some of them we're able to test using the ELISA system, the immunoglobulin G. And we continue to do immunochemical diagnosis of these orthopox viruses using different codes. We also have particularly dangerous infectious agents, for example, filoviruses. As you can see, we start from Ebola virus, which continues to change in terms of, or to mutate. And in this family, we have six types. 3 are very, very highly lethal for humans, as you can see in the red color. We have Thai forest virus, which also has a fairly adequate lethality to humans. And the ones that don't have such strong reactions towards people is Reston virus, which has only been registered in Asia. And we also have we also have on the borders of the Western African countries, we were able to discover a new virus called Bombali virus, about which we still do not have full information, but we're still continuing to study it. These viruses are practically spread throughout the African continent. For example, so we continue to have different classifications depending on their localizations and their genomic structures, as you can see on the graph. And now we want to look at this Ebola virus disease outbreak, which happened in 2014 on the territory of West African countries. And when we consider the lethality it had and the number of people that were confirmed as positive cases, it was 11 times larger than all previous outbreaks that had been encountered. And this virus of Ebola is still quite an actual problem for Africa. And as you can see, we also registered 2,299 deaths in Democratic Republic of Congo in 2018. And we continue to register very, very high levels of lethality for this virus. And this is also particularly noticed that it's mostly in unstable areas that we notice the lethality and the mortality which is caused by the viruses like Ebola. And I think we talk about more about the case study for Uganda. And we also want to talk about Marburg virus and Raven virus, which are also very, very lethal to humans, and they are almost the same as the Ebola virus that we've seen in the previous classification, and they have a very high epidemiologic potential. It's also important to talk about the We also have to talk about the family of arenaviruses. For example, we have been aware of the Lassa virus, which is particularly predominant in Western Africa, and also the Lujo virus. In the Southern Africa, we also have Lujo virus, together with the other viruses that you can see on the screen, which are interesting to know in different locations. And of course, the nomenclature of these viruses is very interesting, and it depends on many different things. Some of these viruses are actually named from the way that they appear on the microbiological slides, and as you can see on the slide picture, it showed their round shape, and this determined the formation for their name. We want to also talk about this Lassa fever that is particularly endemic in West African countries. We speak of about 7 types of this virus, and in the time of this past years, we've been registering about more than 10,000 cases of Western African countries, and this has been with the use of a number of kits, a number of diagnostic kits. And in 2024 alone, we have already registered about more than 5,000 cases of Lassa fever. It's important to note that for rapid response towards these dangerous epidemics, outbreaks, the very effective and very sensitive methods of diagnostics for these outbreaks need to be used. For example, in differential diagnostics for these outbreaks will always be helpful in aiding us to create prophylactic measures and also adequate treatment against these dangerous and this is also very helpful in case we're able to construct institutions that have the abilities to be able to carry out the diagnosis and treatment for the same. For example, we have seen this in Ebola virus in the Guinea Republic, and we continue to also use this in other African countries. Yeah, thank you so much for all your attention, and thank you.
Thank you. The last but not least presentation from the side of Dr. Kamara from Guinean Republic. Please, Doctor, take the floor.
Ok, bonjour à tous. Je suis Alimou Kamara, pharmacien immunologiste. Je suis docteur des fièvres hémorragiques de Guinée.
I would like to thank the Russian Corporation for having organized this conference. I'm going to present work on the Zika virus, the dengue in Guinea. My presentation is going to be on the Zika virus. This is a collaborative work between Guinean researchers on the identification of vectors in the regions of Farana and Zerekore. Detection of virus markers in these regions. The pandemic of Zika and dengue and yellow fever have been recorded in several countries in Africa. And recently, previous studies have shown that several mosquito vectors have been recorded. And these have been found in the district of Kundura at the border with Guinea-Bissau, where some of these have been noticed. Between 2022 and 23, these were also noticed in the district of Dabula. In 2023, another of these was noticed between the border of Senegal and Mali. This shows that yellow fever is circulating in Guinea. Regarding the Zika virus, it is transmitted by mosquitoes, which presents a disease, an acute disease amongst humans. And it was isolated in 1947 in Zika in Uganda, and it affects several countries in Africa and outside Africa. In 2015, the Zika virus there was a big outbreak where 4 million cases were recorded, having the epicenter in Brazil. In 2017, the Zika cases affected several other countries. These are some of the hypotheses from various researchers. First of all, the Zika virus, dengue, and West Nile viruses circulate within the regions of Nzerekore and Farana in Guinea. The mosquito vectors of this virus are abundant in these two regions, and clinical cases of these viruses have been found in Guinea. To verify these hypotheses, we had 3 research questions. What is the rate of seropositivity of the Zika, West Nile, and dengue viruses in the Farana regions? Secondly, what are the main mosquito species of these viruses in this zone? And are there clinical cases of this virus? This study was carried out in Guinea and Russia. I'm now going to talk to you about the health situation in Guinea. Guinea is a country in West Africa with a surface area of 245,000 square kilometers. Guinea has 4 natural regions with distinct climatical conditions. The country has a population of 12 million inhabitants, according to the national statistics in 2023, with 52% being women. The annual growth rate is 2.9%, and life expectancy is 58.9 years. The average age of the population is 22 years, and a big part of the population is less than 18 years. Health is a constitutional right for all Guineans. If you look at the health pyramid in Guinea, to the right, we have the community level at the base, prefectorial level, and the national level. And these are all supervised by a central health authority. Information is transferred from bottom up. As far as health structures in Guinea are concerned, we have 1,316 health centers, 415 centers for vaccination, 35 community medical centers that have various medical activities and other basic specializations. We have 26 regional hospitals that offer this health package for in the areas of cardiology, pneumology, neurology, and urology. We have 3 national health hospitals in Conakry that carry out research, training, and health care. As far as laboratories are concerned, the country has 39 labs at the district and commune level, 8 laboratories at the regional level, 4 laboratories for the animal sector, and 3 national referral laboratories. In 2014, the country came up with 13 priority diseases, and these involve rabies, Rift Valley fever, Lassa fever, trypanosomiasis, and avian flu. Other diseases with epidemic potential were added, like yellow fever, cholera, meningitis, plague, COVID-19, measles, and other seasonal fevers. This list changes all the time, and it's always updated depending on the conditions. So different serum were collected from patients who came to medical facilities to test for Zika and anti-dengue. These works were carried out with commercial kits. To detect the Zika virus, 152 plasma were collected from people presenting acute fever. And to detect IgM anti-Zika, 116 samples were collected from patients at the Farana Hospital who presented fever. They were tested with anti-Zika virus, ELISA, and the reagent kits, Erumium, and others. Materials and methods. Sequencing of the genome was carried out with specific fragments, and these were sequenced using the genetic analyzer according to the instructions of the manufacturer. The complete sequence was processed. Regarding results, seropositivity of IgG, you can see that 6% were used in this study and 12.1% for dengue fever. So these were carried out in the analysis of these diseases. For the Zika virus, 0.50% of the samples were studied. Regarding the results, there was a woman of 27 years who was pregnant, businessman, and the first symptoms were noticed on the 25th August 2018. He came to see the doctors on 29th August 2018, and the PCR realized a positive test. And then we compared with the existing sources, and our source was compared with one that was discovered in Senegal earlier in 2011 and 2015. And then regarding the vectoral study, we identified 8,321 mosquitoes that were collected and identified, and we had big diversity of species that were found of these mosquitoes. To the right, we have the Anopheles, and then Aedes and Culex. Positivity of the Zika, Chikungunya, and West Nile and dengue viruses were presented less results compared to what others had done in 2021. And no clinical case of Zika was found in the literature according to before our results. Mosquito species identified could enrich our knowledge on the presence of new species. To conclude, the results of our study suggest that we need to continue research on these arboviruses and vectors of these diseases, and this research should continue. And to conclude, I would like to say that let us work together to achieve more success. I thank you.
Colleagues, we are going to now move to the panel discussion. Because of the fact that we made some few changes in the program. And we wanted to be able to do this so that we can discuss towards the end of this session. So the panel session will have 3 people, I think 4. Each person will have 4 minutes. And then we'll have any questions, additions, or responses.
Coming up is Professor Okware, Professor of Public Health, the Director General of the Uganda National Health Research Organization. Is going to discuss with us Ebola. He's the man who has had Ebola firsthand. Professor Okware.
Thank you, Chair. 5 minutes will be may not be sufficient, but I'll try to squeeze it within that period. Ladies and gentlemen, I had a very special opportunity as head of disease control in the Ministry of Health to have led the containment of the first outbreaks of Ebola in Uganda. Yes. Just to recap the history of this disease. This disease was first identified in 1976 along that river Ebola. And then somehow 1 year later it went across to southern Sudan. And eventually we hope that from there it came over to Uganda. Right now we have, I think, we've had 3 outbreaks of Ebola types of Ebola in Uganda. The Bundibuju type, the Sudanese type, and to some suspicion, I think the Ebola type. Now, these were the outbreaks that we had over the last 20 years. There are about 7 outbreaks. The major one, I think, which is most important, is the Gulu one up there, where there was a spread over to the neighboring district and also to another hospital southwest of the country, but was quickly managed. Let us then followed 2007, was followed by another outbreak, in Bundibuj outbreak, and even that one was really problematic. We'll be discussing it briefly. And then there were 2 other outbreaks in central Uganda. And the last one was in Mubende, central Uganda, which was well managed. Let us see details of this outbreak. Basically, you can see that the first one was quite complicated outbreak. At one time, we held the record of the largest number of cases of Ebola, 224 deaths, of which we had 23 healthcare workers dying, and one of the, including the medical director of the hospital, Dr. Lukia. Now, why was it that this disease was not picked up on time? It was up in a rural area. It was thought it was witchcraft for some time, and it's not until the nurses, 7 nurses died in a training institution in Gulu, that we realized it was Ebola. And in fact, at that time, we had to take specimen to South Africa, so we lost like 2 months. So Bundibuji one, basically also, it was bad because we did not know what it was. We had to take samples to USA, and that's when it was recognized to be a new type of variant. I will talk also about that Luwero outbreak where there was only one fatality. Why was it that we were able to do so well? Why were we able to do so well in such a situation? And then the others, and of course the last one, Mubende one, I think we'll be discussing it. Where do we think that this disease came from? I think we believe strongly that this disease came from bats. Why? Because 5% of the bats in that region have been positive for Marburg, and I think also bats are responsible. Now, the link between the index case and the bats is that because this was occurring during planting season, fruit season, these people could have gone up there to do gardening, and then when they were there, they ate partially contaminated, eaten fruits, and thereby linking up the infection from the bats to these patients. And when they came home, of course, the spread person to person continued very severely. But of course, there are also other ways. There are also other methods of contamination, and sexual thing, we rule it out, sexual. But also, there is this new one discovery that there's the viral viral persistent derived transmission, which has been found in 2% of patients who had survived in Sierra Leone. We are not quite sure why we are responsible for that. Let us look at the clinical features. And why am I bringing this one here? In the case definition, we're talking about fever, you're talking about blood. But you can see, bleeding, sorry. But you can see that not all the cases here who have fever have less than 15% of the patients here have actually fever. And also the bleeding, especially in Bundibuji type, in our dark skins, bleeding is not so obvious. So the case definition has got to be validated all the time. Just to summarize basically the risks here, okay, there's no infection before fever, that was our experience. Bedside care, hospital had twice as risk, and also cadavers. In fact, the women who are doing the cadavers, preparing cadavers for burial, had 7 times more severe infection than those who didn't have. And then this link, which I have just talked about, forests and fruits, and also planting season, rainy season, very important. Now, I think, why was it that we were not able to do quickly, delays? Some of these cases came from rural areas, and up to 2 months before we could get, the Minister of Health could get the infection. Another thing was complacency. Most of these patients actually, more than 50% were picked up from the general wards, not from the isolation wards. There was a general tendency for people to think that when you are in the general wards, when you are in the non-isolation unit, you are secure, but that was wrong. And there was also support staff who had been ignored. And at the end, most of those patients who suffered were support staff. OBGY, bleeding, this menstrual cycle, abortions, that's how some of the patients entered into our system. In the case of Bundibuju, the first case was one supposed to be abortion. And in the case of this outbreak in Luwero, the first case was supposed to be having her period. But because she had fever, she was tested and she had that problem. Now, let us look at the national response. And basically here, I'm looking at the whole society response, starting from HE, the president, and at each level, at national level, sector level, you had all those tiers. You have the intersectoral committee, the national task force at the sector level, district, and so on up to the parish. But let us look basically at the parish level. Parish level, this was the engine. This was the basis, foundation actually of the containment. Because there was no treatment, there was nothing. We gave it, the village health teams be responsible for this. We engaged them.
Professor, you have a half a minute.
Oh, half a minute, okay. And so on. So that's basically, their main role was surveillance, care, essential supplies, and then registration of, and this is basically how they were linking up with ambulance teams and then making the whole system. So the best outcomes, I think, are here. You can see in Luwero, early diagnosis. The patients are identified 5 days later. The virus research institute identified this, and activity started at the community, and almost that was. Also, community containment. You know, communities, when these patients ran away to Masindi, the communities decided to put quarantine in that small community, and we were able to succeed because out of a whole population of Masindi, only one patient got infected, but the community infection was contained. So basically, I think they have summarized this. The risks, I think, have been rainy season, hospital visits, maternity, healthcare was being vectors, and misdiagnosis because of that fever issue, and also false sense of security, complacency, and community engagement. Finally, I think, conclusion, we're not 100% perfect, but the Ministry of Health working alongside these partners and the community contain the outbreaks, sometimes the delays, but once that's in Luero, promptly and effectively using the community. Yeah, you need to read more material.
Thank you very much, Professor.
Those two books which are published, those two books are published recently, and also there are those references. Over.
Thank you very much. Our next member on the panel, Dr. Mulongo.
Good afternoon, I think. It's hard to present in 4 minutes. I'll try. I'm sharing an experience as part of the ongoing data analysis that we're conducting about the 2022 outbreak in central Uganda, and I'll focus myself on Kasanda district during this outbreak. Like we all know, the outbreak was announced on 20th of September by the Permanent Secretary, and after that announcement, multidisciplinary and multisectoral teams were deployed to control the outbreak. What is important to note is that the 2022 outbreak spread so much within central Uganda, although we had some districts affected within south, that is Masaka and Jinja in East Central. But the most affected districts were Kasanda and Mubende. As you can see, most of the cases came from those two districts. Kasanda specifically, sorry. If you look at the way the outbreak blew out, in 2022, we tended to have 2 peaks on the epi curve. And you can notice that the second peak, which was highest, was noted in Kasanda. And in Kasanda, most of these cases, Kasanda is neighboring on the southern side to Mubende. So most of the cases, the index cases came from Mubende, crossed into Kasanda. So you can see the border sub-counties within Kasanda were the most affected sub-counties. I think there's a technology hitch. Okay. In Kasanda, we had an outbreak which behaved in a different way. Males were more affected than females, with the attack rates in males twice as that in females, but most of them were around ages between 15 and 44. We had 5 clusters, and in Kasanda, and as you can see, the first cluster gave us 3 cases, the second cluster gave us 2 cases. Oh my God. The third cluster gave us 1 case, the fourth cluster about 3 cases. The fifth cluster was the most troublesome cluster. It gave, on one arm, it gave us 3 cases, but if you look at on the other arm, it blew out to over 37 cases. And we're wondering why, what had happened, what was wrong, would it be a spread at a family level, what could have been the factors? So we were wondering what was the relationship between household size and the risk of Ebola. Was this transmission at household level, or there were other external factors? So we conducted, I think I'm having challenges. We conducted a respective analysis, which is ongoing, and this is part of the results. We defined a household as a group of people living under one household with one head, and the risk of Ebola, we used the household attack rates, which is a proportion of household contacts that got the disease. And we measured the relationship using the Pearson moment product correlation coefficient. So we, in total, Cassandra registered 1,075 contacts with a median age of 19. These contacts were coming from 393 households with a median household size of 2.64 family members. Among those contacts, 42 developed the disease, but the households which had contacts were 31. So we, and the average number of cases per household was about 1.35. The attack rates at household level was 70, ranging from 10 to 100%. So we plotted a scatter plot trying to test the relationship between household size and attack rates. As you can see, it's a negative trend. If you see the R is 0.0446, which shows that the lower the number of household members, the higher the risk of transmission. That means that maybe most of these take care in looking after that individual. When the household size is higher, like say you see 27, the attack rates were low. It means that some household members do not directly get affected by the transmission. So looking at our R and the coefficient of determination of 0.55%, we think the 55% reduction gives us a moderate variation, moderate relationship. So in conclusion, we have high attack rates in the families, with men more affected than female, but these attack rates reduce as the household size increases. Perhaps because of effective surveillance, and at that time we're picking cases and isolating them in dry phase, like Professor has just presented. If you pick cases in the dry Ebola than in a wet Ebola, the transmission rates become low, and maybe these are lessons for future outbreaks. Thank you for listening.
Thank you very much. Even with the interruption, all is well.
Thank you. The next quick speech, Dr. George Passy, University of Busitema, Uganda. Thank you.
Good afternoon to everyone, through you, Chair, fellow panelists, and distinguished guests. My name is George Passy from Busitema University, and I'll be taking you through spatial clustering, temporal analysis of the recent 2022 Ebola outbreak in Mubende. In a nutshell, I'm just talking about the science of where. This is premised on the fact that there is a geographical risk to infectious diseases. It's 48 years since the first containment of Ebola outbreak happened in Africa. And the fact that Ebola has a zoonotic reservoir, it can't be eradicated. That means time from time again, we're going to have Ebola transmissions from the animals to susceptible populations in Africa. The fact that there is no substantive treatment, the vaccines are still all in trial. This leaves us with early detection, notification, and response as the mainstay for the containment of many of these outbreaks. However, challenges do exist towards early detection. The fact that Ebola, like many other viral illnesses, presents with non-specific symptoms, and the fact that there is also a phenomenon of asymptomatic transmission. These two kind of mask the early telltale signs for Ebola. So there are usually going to be delays towards detection. This, therefore, allows us to be a bit innovative, that our response should be a bit innovative in trying to curtail or control the outbreak. In this particular case, the outbreak detection took about 42 days before the first index case was captured, with a number of suspect cases dying in the community. I therefore present to you geospatial analysis. This is an organ, a tool that can be employed to foster effective response towards infectious diseases, including Ebola outbreak, through one, looking at the disease transmission dynamics, two, identifying high-risk areas through hotspot analysis. These two enable targeted interventions towards Ebola outbreak. This was covered by previous speakers. Analysis begins with the epicurves. There are two, it was a bimodal epicurve indicating that the first curve shows the primary introduction of the Ebola infections. The second curve shows secondary cases or secondary clusters. So we set out to find what were these secondary clusters and where were they. Through spatial autocorrelation techniques, we set out to determine the global Moran's eye to show if there was clustering, and indeed, yes, this was a positive test for that, showing that there was statistically significant clustering from the sub-counties in our study. When we use the local Moran's eye, this pinpoints where the clustering is happening. We see the red. The red signifies the high clusters, and this is what we call the hotspots. These were areas fueling the outbreak in Mubende 2022 outbreak. We found two clusters, one multi-center cluster having 13 locations, 11 in Mubende and 2 in Kasanda district. We sent out to take a deep dive into this. What was fueling, what was driving, the dynamics driving these two hotspots identified, the Kasanda and Mubende. And we found that the overlay temporal intervention laid there was lockdown. On the 15th of October, there was a lockdown put up to try and curtail or control the outbreak. And we found that for Mubende, dynamics of attack rate, doubling time, and days to the peak were significantly reduced in the post-lockdown period, meaning in a way the lockdown worked in Mubende, rightly so. The effective reproductive number for Ebola in that particular region reduced, as you've seen by the curve down there, to below 1, indicating that there was no active transmission of disease. For Kasanda, on the other hand, we found that post-lockdown institution, there was worsening of the situation. We found that the attack rate, the excess risk, and days to peak actually increased in the lockdown period, as shown by the curves showing the pink shows the cases almost increased by 7-fold, and rightly so. We see the R-square, the effective reproductive number increasing, meaning Kasanda was responsible for the second peak, or the secondary transmission we're seeing in the Ebola outbreak period. When we did a causal impact assessment for the lockdown, to see before and after assessment, to see on the number of cases as well as number of deaths, we found no significant association of the lockdown reducing caseload as well as the death in this particular outbreak. Possible explanations could be delayed reporting, initial spread before the lockdown. How was the lockdown compliance ensured? And lastly was the health infrastructure in these particular regions. Conclusions, there was substantial spatial clustering at sub-county level during the 2022 Ebola outbreak. And this geospatial analysis provides a very important tool towards informing targeted interventions in outbreaks, understanding spread, safety protocols in areas where there is protection, and further investigation. I'm happy to say that this work has informed a maximum entropy modeling we're doing currently for Ebola risk mapping. We're building onto the works done by Luke Nyakairuhama, and probably throwing in more variables, including social and ecological variables, to try and see what is the updated map for Ebola risk in the country. But also importantly, this was retrospective, but we're building a prospective model which will be probably used in the next outbreak, because surely you and I know that Ebola is not yet to stop in Africa. There will be continued outbreaks throughout the country, and how prepared we are through such mechanisms, such meetings, is what probably informs the impact of the outbreak through such meetings. Thank you very much.
I greet you all again. Let's have the presentation. I would like to speak about how we carried out the liquidation of Ebola virus in the Guinean Republic. I'm going to speak about it a little bit deeper and in more detail. Presentation, please. I will begin without the presentation. Maybe it will come on. We all know what happened in 2014 in the West African area in Guinea and Sierra Leone. In that moment, it was a really big situation to reduce the risk and the outbreak. And so, on the 19th of August 2014, the Guinean president asked the president of the Russian Federation to send help, and the president of the Russian Federation took a decision. And a team from the Rospotrебnadzor was sent to the Guinean Republic, and it was consisting of 2 mobile laboratories. And these were delivered to the Guinean Republic using particular aircrafts. And of course, on the 22nd of August, they arrived in the Guinean Republic. And the cadres that were in this the specialized anti-epidemic team were 2 epidemiologists, 2 virologists, 2 laboratory diagnostic experts, and 1 experts team decontamination technician. Of course, there was also drivers that were part of it. And there were 2 modules for the laboratories that were for detection and bacteriological research on the Guinean Republic. These laboratories worked autonomously with a capacity of up to 140 samples. And of course, they used different diagnostic measures, for example, PCR, ELISA, for bacteriological research. And when we talk about the Ebola virus, they detected more than 20 species of particularly dangerous and socially significant infections. And next, in January, the following year, due to our international cooperation, in the Guinean Republic, in the city of Kindia, there was an opening of hospitals for the treatment of patients that had gotten infected with Ebola. And some mobile laboratories from the capital city, Conakry, was sent to the city of Kindia, where they continued to work with the samples in that city. So in short, I want to speak about the results of our of our cooperative work together with Guinea. So we worked together from 2014 to 2016, particularly on this outbreak of Ebola. There were 2 laboratories that worked, and all of them worked in autonomous nature. And this mission that we had to the Guinean Republic took more than 50 people who were always rotated every year, and they were changed with different methods. So 15,000 studies were carried out on the presence of different causative agents, and these were also carried out with 20 other infectious diseases. So what was received that I can say is new was that the preservation of the virus in biological fluids of people that had been recovering was mostly in the breast milk. We also were able to find out more about the molecular genetics of the Ebola virus. So during this work, we were able to have 4 test kits that were applied for the detection of Ebola virus, and specific antibodies were developed towards this cause. And more than 400 Guinean specialists were trained through this cooperative work. And during the time of this mission to Guinea, none of the specialists from Russia, none of the workers in the laboratories, none of them, of the staff of the collaborative work were infected. And even after the specialists went back to the Russian Federation, there was no detection of any spread of Ebola virus that had been carried from Guinea. So this outbreak gave us a chance to learn a little bit more, and we had a total number of cases, which was 16. Unfortunately, 9 of them died. And so using sample IDE2, we were able to confirm these cases with blood serum from the second laboratory, and we were able to collect data about the different strains of the causative agents. And we found out that this outbreak also moved to some other cities, and it was spread from person to person even sometimes, and it can be spread to even healthy people. And as you can see on the map, you can find all this data in NCBI GenBank on that number. I want to say a big thank you to the collaborative work between us and Guinea. We won together, and thank you very much.
We have come to the end of this session. We would have loved very much to have some interaction, but we are 25 minutes late for the next session. So it will be perhaps, let's carry on the discussion from this session during lunch, and perhaps if we get time immediately after. So we'll invite the next session leaders to come up and take up their position. We are sorry we have lost a lot of time. We put our hands to thank the members who have completed their presentations.
Thank you very good. It was nice. Right.
А сказали, что вопросы после всей сессии, что сейчас мы опаздываем.
You can stand up and stretch your legs to avoid DVT. As the guy.
Dear colleagues, let's start the next session. And now we move from vector-borne diseases to acute diarrhea, and our session devoted to lesson learned from cholera outbreaks, but we will speak not only about cholera outbreaks, we will also speak about other intestinal diseases. And the first speaker, Oksana Podaynicina from Rostov Research Anti-Plaque Institute, Russia, and her presentation devoted to cholera, modern aspects of epidemiology and anti-epidemic measures. Please.
My name is Podaynicina Oksana, and I'm a staff of Rostov Research Anti-Plague Institute, which is one of 5 anti-plague institutes in my country. I would like to first thank the organizers for the possibility of being able to be here, and also to be on the understanding side of the need to have such conferences. So in the 19th century, there was spread of cholera worldwide and after We had about first 6 pandemics, and right now we have the 7th pandemic that is taking place right now. And then right now there's a biovariant Vibrio cholerae that is particularly effective. So the vibrants of this biovariant, this new one, were first identified in 1905, and they continued to displace the pathogens of classical cholera, and they took up now the first place or the first area. So currently we know about 206 known serogroups of Vibrio cholerae. All 7 of them in the pandemic were caused by Vibrio cholerae 01. But in 1992, an epidemic in Bangladesh led us to discover that the cause was Vibrio cholera 0139. And the Vibrio cholerae 01 and 0139 are quite similar in nature, but they just possess a different type of O antigen on the surface of the cells. So it was thought that this Vibrio cholerae was supposed to cause the 8th cholera pandemic, but it did not happen. So sometimes these strains of Vibrio cholerae are isolated in the continent of Asia. The evolutionary success of this Vibrio cholerae is associated with high plasticity of the genome, with ability to change and acquire new genetic elements. And Vibrio cholerae L2 has undergone a number of changes. And as a result of that, it has acquired resistance to certain antimicrobial drugs, and it has become more virulent than it was before. And in 1991, we now started seeing atypical strains of Vibrio cholerae. And at the same time, we also saw the typical Vibrio cholerae strains. And right now, the atypical Vibrio cholerae continues to occupy the biggest position in the infectious spread of cholera. In trying to understand the pathogenetic potential of Vibrio cholera, it is important to take up genetic studies to see the genetic dynamics that encode the main pathogenic factors. And 2 of these, one being the adhesion, the adhesion whereby it's able to adhere to the cells of the intestinal mucosa, and also, of course, the genes about biosynthesis of proteins. Vibrio cholerae 01 and 0139, they contain the genes that are shown available, and they are significant genes which lead to the cause of these cholera infections. So as you can see on the graph, the epidemic incidence of cholera, you can see that this trend has now continued to increase. And I want to talk about the Russian experience, about the welfare, and also how Russia has continued to combat this cholera infection. And so to be able to have to reduce the spread of cholera in Russia, we set up a set of measures, and these include organizational measures, preventive and anti-epidemic measures, which are being carried out even to this day. So the organizational part in the first part is for the development of that comprehensive plan, and in the organization part, we take note of what needs to be done during a cholera outbreak. In this organization part, we also see how the warning signs, what needs to be done to get response for the cholera infection. And it's done in different ways in the different territories of the Russian Federation. So every year, we also conduct trainings for the different personnel that are involved in these cholera outbreaks. And we do simulations of real situations that would need response by our teams. So, for example, the patients that we suspect are gotten by the ambulances and emergency teams, and they're taken to the hospitals, and we simulate how it would be. So in that way, we are able to do a kind of a modeling of how to respond to the cholera outbreak. On top of that, we have particular and specialized training for all specialists involved. Let's look a little bit at the preventive measures in place. These are also carried out every single year, and it involves the monitoring of the environment, and also involves monitoring of patients with complications. So we have been able to examine patients with severe cholera, diarrhea, and vomiting with pronounced dehydration. And these examinations also take place with patients who are in acute foci. For example, if a patient had vomiting or nausea during the time of the investigations and examination. So they all take place on patients who have any acute intestinal symptoms, including diarrhea and vomiting. Apart from examining people, we also examine the different materials in our environment. So every year, we continue to examine the water and the water sources. So we mostly want to focus on the central water supply sources. So we normally check the decentralized water use also, for example, in columns, in wells, and the springs. We also examine the recreational water use, of course, where people swim, for example, where they do sports from, where tourism is widely spread. And we also carry out tests and examinations on wastewater materials. So the preventive measures that are taken are taken upon detection of a patient that could be having this cholera. So when we discover a cholera patient, we create a coordinated response towards and so during this collaborative work, we now decide where and when we shall be able to isolate, what measures need to be taken, and this creates a complex plan of how to be able to combat this infection from spreading. On top of that, we also a laboratory group is also formed on that territory where we have discovered a patient, and that laboratory group is important for determining the capabilities of what laboratory tests and investigations will be carried out. It will be also responsible for deciding the competency of equipment or the presence or even the absence of particular equipment. And also on top of that, whenever we find a patient with cholera, there is a composition of doctors on the hospital basis in that particular area. So the hospital bases in the Russian Federation, we have particular special hospital bases which pay special attention to cholera outbreaks. And in these hospitals, we have isolation areas. We have areas for dispensation. And in these hospitals, they will undergo investigation. And of course, there will be urgent prophylaxis that will be carried out. So at the end of the day, we cannot isolate people without we first isolate them, and then we go ahead to confirm the cases. And the hospital bases also have a responsibility in looking out for places and cases of intestinal infections. Whenever we take out these examinations, if we see that it's a cholera infection, we move them to those particular specialized units. And at the same time, there are observatory areas in these hospital bases that we have created. And so they are responsible for making sure that they prevent the spread of infection. And so when we take out isolations from the surface reservoirs, what will we find? So there are some limitations, of course, some restrictive measures that we place on the water and the use of water bodies. And so these kinds of water reservoirs have two kinds of points that we'll take into our attention, the upper scale and the lower scale of these water reservoirs. And so on top of that, we also make sure that epidemiological investigation is done for the water reservoirs, and it is conducted in order to identify the sources of contamination in the waterways. Bacteriological examination is also done for these cholera patients on the basis of the water sources. I would have wanted to continue, but the time is limited, so I want to end here. Thank you so much.
So, thank you very much. So next we'll have assessing cholera outbreak preparedness in Uganda by Dr. William O'Connor. So given the time constraints, I think we could try to do it in 10 minutes. The key data and key messages. Thank you.
Yeah, thank you so much, Chair. Good afternoon. I'm William O'Connor, a public health specialist and currently an infectious disease field epidemiology fellow at Bustema University. I'm going to share our experiences regarding cholera preparedness in Uganda, a case of Busia district, which is found in eastern Uganda, and mainly profiling the role of the Emergency Operations Center, where I did my field attachment. Mbale Emergency Operations Center was the first emergency operations center to be initiated in the country in 2020 during the COVID-19 outbreak, and the mandate was to offer regional coordination in order to prevent, detect, and respond to emerging public health threats or hazards within the region. And the center operates through the watch mode, which is the day-to-day business, and conducting analysis of weekly surveillance data so as to analyze emerging epidemics within the region, but also in the alert mode where there is an imminent danger of a potential outbreak, and response mode where we initiate our activities based on a confirmed outbreak. Mbale Emergency Operations Center oversees over 16 districts and one city within eastern Uganda, serving about 4.5 million people. Sorry. Cholera in Uganda has been in existence since 1971, when the first outbreak was actually discovered in Kampala city, and since then, over the past 2 decades, we've been having outbreaks almost yearly, and in 2017, there were over 16 districts which were listed as cholera hotspots, and Busia district was one of them. The government, through the Integrated National Cholera Prevention and Control Plan 2017 to 2022, looks at strategies to eliminate cholera by 2030 and reduce death by 90% in 2030, just as guided by the global WHO roadmap. And the plan looks at interventions such as WASH, community awareness campaigns, cholera vaccination, and improving quality of care. But despite that, we continue to have outbreaks within the country. Notably, in 2023, there was a confirmed outbreak in Namayengo district close to the Kenyan border where 21 cases were confirmed. Were discovered, 7 confirmed and 14 suspected. There were no deaths. That is an outbreak area in purple, as you can see. That's Namayengo district. Part of it is an island, and Sigulu Island is where the outbreak occurred from. And Busia district is green, neighboring the outbreak district. So there was therefore need to carry out preparedness assessment for Busia district, which was within the catchment area from Mbale Regional Emergency Operations Center. Firstly, because Busia was bordering the outbreak area, but also it was it's a main business hub within that area, and it's home to key main hospitals within the area. It means there was a likelihood of patients from Namayengo being actually referred for care in Busia district, but also according to Bwire and others in 2017, Busia was actually listed as a cholera hotspot and targeted for vaccination, which was done in 2021. So this was Mbale EOC-led assessment. Our overall objective was to conduct preparedness assessment in Busia district because of the ongoing outbreak in the neighboring district, but particularly we aimed to activate the coordination mechanisms in the district and also to assess key response pillars like the surveillance pillar, health facility readiness, and also other strategies like risk communication and community engagement. In terms of methods, we had an entry-level meeting with the district, a task force, which is the overall coordinating force within the district for any outbreak. And we also did assessment of the cholera designated treatment facilities in the district, and there were mainly 2 hospitals which were designated cholera treatment facilities. We used the Ministry of Health preparedness assessment tool to qualitatively look at the preparedness of the district. This might be a busy slide, but at the district level, we looked at key pillars like coordination, risk communication and community engagement, surveillance, and IPC. Regarding coordination and leadership, the district had an existing district task force, and they had also mapped out partners to know who does what within their district. But the gap which we identified was that whereas these district task forces were implemented so highly during the COVID-19 and Ebola outbreaks, they had not had any regular meetings post-COVID-19. Regarding risk communication and community engagement, the district had the district risk communication and community engagement team headed by the district health educator, and they also had communication opportunities to leverage on, for instance, the resident district commissioner airtime in the radio stations. The gaps were identified in that pillar was that the team, the risk communication and community engagement team, had not yet been trained on how to conduct communication regarding cholera, but also they didn't have information, education, and communication materials specific for cholera. Regarding surveillance, the district had surveillance tools. For instance, the case definitions, these were available at both the district but also at the health facilities, and they had clear channels of communication. Even at the lower levels, the village health teams had contacts of the district health officers and district surveillance focal persons. And then the district had recent training on integrated disease surveillance and response, and this was done by the Ministry of Health. But there were gaps identified regarding cholera SOPs, which had not yet been disseminated throughout the district, but also
please. No
refresher training on cholera. Regarding IPC, there was IPC structures in place, and they had partner support who were very crucial in ensuring that IPC facilities are available at the district. However, these were inadequate. At health facility level, we looked at the designated health facilities to assess their capacities in terms of IPC, and found that, yes, the IPC infrastructure was existent. The health workers were trained on IPC and they had IPC protocols, but the challenge was on logistics. Regarding laboratory, the lab system was up and running. There was a functional hub system which could collect samples from the community level to the regional referral hospital and then further transportation to the Ministry of Health. This was working very well, and we leveraged it on COVID-19 response. However, there were anticipated challenges that sometimes the hub riders were not operating over the weekends, but also the sample collection materials, particularly for cholera, were not readily available. Regarding case management, the district had designated cholera treatment centers based on prior experience, and they had transport mechanisms in place. However, there were anticipated challenges of fuel, but also SOPs guiding cholera care in these facilities was lacking. And also, in addition, essential commodities necessary for cholera care were inadequate. WASH was generally a well-done pillar because they had a recent partner support, and the gaps identified in WASH were addressed. We took an inventory of the logistics in the districts, and as you can see, there were really inadequate quantities of essential logistics which could be used in case they discovered or a suspected or a cholera case within the district. Yeah, I'm just winding. Okay. So some of the best practices we learned from this assessment was that activating of the district task force was very crucial, and the Mbale Emergency Operations Center was able to do that, and the district task force agreed to meet weekly, and also developed a costed comprehensive cholera response plan in case an outbreak occurs. But also we worked with the district to procure some emergency logistics and to be prepositioned in the district store just in case an emergency, a cholera. The cholera response plan, and partners came on board to support in areas of risk communication and community engagement and logistics. We worked with the district to train health workers on cholera case management and in those designated facilities, but also we enhanced the isolation facilities. Some of the isolation facilities didn't even have beds, but we worked with them, with the district, to prepare the isolation facilities. Those are some of the pictorials.
Thank you very much,
of our
Dr.
field
Kurot.
activity. Thank you so much.
Thank you.
Thank you very much, and we invite the next speaker, Dr. Lilian Ngengurunze, from Center of Emergency Response in Burundi, combating cholera in Burundi, please.
Merci beaucoup. Je suis
Thank you very much. I am Lilian Ngengurunze, and I am the director of the Center Combating Infectious Diseases in Burundi, and I'm going to talk about the way we have managed cholera in Burundi, and I'd like to thank all the organizers of this conference. We salute the Russia-Africa cooperation in the fight against epidemics and infectious diseases. The outline of my presentation, I'll begin by giving a presentation about Burundi, introduction, the epidemiological situation of cholera, the organization of the response and the achievements, as well as challenges and future perspectives before I talk about the conclusion. Burundi is a relatively small country with 278,000 square kilometers surface area, a population of about 13 million inhabitants, and that means that where there is an epidemic, there are certain significant risks. We have 45 health districts. We have a tropical climate, and we have rains that are on the increase as we have elsewhere in the region. We have 4 health center regions in the country. Introduction: Burundi recorded its first cholera case in 1978, and since this period we had other cases that were recorded periodically, especially in the areas around Lake Tanganyika. And these are people that live in areas where there's insufficient water and insufficient sanitation facilities. In 2022, some sporadic cases of cholera were recorded in the district of Cibitoke, and in 2023 this outbreak was declared. And then these cases have been recorded over the years, but from 2017 we have not had very many cases, and in 2020 there were few cases recorded. So cases are recorded each year. And what is the epidemiological situation that as far as 2023 is concerned? We had 512 cases in the northern area. In total, we had 1,505 cases. 9 were active, and they were dealt with in the cholera centers, and these were found around the Bujumbura municipality area. 9 deaths were also recorded at the beginning of the epidemic, and these were related to cholera. Some districts have been heavily affected. 9 active cases were managed in the hospital centers, especially Bujumbura North districts. The Bujumbura North district was the most affected. These cases were found in the areas bordering the Lake Tanganyika, as you see on the map. The evolution of the outbreak of cholera, we see that cases increased and decreased during July 2023. But in August 2023, there was an increase, and later on a significant deficit of cases towards the end of the year. However, these cases are on the rise due to the flooding that is being experienced in the countries lately. The distribution of cases that were notified according to the age groups and gender, it is mainly young people that are affected. The youth are mainly affected. How has the response been structured? We have the public health services section that has put in place a process for managing incidences. We also have a national multi-sectorial platform for response to epidemics and other emergencies as far as public health is concerned. We have the emergency response teams in all the health districts. And we also have the IDSR surveillance at the community level. We also have a national platform at the provincial level for prevention of risks and disaster management. We also have community networks, volunteers from the Red Cross who help in surveillance and early detection to follow the first cases and refer them for management to other hospitals. So how the health structures are organized to respond to epidemics, we have the Ministry of Health at the top. Then we have other sections like planning, finance, administration, then working together with multi-sectoral agencies. And these collaborate together to ensure internal and external communication. What activities have been carried out during the response against cholera? We've put in place a system for management of incidents. We have multi-sectoral participation with various ministries. And compared to other years, we have also carried out an action plan to review how this disease has been managed. We look at weaknesses, challenges, so that we can see how to carry out better actions to manage the epidemic. We also have a coordination mechanism, and we have built capacity of personnel as far as diagnostics are concerned and surveillance is concerned. We also manage different cases. The population has been sensitized on measures of prevention against cholera in the different areas. We also do contact tracing and disinfection of houses households that have been affected. We also ensure provision of water in the affected areas, especially clean water. We've carried out an inventory of households. As far as hygiene is concerned, we have decentralized diagnostics with rapid tests, and we've drawn up a strategic plan for elimination of cholera in Burundi, because elimination of cholera in Burundi is possible if we put in place hygiene and sanitation measures as well as oral vaccination against cholera. Nonetheless, we have challenges, and these challenges have been outlined by others. First of all, we have poor access to drinking water in health districts. Then the problem of climate change that brings about flooding and drought. And then we have poor infrastructures and human resources and weak capacity at the entry points in surveillance of diseases from neighboring countries like the DRC because of porous borders. We also lack a multi-sectoral platform, a One Health platform that is operational, and it's not well involved in the management of epidemics and with other ministries do not work in proper synergy with the Ministry of Health. We also have a challenge of inadequate resources in addition to poor access to health facilities in the affected areas. These pictures show you these challenges. For example, the challenge of flooding in most of the areas around Lake Tanganyika. This is a common phenomenon, and we have to evacuate people. So this is another incident of flooding in an area near Lake Tanganyika, which is one of the hotspots for the spread of cholera. Future perspectives. First of all, establish a multi-sectoral One Health platform, strengthening collective and community health, and then advocating for the establishment of an emergency fund that is that can be mobilized quickly, mobilize material and financial resources for the implementation of a national strategic plan to eliminate cholera, capacity building for human resources, rehabilitating entry points according to the international health standards, international health regulation standards, strengthening operational research, strengthening surveillance at community level, and strengthening partnerships. In conclusion, in spite of all the challenges enumerated above, Burundi is determined to face different outbreaks and other transmissible diseases. We also need multi-sectoral collaboration, which is very important to prepare our response to epidemics and the fight against diseases like cholera. I thank you.
Thank you very much, Lillian, for the great presentation. So we've had the presentations on cholera, and we've seen its importance, but we know that beyond cholera, other diarrheal diseases are almost the third leading cause of mortality, especially in the under fives. So we'll have Professor Natalie Shenichinaya, the Deputy Head of the Central Research Institute of Epidemiology in Russia, telling us about acute intestinal infections and typhoid fever.
My task is very small to make a short review about acute diarrhea and typhoid fever. As you all know, как мы все знаем,
As we all know, the burden of acute diarrhea in the world is mostly born on the African region, African continent. But we also have some other countries that are affected by these acute diarrhea illnesses. We also used to have cases in the 70s in Northern American region. And as you can see in the 1970s, the bacterial causes of these acute illnesses were more prevalent. But as time has gone on, the viral causes of these acute intestinal illnesses have increased. And we also in Russia continue to combat these acute diarrhea illnesses, and with the different percentages of confirmation. So on this slide, you can see on the microbiological landscape in the Russian Federation and the percentages. And what are some of the causes of these acute infectious diarrhea diseases? And on the slide, it's very well laid out. When we talk about the African region, we talk about bacterial, for example, Escherichiosis, Salmonellosis, and other bacterial causes. We also have amoebias and of course, as we've talked about, salmonella and cholera pose a bigger problem and a bigger threat when we talk about the African continent. And in children, we have noticed that the children tend to have more viral causes for the acute diarrhea infections. And as you can see, as the age increases, as you can see on the map, the causes for the viral causes actually are more confirmed as the age increases from children to adults. And it is also seen on the graph that for the elderly patients, they have more bacterial agents that cause these acute diarrhea diseases than the children. And lethal outcomes from children in the African continent is mostly in the countries that are located in the equatorial region and also in certain peninsulas. So this is actually a big problem, particularly for these countries in the equatorial regions, even up to this day, as you can see on the map. And this is because when there is no access to clean water, to clean sources of water, for example, we end up seeing the main outbreaks of these acute diarrheal illnesses. The main causes and the main reasons is unsafe water sources, unsafe sanitation, other causes also come in with difficulty in accessing water sources. We talk about things like non-exclusive breastfeeding, and we also, and as we've talked about, most of the problems are around absence of proper hygiene, and this causes spread of these acute intestinal infections. And you also see some pediatric problems, for example, child stunting, child underweight, premature births, so that is the giving birth of children with low birth weight. We also see vitamin A deficiency, especially in the younger population. So laboratory diagnostics have enabled us to be able to discover and experiment, examine a wide range of these causes. And many kinds of these investigations have been done. For example, we have multiplex PCR and some other that are able to check immunoglobulins to these causative agents. And when we talk about PCR particularly, I want to pay attention to multiplex, which is able to, for example, find the causative agents of Salmonella, Shigella, and apart from this one, we also have our normal classic methods of diagnostics, which still remain relevant to this day. And as already understandable, they really do help us to also isolate microbiologically and also to find out the sensitivity and resistance to antibiotics. I'm not going to delve too much into this algorithm because there's no time about it. We know that it's a group of professionals that have gathered here. But when you talk about this, diarrhea tends to have symptoms of inflammation. It can increase the temperature of the body, and in a space of about 2 to 3 days, already clinical symptoms can be sometimes even seen in certain acute infections. And as a result of this, we sometimes notice in patients electrolyte imbalances, intoxication, and this can even last from 2 to 3 days too. And this needs us to institute rehydration therapy usually, but also antibiotic therapy. But when we talk about bacterial diarrhea, here we have to always involve the laboratory methods of diagnostics to be able to confirm particularly what we're dealing with. And most of these acute diarrhea diseases have different classifications. We have the World Health Organization classification, which you can see on the map, depending on parameters and the clinical features. And we are able to now differentiate between the high and medium and low levels of dehydration levels, and it gives us the spread and the strength of the disease. And also, when we look at the other classifications, we're able to look at parameters like loss of weight, and depending on the percentage of loss of weight, we're able to better classify the different levels of these acute diarrhea illnesses. And particularly, the Russian classification is from the scientist Pokrovsky. It was done in 1978. And more other parameters that are used in this classification are the frequencies of diarrhea, frequencies of vomiting. There's a real wide range of parameters and clinical features that are responsible for classifying these acute diarrhea illnesses. And depending also on the dehydration, they're able to now get a better parameters on how to institute the therapy and how to create fluid replacement. So the replacement of these fluids should be done at least within the first 4 hours, but if it's possible, to be introduced between the first 1 hour, so that we can have positive outcomes. And after that, we carry out also replacement of ongoing losses and also replacement of normal daily requirements for that person or the patient. There is a full range of substances that we use as oral rehydration salts or solutions. And at this moment, we talk about the different kinds of osmolarity that have to be contained in these substances. And as you can see, the composition of this OPC is recommended by the World Health Organization and UNICEF, and it has to be with reduced osmolarity. And vomiting is one of the main causes why we institute these oral rehydration solutions. And depending on how much it is, the rehydration therapy can be then introduced in the right measures, depending on the different solutions that are available on that table. They're already shown on the slides. These are salt solutions for rehydration. And they are used in different stages. So depending on the level, we can use trisol, quatersol, and depending on how much has been lost, as I've already said, we are able to rehydrate as much as is necessary. And some of these solutions, some of them have low levels of sodium chloride, others have higher levels, and some of them actually, we are moving slowly by slowly to even discover more sodium components and combinations and percentages that can help us to get accurate rehydration. So Salmonella also poses one of the highest risks or the highest threats as a pathogen. And with the help of antibiotic therapy, we are able to counter and combat salmonellosis. This is the same thing for Shigella, as you can see represented on the table. And different antibiotics will be more important in different infections. And of course, the laboratory diagnostics to sensitivity to the antibiotics plays a very important role in this classification of what would be the best treatment method. The finding out of which strains have resistance, the testing of the populations also play a very important factor in these antimicrobial elements. And of course, we want to speak about the prophylaxis too. Good hygiene, hand washing, adequate water sources, sanitary epidemiologic measures for our water sources and the water supply. Of course, when we talk about prophylaxis, there's also vaccine development, especially towards the children. And effective and safe vaccines have already been created for certain infections like typhoid fever and cholera and the like. Let's talk a little bit about typhoid fever. It is an acute diarrhea illness, of course, and some of its mechanisms of transmission include fecal-oral route. We also found out that it can also be spread through household contact. And as you can see on this, typhoid fever are in the African continent and slightly also in the continent of Asia. And the experience has also shown us that the causative typhoid have different resistances to antibiotics. And so this also should be taken into consideration when we talk about the therapy and treatment. I'm not going to speak too long about the pathology of pathogenesis of typhoid fever. I think it's a very common topic, and we do know about how it replicates in the body and the different stages of how it moves with ulceration of the pairs, patches. This causative agent then accumulates in the lymphoid processes of the intestines, and this comes to the formation of necrosis of the affected intestine mucosa, and as a result of that we can even have perforations, we have bleeding, and sometimes even fever can be one of the first symptoms, and this easily spreads. And on the second week, we are able to see a wide spread of this Salmonella typhi, up to which we are able to see splenomegaly and necrosis in the liver too. And you can see in the, I believe that the color of skin also on the African continent is a little bit different from ours, so it makes it harder to even see the clinical features on the skin. But some of the differential diagnoses include other infectious diseases with similar clinical pictures, for example, malaria, amoebiasis. And we have seen that they have clinical features like high fever, which moves gradually in increasing form. And this is the classical manifestation of typhoid fever. And we also talk about enteric fevers, where we take samples from bone marrow, sometimes urine cultures, and also feces cultures, and blood cultures, where we're able to identify and isolate the causative agents of this typhoid. And of course, these laboratory tests are always oriented towards serologic methods sometimes, and sometimes they are actually not as informative as we would have wanted them, despite the fact that they are widely used. And this is because of the low level of bacteremia that sometimes exists with these acute infections. And as a result of that, it needs us to go to even other methods like PCR to get better determination and better isolation of the microorganisms. I want to also, again, I want to talk about the big range of antibiotic treatments and options that are available for typhoid fever. And I want to say that in each region, there is an antibiotic that is more specific, depending on the population foci. But because there are different strains of this Salmonella typhi and different resistances in different locations. So right now, as we speak, there are different strains that are being studied in different laboratories due to the locations. So you can look at the slide. You're going to see the scheme of the therapy and the treatment. So you're looking at agents of limited usefulness for the high prevalence of multi-drug resistance. So this problem of drug resistance is a big problem. And another problem that we also have with this typhoid fever is chronic carriage of Salmonella typhi. And it's hard to sometimes even discover or identify such individuals. And it's normally discovered in reconvalescence, definitely. Despite the fact that some of them go through a long periods of antibiotic therapy, they still maintain that courage, and over a period of time, it manifests again. Vaccination against Salmonella typhi. It's mostly in endemic areas, as recommended by the World Health Organization, that vaccination takes place. And here is the message that we have continuous changes in these acute intestinal infections. And of course, they have a strong rate of transmission and migration in the populations. And sometimes even when we talk about these diseases, what used to work 2-3 months ago may not work in the following 3 months, depending on the sensitivity to the antimicrobials. And I want to thank you all for your attention.
Thank you very much, Natalia, and all the other presenters. And thank you very much, the audience. Sorry, we've had to overshoot. I don't think we should stand between the group and lunch anymore. So unfortunately, I think we shall not be able to take any questions or discussion. We'll end it here, and you can interact with the presenters during your free time. Thank you very much.
39, please. Если что, второй канал для перевода. Да, на русский. Forty.
Включается.
41. 42.
So, dear colleagues, we have to wait probably 5 minutes. I believe that some people, some of our colleagues will coming soon. 5 minutes. So, dear colleagues, let me open the afternoon session. Our session will be devoted to some effective steps against social economic infection diseases. And I'm proud to introduce the first speaker, Dr. Dmitry Kireev from Central Institute of Epidemiology. He will talk about some specific organization step and epidemiological follow for the AIDS. Please.
Thank you. Thank you for the introduction. Dear colleagues, I'm very proud to be here and to participate in this first Russian-American conference. I am absolutely sure that this conference will give us, as a result, our joint collaboration, which will be useful for both sides. Yesterday, academic Kuterev said that one of main goals of this conference is to exchange our experience. So I am very pleased to share with you data about some features of epidemiological surveillance, and also give you some data about current situation of epidemic of HIV infection and hepatitis B and C in Russian Federation. I'm sorry, I will continue with in Russian.
So the main purposes of epidemiological surveillance are to be able to assess the epidemiological situation, monitoring the coverage of the population, looking at the trend, and to also look at the prevention possibilities in the hotspots. We also look at the territory and the treatment and the anti-epidemic measures that can be taken through epidemiological surveillance. And this is mostly seen in the foci of outbreaks. I also think that plus or minus, one of the goals also of each country is how to be able to get to that goals that we have. So as you are aware, the Russian Federation has a very large territory, more than 17 million square kilometers, with 9 federal districts. And in every federation district, there is a particular government and particular systems in place for monitoring and also treatment of the population in that region. And of course, all of these work under the Rospotrebnadzor, which does the general monitoring on a national level. So we want to look at the HIV screening. The citizens are divided on two groups. The first group is for people who take up periodic voluntary HIV testing for themselves. For example, pregnant women and husbands and sexual partners of those same pregnant women. We also see sex workers that sometimes voluntarily do the HIV testing. And then there is also a second group of people that have to take mandatory testing. And for example, this includes the donors of blood. And at every donation of blood, they have to mandatorily check for HIV using PCR tests. Also on top of that, we have medical workers and also those that work in the laboratories. We have people that take part in surgical departments, and also foreigners that are in the country of Russia also have to take mandatory tests. So Russia holds the biggest number of testing and tested individuals, and this stands at about 48 million people who have been tested for HIV. And this is able to enable us to have early detection and treatment for that. So you can see this algorithm for diagnosis is a little bit difficult, but it's specific in the sense that it depends on the screening laboratory, depending on the different types of methods. For example, we have immunoenzymatic methods that are used, for example, ELISA, the 4th generation, and this is able to enable us to identify the antibodies, and even other tests help us to identify the antigens. And so, of course, these results are sent to reference laboratories where the infectious disease specialists are able to assess the results, and sometimes these specialists are able to even find changes in collected data and help to analyze it. And another criteria is the laboratory confirmation of this HIV infection testing that is done. And this, as I have already mentioned, depends on the territorial Raspatrabnadzor center in a particular region. And this has to be in a physical presence of a patient. And in the Russian Federation, the HIV testing is completely free. And I want you to also pay attention to so in 1994 is the first time that we diagnosed HIV in Russia, so it came a little bit late. And in the space of the first 10 years, it wasn't that much noticed in terms of diagnosis. But unfortunately, the past 20 years, we've been seeing an increase of cases of HIV infection, and this is due to many reasons. One of them being that there is increased number of people that take in opioids and narcotic substances. And as you can look at the graph, we got a trend which was at the highest in 2015, where we had the highest number of diagnosed patients. And we normally take parenteral therapy for these patients. And after 2015, we are seeing a trend of reduction in HIV. And we have also constituted parenteral therapy, which is free for all patients. And we know that there is more than there's more than 17.7% reported intravenous drug use cases that contribute to HIV infection. And we have also realized, as you can see in the graph, that 77% of those newly diagnosed are always with heterosexual contacts. And the different colors show the different routes of transmission. And when we look at now the prevalence and the spread of HIV infection, HIV infection by December of the previous year, we had reached 817.6 people per 1,000 in the Russian Federation. But as you can see in the global spread or the global prevalence, there are particular regions in Russia that have a particularly higher numbers for HIV infection and its diagnosis, as you can see on the graph on the darker colored areas. And this, as I've already mentioned, is because of the increased drug use. It's also because of increased sexual spread. And when we look at the age of those that are infected, we have seen that the group of people from 35 to 50 years is most affected and most infected with HIV. So we look now at the cascade of HIV care in Russia. So Russia, just like many other, so we also joined the 90-90-90 strategy as it is in other countries, so that we can be able to, as much as possible, to identify and diagnose HIV, so that we can also successfully decrease its spread. And we believe that we have gotten to certain milestones. Of course, as you can see on the graph, those that are diagnosed are a little bit more than those that have been linked to particular specialized care. And so we still have a problem in that age. But we also have many others that are on antiretroviral therapy and others who are on other forms of therapy. When we look at the surveillance of molecular genetics, when we talk about now hepatitis and other diseases with viral etiology, most of this molecular genetics shows us that the drug resistance is mostly in particular areas. And we also see the same trend with nosocomial infections, for example, as portrayed on the red colored areas. And as we speak right now, many of the institutions that are involved in testing and in studying of these viruses continuously, they continue to take reanalysis of different data that is given to them. And through this data, we have been able to see the past situations, the current situations, to be able to better understand what will come. And we are able to also look at the turnaround time of certain tests that are done on these people that have HIV. So now I want to look at the screening program also of hepatitis B and C. And as there are also two categories of screening. The first category, it's for people who we recommend to undertake testing of antigens of hepatitis B and also anti-HCV antibodies. And you can see them, the groups of people. And the second category, who we also secondarily recommend to take regular tests for hepatitis. They take up antigens of hepatitis B and C, and as you can see, those that category is also displayed on the screen. And the algorithm of the diagnostics for hepatitis B and C, especially in the suspicion of someone who might be having any liver disease, is put before you. So the infectious disease specialists are the ones who start this process when they have identified a patient with a particular liver disease. They take up the tests for PCR, for other sorts of examination, and I want to compare it with HIV, because every HIV case is reported particularly to raspatribnazole in order for this diagnostic and this reporting and data to be analyzed very well. And for every case that has been confirmed, we're able to get their contacts, and we talk with the families or the contacts of these people to come and also have testing done for them. And also, we continue to do hepatitis B and CV identification and analysis, especially using other forms of laboratory diagnostic methods. When you look at the cases of acute and chronic hepatitis B, it started at the end of the 20th century in Russia, and in 2006, they started a project in the Russian, a national project, which was supposed to be geared towards HBV vaccination. And after a number of years after this project was started, we can see that the number of patients really decreased. And right now, as we talk, there is voluntary vaccination that is carried out both for the young and also for the adult population. And of course, the morbidity has a trend in which it is decreasing. Yes, and it's decreasing in trend as we talk about morbidity, but we continue to monitor that as we study it. HBV, hepatitis B prevalence in the Russian population, as you can see again, we continue to see these results are results from serological studies that were carried out in all different regions of the Russian Federation. So on the right, you can see also the impact of the hepatitis B vaccination on infection in 2008. And we have also been able to identify that there are some regions that are hyper-endemic for this hepatitis B in the Russian Federation. And depending on these percentages, we consider to we're able to create maps of endemic areas. And in total, the number is about 37,221 volunteers who gave their and so let's look at genetic surveillance for this hepatitis B virus. It's classified depending on genotypes, and as you can see, different genotypes have different also primary drug resistance. Of course, when we talk about the prevalence of hepatitis B drug resistance, it's not too much as we look at 2010, and it was totally and mostly reduced to 0.2% by the year of 2018. And so treatment becomes more and more effective as the years go by. And of course, this is this multi-drug resistance is because of the different strains that continue to come up, and they would need effective therapy. When we talk about the morbidity of hepatitis C, you can look at the graph and you can see the dynamics of the incidences in the Russian Federation from the beginning of from the beginning of the 21st century. You can see the trend, and this is mostly this increasing trend is mostly because of the increased parenteral contacts. And some of the other things that are causing the acute hepatitis C to decrease is because of the improvement of the diagnostics and improvement of economies in the Russian Federation. Unfortunately, for the chronic hepatitis C, we still continue to see a high level of its incidence. We continue to see more people that have been infected, and so up to this moment, we are still trying to combat that because it's important. I'm going to skip a few slides. We're going to look at the medical preparates that are important when we talk about this hepatitis, and also how they are instituted in different regions of Russia. And I believe that even after this session, we can be able to talk about the medical treatment. It's very important to talk about the start of a Russian national hepatitis C elimination program in 2022, and it was geared first towards to hepatitis C, and we hope that by 2030 we'll reach that goal. And how do I want to complete my talk today? It's with genomic surveillance. I want to speak about the fact that the main task that we have right now, it is the integration of genomic surveillance into the structure of epidemiological surveillance. And we in Russia were already able to look at particularly important aspects that are necessary for such. The first is regulatory documents, because these are able to define the functions and scope of genomic surveillance in our countries. The second factor that I think is important in this is the network of equipped laboratories and people that are able to use it to be able to identify the etiological agents with their sensitivities. We also need to validate bioinformatic packages and programs and scripts so that any kind of epidemiologist anywhere in the world could be can be able to use the information that we have gathered. And also creating a national database that allows us to put together all the genetic and epidemiological data that we have in a standardized form, and to be able to also carry out operation and retrospective analysis. I believe that when we pay special attention to genomic surveillance, it will increase our effectiveness and our accurateness in epidemiological surveillance in our country. Thank you so much for your attention.
Next speaker, who's Balde from the Research Institute for Applied Biology in Guinea, and he'll be talking about prevalence and molecular genetic characteristics of HIV, hepatitis B, and hepatitis C in pregnant women. You'll have 15 minutes to present your talk.
Chair and members, it's an honor for me to present to you results of research. These scientific results regard the prevalence and molecular genetic characteristics of HIV, HBV, HCV in pregnant women in the Republic of Guinea. We all know that HIV, HBV, and HCV are important problems in health around the world. And 170 million people suffer from chronic viral hepatitis C, and HIV is 30 million. The co-infection of HVC and HBV is indicated on the chart. Genetic heterogeneity of HBV and HCV and HIV depends on the viral load and the function of the virus. The virus in HCV and HBV is indicated on the chart you can see. We have HIV 1 and 2, which are widespread in the world and divided into 3 groups. The group N has all the variants of the virus, and these circulate in various forms. The means of transmission that is most common is with the vertical transmission. This vertical transmission is considered as the most significant in Africa and where this virus is most prevalent. Republic of Guinea is located in the western coast of Africa with an estimated population of 12 million inhabitants. It is one of the least developed countries in spite of its mineral resources. Currently, a little part of the GDP is reserved for health, and the country is a 174th position as far as GDP is concerned. And as far as investment in health is concerned, the country occupies the 150th position. Guinea has a number of people who are being treated for HIV, and they use ARVs. And Guinea has approved other treatments for ARV. This treatment includes certain drugs that are given to patients with HIV and those who also have hepatitis B and C. The objective of our research is to study the prevalence and characterize the hepatitis B and C and HIV strains. We had objectives: determine the prevalence of biological and serological markers of HIV, as well as those of viral hepatitis B and C amongst pregnant women in the Republic of Guinea, looking at the demographic and social characteristics. Number 2 is establish genotype profiles of HIV, HBV, and HVC amongst pregnant women in the Republic of Guinea. 3, study the structure and diversity of drug resistance mutations of HIV amongst pregnant women in the Republic of Guinea. In order to carry out these objectives, we carried out a study on 1,810 pregnant women in different regions of Guinea. We also had 60 women who were male partners of these women who were part of the study. Here are the regions where data was collected. These include the region of Conakry, Farana, Kanka, and Macenta. The age groups of the people studied was between 13 and 55 years. The marital status of the respondents, the married women were the biggest percentage, with 52.8%. Regarding the professions of these respondents, we noticed that the housewives and the business women were predominant. The methods used for this research included the ELISA technique produced in Russia to be able to help us to get the serological markers of HIV virus and hepatitis B and markers for the hepatitis C virus. Where the viral load was found, we were able to do sequencing of these fragments. Sequencing for hepatitis C virus as well was done. So we carried out a number of studies. Regarding serological markers prevalence, when it came to HCV, it was higher than the serological markers of HIV and HCV. And then HBV was predominant compared to HIV. So there was a difference between serological markers of hepatitis B and the molecular markers of hepatitis B. On the screen, we see the distribution of molecular, biological, and serological markers. The molecular biological markers, we see that there was 10% in terms of viruses that were observed. Then when it came to the rural and urban areas, we did not find very wide prevalence or difference. When we compared the molecular biological markers in the different cities, it was seen that the much from the other cities, and also the HIV DNA, as indicated, had a higher percentage and was more prevalent in the Farana region. And then the HIV RNA had a higher incidence in the Kindia region. We did not biological markers according to age. HCV was more representative in the 13 to 17-year age group. And then if you look at molecular biological markers according to occupation, it was much higher amongst women with other professions, with the exception of midwives. And then DNA of HIV was higher amongst tailors than other professions. And a significant difference was observed. The incidences amongst individuals, it was higher amongst all these individuals with the exception of the hairdressers. Significant difference as compared with other professions. And then we looked at men who confirmed having sexual relationships with these pregnant women and realized that the markers were higher amongst pregnant women. And there was not much difference with HIV RNA. This slide shows the genotyping of HIV-1 in the group that was examined. According to this study, the incidence of subtypes of the recombining forms of the HIV-1 in the group examined shows that there was a high percentage of 39.18% in the middle group. Regarding HBV, it had 92%, it was the biggest group. The other subgroups are also indicated. This slide shows us the phylogenetical analysis of the genotypes. Regarding the genotyping of identified isolates, we are able to find 4 subtypes. The incidence of drug resistance, HIV drug resistance mutation and distribution of resistant virus strains. 26% of pregnant women showed drug resistance to ARVs. And we also had 50% indicated on the chart for other inhibitors. And then drug resistance mutations that were most frequent amongst pregnant women in the Republic of Guinea. We have these indicated on the chart, and the incidences of HBV mutations up to 86%. Then the mutations that were clinically significant in the region, we had mutations that were clinically significant to different drugs, and this was linked to resistance to certain drugs, and especially linked to HBV. Mutations linked to vaccines. We also had the substitution of amino acids in the region. We had 12 substitutions that were found within these 3 genotypes. Regarding the substitution in this region, we had 67 positions that were identified regarding the different genotypes. And these are the polymorph substitutions of HCV isolates that were identified. HCV in Farana, we discovered certain polymorphs that were resistant. I am not going to read the conclusions because of time. I thank you for your attention.
So, dear colleagues, let me introduce the next speaker, Dr. Anna Panova from Federal Research Institute of Virus Infection, brand name Virom, Russia. And the title of this talk is The Modern Approaches to Monitoring and Laboratory Diagnosis of TB, tuberculosis. Please, 20 minutes.
Здравствуйте. Greetings, dear colleagues. My name is Anna Panova, and I thank all of you for the opportunity to be part of this conference and to share experience of the Russian Federation about the modern methods of diagnosis and testing of tuberculosis. So tuberculosis, even in the current time, it still remains a global problem. It remains a biological and economic threat, not only in the Russian Federation, but also in the African continent. Tuberculosis is one of the leading causes of death in infectious disease outbreaks. And tuberculosis is one of the main causes of deaths, and it's one of also the highest that has multi-drug resistance when we talk about its causative agent. So it's important to note that in the modern time, in the Russian Federation, in the African continent, all over the World Health Organization, so the epidemiologic situation of tuberculosis is getting worse and worse every simple time. The morbidity it continues to worsen. It's very important to note that in the Russian Federation, we are having decrease in the indicators of anti-tuberculosis measures. And as you can see that in the Russian Federation, we have 30% of a decrease in TB incidence compared to 2015. And very recently, Russia has moved out of the list that was endemic for tuberculosis, list of countries. So the main problem in combating tuberculosis everywhere in the world is actually the fact that tuberculosis has a lot of multi-drug resistance. A part of all the patients in tuberculosis usually and also there's a bunch of patients that have tuberculosis that comes together and joins with HIV infection in combination. And so the Russian Federation is trying to get to a level where it's able to have very fast tests and to be able to get quick results and to also study the resistance of this etiological agent to antimicrobials. So modern epidemiological situation is really based on the effective monitoring of tuberculosis and monitoring. So the monitoring and surveillance of tuberculosis is geared towards particular functions, and it is monitoring and it is geared towards monitoring, obtaining quality information. Some of the main principles of effective monitoring for tuberculosis involve continuous systems of testing, obtaining quality information, the development of implementation of administrative decisions, and also analysis of all information. The Russian Federation uses the surveillance system as a very important national use to detect tuberculosis, and this is done both on the federal level, and I want to pay attention to the Federal Register of Tuberculosis Patients, which was started in 2017. And up to this moment, we have all cases that were ever found in the Russian Federation, all cases and the results of their treatment. It has all cases, and it helps us to fully analyze the data. It's also important to note that all the statistical indicators of tuberculosis in the Russian Federation are based on the registration, on the registered information. For example, how the morbidity, the lethality of this infection. And when you look at this slide, you're going to see the scheme of organizing the monitoring for tuberculosis. And so this monitoring of tuberculosis in the Russian Federation exists at a number of different levels. For example, at the points of care, of health care, and it rises up to the federal level, where we have the Raspotrebnadzor that takes up administrative implementations and decisions on the control of this infection. On this slide, we see the results of epidemiologic monitoring of tuberculosis, which are based on the registered information for 34 years. So we look at the current situations of tuberculosis, which continuously has been changing over the years. In the 70s and in the 80s, we saw a decreasing trend in the death of people from tuberculosis. But then in the 90s, during the times of economic crisis and stress, in Russia, we then saw an increase in the number of patients that died from tuberculosis. And the peak was seen in the year 2000, when the level reached 90,000 out of 100,000. But for the past few years, the tuberculosis eradication has become a priority for the government also, and anti-tuberculosis measures have been given a lot of emphasis, and we have seen that they have decreased the death of people from tuberculosis. And you can see that the level has decreased, of course, more than it was in the 70s. And even the Russian Federation is no longer part of those countries that were having high numbers of death due to tuberculosis. However, as you can see on the graph, not only in Russia but elsewhere in the world, we continue to see multi-drug resistance of tuberculosis, and also the co-infections with HIV. And it's a global problem that we can see has been also increasing in its trend up to about 80%. And it's important to note that all the regular results that we get from genetic monitoring of tuberculosis, Russia has shown that in all regions, in all places of Russia, the Mycobacterium tuberculosis genotype has been reducing. That genotype is called Beijing. So this particular genotype is associated with multi-drug resistance, but it has been reducing, and it has been proven that multi-drug resistance is mostly due to the Beijing genotype on the Russian territory. And so it is very important to have effective laboratory diagnosis for tuberculosis in Russia. So when we talk about this laboratory diagnosis of tuberculosis, it has also become a priority in our healthcare system. And it's important to note that diagnosing and finding and treatment of patients is free for all citizens of the Russian Federation. Every year in the budget of the government, there is a financing that is given for all the diagnostic efforts and also for the medicamentous preparations that are given for the patients with tuberculosis. The algorithm for laboratory diagnosis in the Russian Federation is regulated by the government itself. There is a society and a community of people that take this into. And in 2014, it is when we started a modern method of laboratory diagnosis, and every year it is always is always improved. So in the Russian Federation, one of the most important things is to be able to notice and determine this microbacterium very, very fast using the genetic methods and differentiation and determination of the phenotypic drug sensitivities and resistances. And this means that we have to be able to receive cultures from different areas to be able to detect the reserve samples that have been received and to be able to find out their sensitivities. And so as you can see on this algorithm, it moves in the anti-tuberculosis dispensaries up to the primary healthcare points. And there are different levels of laboratory network and of the anti-tuberculosis clinics. So this starts right from the levels of the hospitals, the points of triage, and you can see we have anti-tuberculosis dispensaries both in the different regions, and on the federal levels we have research institutes that are in charge of also this laboratory diagnosis of tuberculosis. But at the end of all of it all, the main role is held by the National Reference Center for Diagnosis of Tuberculosis. And this is an initiative that came just a few years ago. Dear colleagues, I want us to note that in the Russian Federations, in all places, we are conducting fast molecular tests and genetic research for tuberculosis. In the Russian Federation, we are also having application of almost 297 TB laboratories that are in the same effort towards eradication of this. And on top of this, I want to talk about the system that we had even in the old time of the Soviet Union. So this system is responsible for diagnosing tuberculosis and recognizing the agents for tuberculosis, and also to be able to detect the mutation of different strains and to also see their sensitivity and resistance. So the phenotypic tests have also been in the country for a number of years, and this is responsible for allowing us to be able to identify which medication is effective for particular strains from mycobacteria. And of course, there is a very major role for the scientific community in helping us to identify all this information. We still continue to do scientific research, which is geared towards getting better analogs of imported substitutions. So we want to get substitutions for systems like the Gene Expert system from the USA, and this project would enable us to completely get our own substitutes and our own analogs for these imported systems to be able to better carry out our own processes. And at this moment, we are also trying to work on import substitution for cultural methods. For example, the system of Bactec MGT from the USA. So with this project, if we are able to get better imports and better analogs, we are able to get cheaper and faster results from these systems. Dear colleagues, it's also important to note that in Russia, in the algorithm of diagnosing tuberculosis, we have immunological methods being used. And these are considered additional methods in identifying tuberculosis. And so we have recommendations both from the World Health Organization and also our own domestic immunological tests that we use. And using the possibilities of the Raspatribnadzor, we are able to utilize these systems to diagnose tuberculosis. In the current times, in the current times, we are also moving ahead with sequencing of the strains for the Mycobacterium tuberculosis. And also a new generation is also allowing us to be able to do genome sequencing, which enables us to get results with more sensitivity and more efficiency. And this project is called the Next Generation Sequencing. And we have been able to already find 7 new mutations of multibacteria. And also, these tests are very important because, as I already mentioned, they're able to improve the treatment and to improve the epidemiological surveillance of these particular infections. I want us to also note that in the current times, this next generation sequencing is carried out in the different research institutes. But it is our domestic methods of sequencing that still remain prevalent. For example, the target methods. And these allow us to carry out these investigations with the sputum, targeted NGS sequencing, and to be able to determine the Mycobacterium DNA, to be able to differentiate the different sensitivities also. And one important thing is we want to also make sure that these methods are available for clinical practice for every hospital and for every institution. It's also important to note that the modern laboratory diagnostics are very important for creating international, for collecting bases of data about microorganisms. And this is very helpful for us in identifying the different microorganisms, not only for tuberculosis, but also for prophylaxis against other etiological agents. We believe that through cooperation, even in the area of tuberculosis, in the area of global pandemics, in the area of multi-drug resistance, we believe that international cooperation plays a very important role. And I want to end my presentation with these words of the President of the Russian Federation on the first ministerial conference in 2017. He says, and I quote, "Only together, by joining forces, will we be able to counter the threat, which is undoubtedly global in nature." Thank you for your attention.
Vient de parler d'un sujet, d'un test qui peut rendre plus de sensibilité médicament, sensibilité pharmaceutique. Ce serait intéressant comme sujet de recherche collaborative. J'aimerais passer la parole à Guéré de l'Université de Sutema qui va nous parler aussi de la résistance résistance aux médicaments. Vous avez 15 minutes aussi. Merci beaucoup, monsieur le modérateur. Bon après-midi, chers collègues. Je suis Mathias Bogueret. Je suis IDR de Bustema Université. Je suis supposé aussi travailler dans la région d'Ankole, surtout Kazo Chirvura, Uhejo et Ibanda. L'Ouganda, c'est un des pays qui a ce fardeau lourd de la tuberculose dans le monde. Et d'après l'enquête de prévalence de tuberculose,
with a cough for more than 2 weeks do not seek health care. There was an estimated 1,500 people with TB. However, we see low notifications as far as DRTB is concerned in the country. This could be due to a number of reasons, but as we will see, we discovered some of the reasons could be poor health-seeking behavior. Yes, in a Kazo district, we had noted that there was the case notification rate was going down, despite records showing that there were TB cases and also rumors from the community showing that there were people with these TB symptoms in the community, but they were not coming up. And the reason was because of stigma, and this could be probably because TB is associated with HIV. And for this reason, we set out to find people with TB Can you support me to move the slides, please?
Go forward, I think. A couple of steps.
Yeah, go forward. Yeah. The objectives. Yes, one of the objectives was for us to engage the community, having heard from rumors that there were people with signs and symptoms of TB, but they were not seeking care. The other one was because people were telling us that there was stigma in the community. We wanted to make sure that the community is sensitized about TB so that they don't see it as a crime to seek care. And the other one was to find those people that have TB but were missing, were not being diagnosed. Yes, so what did we do? We held micro-planning meetings with the district leadership, and this was particularly the district health team of Kazo District, together with the local implementing partner, which is facilitated by USAID, and that is TASO. And during these micro-planning meetings, we were deciding plans of action. How would we proceed? We reviewed the TB register, which is for the district, And it was detailing for us where a majority of the TB cases were coming from. We reviewed this for a period of 1 year, the cases that had been diagnosed, and we did hotspot mapping. However, again, during that micro-planning meeting, we determined which logistics we needed, who would provide that, and we had agreed that the Ministry of Health and Kazo District would provide the resources, sputum mags, sputum tools for data collection, and the implementing partner was supposed to facilitate the teams that were supposed to go to the field to sensitize the people, but also pick sputum samples from the population for diagnosis. Yes, during the hotspot screening, 3 sub-counties were identified as hotspots, and we decided that we shall do a door-to-door screening, and also at the same time doing community engagement to sensitize the community. This was through the radio, but also holding community dialogues where TB survivors could talk to the population to dispel the myths about TB so that they could encourage the population to come and seek services. Yes, we decided to pair a VHT and a professional health worker. The professional health worker in this case was either a clinic officer, a nurse, a laboratory officer, so that they could go to community. The reason here was that the VHT or the community health worker in their villages knew the homes where these people could be, that were having signs and symptoms were, but also for the health worker to use their knowledge to make sure that they screen based on the intensive case finding guidelines of the Ministry of Health. During this process, people were educated in their households, and those that had signs and symptoms of TB were evaluated in their households. Sputum samples were collected, and these were transferred to the only hub in the district based at a health center for analysis. We reached out to 524 households, and 1,526 people were screened for TB. Out of these, 220 were presumed to be having TB, and 15 of the 220 were diagnosed to be having TB. However, interestingly to note was that out of those 15, we had 7 people diagnosed with DRTB. These were people that were in the community. They were having a TB, but they were not seeking care. So this intervention of pairing the health workers and the VHTs or the community health workers helped us to fish out these people and put them on treatment. The 13, out of the 15, 13 were from one sub-county. And this is a sub-county that had been consistently registering huge numbers of people. But this time around, these people were diagnosed, they had not come out to seek medical care. Yes, in conclusion, I want to say that pairing of community health workers and community engagement in areas where we think there is a stigma is very important to help us to reach out all those people that could be having a TB, but they are in the community. In a TB, much as we are dealing with so much in passive case finding, it is important for us now to delve into active case finding by going to the community and picking out the people that are infected with TB so that we put them on treatment. If we don't look for TB, TB will find us. Thank you very much.
Thank you, Matthias, for saving us about 4 minutes. The next, we'll just shift gears a little bit to malaria, and we will have Dr. George Passy from Busitama University as well, talking about the geospatial epidemiology of malaria in Uganda.
Yes, thank you very much, Chair. Good afternoon once again. My name is George Passy, and I'm yet here to make another case for the importance of geospatial analysis in infectious disease control. Presenting works on malaria, a protocol we've developed called Development of Geospatial Temporal Surveillance and Characterization of Malaria in the Changing Climatic Conditions in Uganda, GTX MARC study. I'm happy to say that the PI, Professor Peter Olupot, is with us, a champion of research, capacity building, who has for the past 1 year developed capacity on geospatial epidemiology in the region. Malaria is a parasitic infection caused by a protozoa, Plasmodium. For species, almost the age of the human species has changed over the years. And if we were to call it different names, I think those different generations would call it something different. To begin with, the global malaria targets. The vision of the global malaria community is embedded in two key documents, policy documents. One is Sustainable Development Goal 3.3 and the Global Technical Strategy for Malaria. These have ambitious aims of bringing down malaria burden in 2030 and ambitiously bring the burden of mortality morbidity by 90% by this particular year. And in line with that, there have been gains since 2010. About 1 million lives saved, 100 million cases averted, and several countries have eliminated malaria in their regions. Well, this huge success largely is attributable to key tools. One is the better testing and treatment through the affordable medicines facility that subsidizes artemisinin combination therapies, as well as availability of rapid diagnostic tests through the 3T policy, the test, treat, and track policy. Secondly are the preventive tools. The use of long-lasting insecticide-treated mosquito nets, indoor residual spraying. These have greatly reduced malaria for the past decade. However, this global trend doesn't reflect the picture in the WHO Afro region of Africa. WHO Afro region. That despite this substantial reduction in malaria incidence and mortality globally, Sub-Saharan Africa largely reports no decline in some countries or a resurgence of severe malaria cases. And rightly so, PFAS, para-malaria, accounts for the largest burden in this region. This is a species that causes severe malaria in many of the cases and death from malaria. 10 countries in Sub-Saharan Africa account for this burden. About 70 to 80% of the burden is accounted for by 10 countries in Sub-Saharan Africa. Uganda being among them. Over the years, there's been an oscillation. I mean, it's third, fourth, sixth, but for the past decade, it has remained within this bracket of 10 most burdened countries worldwide, seeing us going off a trajectory of control down to no control. An example in point is Papua New Guinea, showing a resurgence. Previously, that controlled malaria, but now we're seeing a resurgence of cases in the same. The elimination picture, what you're seeing in green are the countries that have eliminated the malaria. What we're seeing in red are the countries still controlling malaria, and largely we see the biggest chunk is in sub-Saharan Africa, with parts of Southeast Asia and South America still having malaria cases to control. This has been premised on the fact that these areas provide a suitable ecological niche for the breeding of malaria-causing vectors, the Anopheles mosquito. Why the stalling? We have identified key 3 biological threats. The first one is insecticide resistance. The second one is resistance to drugs that have been known to have high utility in treatment of malaria, the ACTs. We're now seeing a growing burden of artemisinin resistance being reported in Africa through confirmation by molecular markers. And lastly, diagnostic challenges. The HP3, HP2 deletions are making these organisms very clever towards evading diagnosis. The other causes are financial challenges. Many funders or key players in malaria control, I think, have reached a tipping point where they feel that their efforts are no longer causing the wanted change. Others are shifts in climate, population, and vector population. And then conflicts in some areas limit control measures. Yes, what can be done? 2 proposals. The first one is the high burden to high impact approach. This is a targeted approach with 4 response elements. 1, the political will. 2, information for impact. 3, a coordinated national approach. These speak to coordination or moving away from one size fits all towards an approach where you're having targeting of interventions based on need. The other is integrating research and data together with innovation. I think this is where this talk largely falls. The picture of Uganda for malaria is that we have had up to 60 million cases per year, up to 50% outpatient visits, up to 30% all admissions, with about 23% death, especially in the under 5 vulnerable group. And to that extent, Uganda was among the first countries that took up the high burden to high impact approach in 2019. Following an assessment to see where they were. And they found that they were way off the trend for control. The green you see is away from the blue. The blue is a targeted trajectory for control, whereas the green is the actual projected burden. We saw that we were way off the mark, so we had to adopt the high burden to high impact approach. This was done through largely MAM is mass action against malaria through the Chase Malaria Out of Uganda slogan. This is being led by the Ministry of Health through the political support of His Excellency President of Uganda. Yes, but more specifically, we have seen that the malaria indicator survey done, I think about some years ago, has shown variability in malaria burden. You see that, yes, the darker you are, I think the more burden of malaria. And secondly, we're seeing an epidemiological transition in malaria. In Eastern Uganda, where we have a map of Choga, we're seeing a change in the way malaria presents. We're seeing rare types of malaria presenting up, the black water fever, as well as malaria presenting with low parasite counts. So this prompted us to look into this for the past 10 years across 135 districts. For the past 10 years, what is the spatial temporal patterns for malaria? This is in a way to inform response. And our objective was speaking to this one, spatial patterns, and 2 is where we're combining both space and time. Spatial, geospatial largely just means geographical location, whereas the temporal part is the time. The time in this particular case is yearly, whereas the spatial or geographical locations are the districts. For objective 1, this was an ecological study design using districts as spatial units and using the temporal unit being time, being years, every year for the last 10 years since 2030 to 23. Okay, for the first question. Yes, through thematic mapping, aggregating case counts for malaria by district, we see a variability in malaria for the last 10 years. We see the darker you are in brown, the more burden. This picks up data, aggregates it by districts, and gives us trends. We use the Jenks natural classification method because this finds intrinsic natural orders within the data. So we found that a variability, we've seen the northern Uganda, eastern part of Uganda as well as the north central, accounting for that dark brown over the past 10 years. However, this has limitations because, well, this assumes that case counts for malaria are occurring in isolation by district. It doesn't take into place or factor in the neighborhood effects of other districts. So we took another approach in objective 2, which was doing what they call clustering, spatial autocorrelation, joining districts that have high values for malaria together amongst themselves. This is much more meaningful or insightful because it clamps up areas that have similar values. So seeing the dark red is areas of high, the dark blue is areas of low. These speak to clusters, hot and cold clusters, whereas the in between there, the pink to purple, those speak to outliers. Purple being areas of low surrounded by areas of high, whereas the pink speaks to clusters of high being surrounded by clusters of what? Of low. This has public health implications, meaning the public health implications of these 4 categories is that areas of high, the hot clusters are called for public health interventions to try and control because these are areas fueling the disease burden. Whereas the dark blue, the areas of low, the cold clusters, these call for maintenance or adapting preventive measures. The outliers, which is high-low, these call for interventions to as well prevent spread of malaria to the surrounding areas because you're having high areas surrounded by low areas. The same thing with the other outlier, which is the low-high. This might as well have
5 minutes.
Limitations because, well, how then would you mean when you have all those 10 maps? How easily interpretable is that? So we moved a step higher by combining all the 10 years of malaria burden into one map. That for all the malaria burden for the last 10 years, across the 135 districts, can we just have one map that communicates to the policymaker, to the person doing the interventions to have a more meaningful or insightful decision to make? And we found, yes, using a space-time permutation, we found 11 clusters. 7 of these were significant, the biggest cluster being in northern Uganda. And then we used ArcGIS to come up with what we call space-time tube. This space-time tube enabled us to do 2 key analyses. One is a trend analysis, and the other one is a classification of the hotspots. Yes, for the trend analysis, we had 2 aspects. Location by location, meaning yourself against yourself for the last 10 years. We found northern Uganda, mostly Karamoja, being significant for this. When we did the clustering assessment, we found 2 clusters speaking to low areas of low malaria burden as well as areas of high. The red being areas of low, sorry, the red being the areas of high burden of malaria, whereas the blue meaning the low areas of malaria burden. And we see the northern Uganda as well as east to north central parts having that. Lastly, we classified our hotspots into 13 categories. What we are seeing as dark red, in this particular assessment, we were able to classify it into 13 categories. And of these, the analysis found 4 key categories of hotspots in Uganda. And this speaks to the malaria story or malaria burden for the last 10 years in the country. We had what they call new hotspots, oscillating hotspots, consecutive hotspots, and sporadic hotspots. These all have different meanings, but because of time, I would probably rush through this. This informed the next steps for the study, the GTX Mark study. And we have used this data to come up with what they call a therapeutic efficacy study, testing the efficacy of malaria in these regions. And we found these clusters very informative in choosing the sites we have chosen. We've chosen 4 sites, one in Moroto, where there is no pattern, one in Mbale where there is an oscillating pattern, two in Soroti where there is a consecutive pattern, and four in Apache where there is a sporadic pattern. So these will probably help us and inform. Is the pattern we're seeing for the last 10 years for malaria due to artemisinin resistance or not? And then lastly, secondly, is that we want to model environmental and social covariates to try and also explain. The two hypotheses we're forming is that one, the four patterns we're seeing of malaria are one, could be explained by artemisinin resistance, but also two, could be explained by the changing climatic factors. And in this way, we want to model using a geographically weighted temporal regression, the covariates to explain why we're seeing these patterns of hotspots in globally. And these are the covariates of the so far chosen through content experts like Professor Peter Olupot who have helped us inform these, including population density, travel time to cities, temperature, precipitation, access to health facilities, and distance from water bodies. These elsewhere have been found to have association with malaria in terms of environmental and ecological covariates. Yes, thank you very much. This marks the end of my talk.
Okay, thank you very much, and you stuck to time. For the next presentation, which is the last presentation for this session, we will stick with parasites, and we'll have schistosomiasis. We'll hear about schistosomiasis in the Republic of Congo, and Dr. Amei Itua is a director of the National Program for schistosomiasis in the Republic of Congo. Is he here? Oh, okay. Okay, might be moved to the next session. I'll now open this up for Q&A. Your break was supposed to be round about now, but maybe we'll have just 3 or 4 questions before we take a break. Any specific questions from the audience? Yes, please. Go ahead. So they're just bringing the mic. Are there any other questions? If you could put your hands up.
If you don't mind, I start.
Yeah, please, go ahead.
So I have a specific question to Dr. Panova concerning the diagnosis of TB, extremely resistant TB and MDR TB and pure TB in Russia. How you deal with the form of tuberculosis which not extracts bacteria? Because you mentioned that during your brilliant presentation that you armed by any kind of diagnostic kits like gene experts, PCR, biochips, and so on, and even in bacteriology. But it's very well known, approximately half of the form of the tuberculosis, especially in Russia, that I know exactly, belonging to form of tuberculosis which not extract the bacteria. How you deal with this situation? How you calculate the real percent of the tuberculosis infected patients, and especially with the profile of antibiotic resistance in this case? Thank you.
Okay, thank you. Maybe we'll take another question, and we'll take a round of questions, and then you'll respond.
Thank you, Chair. Mine goes to the colleague who are from Bustema University who was presented on spatial temporal analysis of malaria transmission. The first question is on the primary data that you used and the reliability of that data to effectively represent the microclusters or the micro transmission dynamics that happen at a sub-district level. And appreciating that there's a lot of variations over time and across districts. And I don't see it in your analysis taking care of it. Chair, if you permit me, I also wanted to take you back maybe to the last session where we had the cholera. We know very well that cholera transmission is fecal contamination of home water sources. But I was at pain throughout from most of the colleagues that presented. This didn't come out clearly on identifying that interface where you have water contamination, where you can be able to actually stop transmission. Right from my colleague from Zambia, and my colleague also from Uganda earlier today, and also I think Burundi, this doesn't come out. And in my view, that's the smallest niche, if that is identified, that can actually stop cholera transmission. As we deal with bigger things, which are infrastructure, water, and of course, actual transmission. Thank you.
Okay, thank you. So we might have to have a response from someone else. Dr. Atwine, I think you had a question, yes? Can somebody, the mic to the, oh, okay.
Thank you very much, presenters. I think actually my question is related to Chove's on the data on malaria. We're more interested in that presentation, but more on the data, how you got the data. Thank you very much.
Okay, Professor Kitara, back there. Yes, okay. And I think that will be the last question.
Thank you, Chair. I would like to thank the presenter
And then we have responses
of the malaria spatial temporal something presentation. It was really great. Thank you very much. But I think there are some issues which you need to address. One of them is about the impact of human being on the areas that are highly burdened. What happened in those areas before 2015? Because it looks like there is something there. Was there something that reduced the immunity of the area, the population in that area, but suddenly it was lifted? That could represent that kind of spatial-temporal features. Secondly, I think if you didn't do any counting of people who were there and results, and then you draw graphs, it looks nice, but it will have, I don't know what to say, but you will explain it later. Now, coming back to, allow me 2 minutes just to talk about one thing or 1 minute.
1 minute.
1 minute. I'd like to talk about the epidemiological and demographic transition in Africa. And specifically when we're talking about infectious agents and infectious diseases in Africa, we should take into consideration those transitioning which is taking place. And Africa is experiencing a double burden of these conditions. Unlike other continents that have had infectious diseases, then they transition into the non-communicable diseases. We are certain that in the next 20 years, we shall be transitioning, because giving an example of Uganda, most of the immunizable diseases have been effectively dealt with. Now, people are living longer. We've just looked at the latest data on the life expectancy in countries in East Africa and particularly in Uganda. We are growing up the other side and we are beginning to see newer forms of conditions. How prepared are we in the next 10, 15 years where this transitioning will be really evident? And most importantly, we've seen the successes, for example, in Uganda, in the control of HIV and AIDS and COVID-19. But specifically for HIV and AIDS, we have also seen rising incidence of non-communicable diseases like diabetes and others. So we should be able to look at this in the whole context as we prepare for the next millennium. Thank you very much.
Thank you. I'd like to invite responses now from those who have questions. In the next 5 minutes, we should be able to finish. Dr. Panova, maybe you go first.
Да, спасибо.
Thank you so much for that question, because it's a very important question. How do you diagnose non-bacterial related tuberculosis? Of course, we can always aim to get etiological confirmation of the etiology of a particular disease. According to the data of the World Health Organization, the etiological confirmation of tuberculosis is always positive in about 50%. In the Russian Federation, this is almost towards 60%. In other cases, when we do not have etiological confirmation, when we do not have a particular understanding of what the etiological agent is in the Russian Federation, even in the other parts of the world, we now start looking at radiological confirmation methods. Chemical therapeutic methods are also used to try to identify these non-bacterial related tuberculosis strains. But I also want to confirm that we are still aiming towards understanding the etiological agents of non-bacterial related mycobacterium. And also, when we talk about we also use PCR because it is very important in seeing the etiological agents for this tuberculosis and reducing the risk of infection. So we still have a role to do more research in this direction. And according to the data in the Russian Federation, we have been able to get up to 80% in certain regions, such tuberculosis, which comes at very early stages and manifests with clinical features. And so we're still looking into this field. Thank you.
Thank you very much for the vast questions, including the permanent secretary. I think our question was overlapping with, I think, Dr. Bosa's question. Primary data source. I would begin with a disclaimer. The data sources are from the Digital Health Information System, version 2. This is housed at the Ministry of Health, and through collaboration, through the PI, Professor Peter, I think collaborating with Dr. Alex Ario, we're able to get access to DIHS, and we're able to abstract data for the last 10 years on confirmed malaria cases by year across the 135 districts. Yes, was it perfect data? No, but yes, we all know that no data is perfect. We make do with what is available. I think when we look at the national structure, we don't have any routinely or regularly carried out cross-country survey for us to do this level of analysis and say over the years, over time, what has the burden of malaria looked like. And rightly so, to the ecological designs, this is largely meant to generate hypotheses. You see us going into second phase by saying, we're now using the hypothesis we have generated from this data to try and see what are these trends through a therapeutic efficacy study to test for artemisinin resistance through delayed present clearance as well as molecular markers. But also two, we go ahead and try and model environmental factors. Professor Kitara asks about human activity. We can't do the biology because this is retrospective data. What we do is try and look at human activity indicators, things like access to urban setters. That changes over time and speaks to the urbanization. With urbanization, there comes a number of human activities that disrupt the ecological niche where these human beings are. We had reporting rates going, the lowest being about 45 during the COVID-19 time. We all know what the lockdowns and the COVID-19 interventions had in terms of access to health facilities. This is health facility level data. Yes, it might not necessarily represent what the community burden of malaria looks like, but well, it's what we have available and probably what gives us insight into what the community burden actually looks like. Yes, population estimates. We don't do this in silos. What you're seeing as the incidence is we get the case counts for malaria and divide them by population. That's in a way of standardizing the what? The estimate. Because if a particular sub-region, let's say maybe Kampala, because of its high population, has a higher burden of malaria. It won't in a way compare with a smaller district with a smaller population. So to try and bring everyone on an even platter, we try and divide every malaria case count by the respective population estimates for that particular spatial unit, which in this case was district. District-wise, why? Because the lower we went, sub-county level, parish level, village level, the more the data became trace. We had reporting. Reporting levels were highest at district level. That's why we limited our spatial unit of analysis to the district level. Well, it might look big, but I think the lower we went, the sub-county level, parish, village level, I think the more we're having missing data. And the analysis is very sensitive to missingness. What do we call missingness? Is it zero, or do we impute? And all these have different meanings in terms of the overall analysis. The other thing is that we try to apply rigor to our analysis. We didn't only use one software, we used 3 geographic information system softwares, including GeoDa, QGIS, and ArcGIS. And all these were almost speaking to the same output. So that level of applicability of rigor in our analysis also try to, and probably try to kind of cement our findings. Lastly, and then what we're calling significant hotspots were very restrictive. Our parameters for calling something significant were we applied a very strict criteria for that, including a p-value less than 0.0001. It has that. That in a way to reduce the chances of what you might call a type 1 error, of coming up with a false positive finding, which might not actually cause a lot of panic around. So it was a bit restrictive.
Okay, thank you, Chair. I think, Professor Olupot, 30 seconds.
Thank you, sir. Permanent Secretary, yeah, the response to that is that this project is a partnership between Ministry of Health, Busitima University, and Mbale Clinical Research Institute. So Ministry of Health accessed us that data, and for purposes of precision, we are now working with the malaria control program for prospective data collection other than retrospective, and we are starting with marking of malaria resistance right up to village level, because those are easier. So the data that we shall be generating going forward will have that level of precision, because we are starting with a smaller group, and once it is feasible, we now enlarge it to involve sub-county level, which has health center 3. Then about the water sources, we have already piloted with Aeromenus hydrophila, which is always mistaken for cholera. During that outbreak of ginger last year, the Epifellows managed to go there, and we were able to go right up the water source, and it was cordoned off, and the infection just went down. So we are now using that model for also cholera.
Professor Olupot, can I suggest you have a private conversation after this to respond, and then there's a cholera aspect as well.
Let me interrupt you. So I guess we will have some roundtable after the next session.
Yes.
So you will get a brilliant opportunity just to discuss with each other. Okay?
Yeah, so I'd like to thank the presenters during this session and the audience for your questions, and of course my co-chair, Dr. Vadim, and I'll invite you to the health break. We'll keep it short so that the next session can not be too delayed. Thank you very much.
colleagues, please sit. It's time to start our session. Dear colleagues, our session will start. Please sit.
Dear colleagues, we need to start this session. So we want to invite you back so that we can start our session that ends the day. And the session is on disinfectology. Yeah, so in order for us to manage time, we want to start this last session, and it is going to be our shortest session, probably not lasting more than 30 minutes. And we have two presenters this afternoon. The session is on disinfectology in prevention and response to infectious diseases. As I said, we have two presenters. One is, I call him Andrew, from the Institute of Disinfectology, and Dr. Moses from Busitema University. So we shall straight away start with the first session on disinfectology as the main area of non-specific prevention of infectious disease and parasitic diseases. And to present it is Sai Andreev from the Institute of Disinfectology of the Federal Scientific Center of Hygiene from Russia. Thank you very much.
Dear colleagues, nice to meet you in Uganda. I'm very pleased to do my presentation. And first of all, I would like to thank all organizers of this conference. They did a great job, and they do a great job. So let me continue in Russian.
Dear colleagues, my presentation is geared towards disinfectology. And this is a rarely used word, especially in the medical practice. And in Russia, it was formed particularly in sciences, and it was established as one of the main areas of non-specific prevention of these diseases. And today I want to explain why we started this direction, this area of disinfectology in our area of, and I also want to explain why it was taken as a separate scientific area. I want to talk about the actual research that is being done in this area in Russia. I want to begin by talking about the history and to talk about which times we started having the beginning of this disinfectology. Of course, Joseph Lister was, I will say, is the point at which we began using the first rudimentary signs of disinfectology. And this was because he used to use carbolic acid to treat hands and surgical tools. And this was in the 18th century. In the 19th century, sorry, when we started having combating against sepsis, and also started seriously fighting against microorganisms. And in Russia at this period, there was a scientist, Nikolai Pirogov, who also made a breakthrough in the fight against wound infections. And this breakthrough by this scientist was, of course, very crucial in reducing the spread of infections. And so we are speaking about microorganisms, but now let's speak about other types of infections or infectious agents that are a threat to human beings. In many different countries, we already saw that in the at the end of the 19th century, we still were talking only about microorganisms. And we also had to open disinfection chambers, for example, in 1883, that were important for disinfection of clothes, of other materials that were used. And the first disinfection chamber was opened in St. Petersburg in 1883. And towards the end of the First World War, we had a full network of such disinfection institutions. And in 1933, we were able to now found the Disinfectology Institute over a period of time in Moscow City. And I believe that this can be called the beginning of the use of disinfectology. I apologize for the long historical lessons that I might take you through, but I believe that sometimes they have a philosophical character. But I wanted particularly to also show you that it's not only a scientific part of medicine, but also histological part, because we want to show how far we have come. And we want to start with World War II. The institution that we had of disinfectology was not affected. Sorry, and it continued to work with disinfectology as one of the main areas of disinfection. And that was during 1941 to 1945. So even after the World War II, the area of disinfectology continued to develop, and it was able to include areas of studying mechanisms of actions of disinfectants on microbiological organisms. It was able to now include physical methods, for example, UV light disinfection. And also disinfection of apparatus began more seriously in this time. Okay, we are done with now the historical part. Let's go to the epidemiological foundation of disinfectology. When we speak about the epidemiologic significance, particularly prophylaxis, we need to remember just one simple fact. We need to remember that vaccination is a very important part in the fight against infectious microorganisms. But now let's take a look. Let's take a look at the natural foci of outbreaks in the world. Usually, zoonotic infections is what I'm trying to talk about. So we only have 10% of vaccination taking place of all zoonotic infections in the world. But from the other side, I want us to also pay attention to from 1913 to 2022. We actually we realized that from the 1940s to 2004, more than 60% of all new infections were zoonotic infections. So of course we can fight with these infections through vaccination, but there's another way also that we can use, and that is prophylaxis. And we also saw this during the COVID-19 pandemic, that we had to find different methods of prophylaxis and fighting against the infectious agents without vaccination. Apart from the fact that non-specific prophylaxis is the first line of defense, I believe that it can be a very effective weapon if it's used, and I'm speaking about disinfection. And I want to give an example on this, which has practical significance when we talk about this non-specific prophylaxis. So in Russia, we had malaria from 1913, and we had almost 3.4 million cases. That is in 1913, and this is the first time when Russia started actively fighting against malaria. And it was fully overcome. We fully overcame this malaria infection. And in the most recent statistics of World Health Organization, we have only 113 cases of malaria, and all of them are imported. And that means that we only get transfer of this malaria from out of the country, but not within the country. And another example that I want to draw attention to today is typhus, as an example in Russia. It was very difficult to find a vaccination for typhus, and it was the way we won it, we overcame it was mainly through measures of prophylaxis that were instituted, and not necessarily only during vaccination. And as you can see, from 1920 to 2001, we completely eradicated typhus. And the last one is tick-borne viral encephalitis. And the vaccine of this infection is there in Russia, but we understand that there's been a change in the morbidity for this particular encephalitis, and it's most prevalent in places where people rest or people take holidays. So in this way, as I've already shown, want us to pay more attention to disinfectology. It is a science which, together with epidemiology, acts on working with the way of transmission. So it stops the transmission from sources to the recipient. And the sources could be viruses, fungi, it could be bacteria. And the vectors of these pathogens could be insects of different kinds. And as has already been spoken, there are three main areas of disinfectology. The first one is disinfection, and I think everyone is aware of disinfection. And for us, we call it the fight against microorganisms. The second area is disinsection, and this is the fight against insects and ticks. We have heard a lot about it, and today and yesterday, and in the Russian Federation, this problem of vectors spreading infectious agents is a very wide problem. And the third area of disinfectology is deratization. It's a harmonized term. And of course, when we speak about the creation of preparates or drugs against all of these things, there are two main principles that we follow. The first one is the efficacy in relation to the specific target species. And so we want to make sure that when we are trying to target a particular infectious agent, we don't want, let's say, the cats to die or any other animals to die. It has to be specific. And the second principle is the safety for people and the environment, because sometimes the disinfectants can be harmful to people and animals, and we want to make sure that it's safe for use. And let's look at some recent tendencies that we see in disinfectology and where we suspect that it will move. So in recent times, after the COVID-19 pandemic, products and materials with antimicrobial properties have been created. And for example, if we touch someone or something in an autobus, and we are not able to use spirit or alcohol to disinfect or sanitize, that is an example that we took, and it's from there that we started trying to get products and materials that can have antimicrobial properties for a long time. So that means that this the microorganisms should be already liquidated already at the beginning of their infectious process. And so we started looking for new active ingredients to create new composites with stronger antimicrobial properties. And we have a few examples that we see, a few examples of ingredients that we've used in our laboratories. As you can see them, we have some of them that we use on medical gloves, and they have permanent effect against microorganisms. And we are working, and so we are even working on making this not only a project in particular laboratories or hospitals, but we want to make it a mass production, even in factories, to create these new active ingredients against microorganisms. And so we have a lot of prospective uses for these materials. And some of them also involve materials or metals that we're still researching into and we're still studying to understand their properties. So we have spoken about microorganisms. But now let's talk about the fight against the insects and the ticks. So in the recent times, we have been concentrating on if I'm to be honest, this particular field now with insects is not yet fully well studied. So we're still carrying out experiments and research in this field. When we started collaborating with African partner states, we understood that there was rodents that also are responsible for spreading infectious diseases. And we want to make sure that we are able to get active ingredients against these vectors for these infectious diseases. And so, in my own opinion, I believe that if we concentrate on this field, it will strongly change the tendencies of the spread and transmission of these of these infectious agents. For example, we are having portable mosquito repellent devices that have repellency rates up to 88%. And most of these are actually taken from naturally occurring plants and elements. And so we have also been able to take up lessons from the pandemics that have taken place. We have seen, of course, a big increase in the microorganisms that cause we have seen an increase in microorganisms with resistance, and we still continue to study this area. whenever we analyze these data, it causes us to start having ideas and thoughts on how to use disinfectology as another new method of controlling the spread. And of course, sometimes even in the hospitals, we have seen the formation of super strains of infections. And it is in this understanding that we have to create better active ingredients for better results in in decreasing the risk posed by them. For example, in our tests, we realized that Microbacterium fortuitum was selected as a candidate test strain for evaluation of the activity of disinfectants. And we have a very big problem with resistance. Even when we talk about vectors, they do have all different types of resistance, whether it is to phosphoorganics or to other types of elements to which they are tolerant. And so we continue to study through molecular and genetic mechanisms the resistance in different regions of Russia. But we continue to also look for modern applications and modern technologies. We continue to test and investigate, carrying out research against to see the resistance and tolerance for these microorganisms and macro. And there's something also more interesting that I want to show us. We also saw that for the past 20 years, there's been a resistance to anticoagulant therapy in blood. And before this period of time, we never used to pay attention to it. But now, this resistance has come to our attention. And this can only be remedied by controlled development in express methods of indication and optimization. So we have started this work of studying it in the previous year, and we have been able to take more than 2,000 samples from the whole country, and we continue to do a phylogenetic analysis of these populations so that we can get better results. And of course, we also have toxicological research. I've already said that one of the principles is to assess the toxicity to humans and to the environment of all these substances. I cannot fail to express the importance of training and preparation of personnel, because any work that we do has to be undertaken by qualified personnel. And so this is essential for the effective prevention of these infectious diseases. And so this has to be taken such, as you can see on this graph, we have different aspects of this training as we have been able to conduct them. And so at the end of my presentation, I want to go back to the first idea that I laid before us, that when we do not have a vaccine against a particular microorganisms, that means that we have to then go back to non-specific prophylaxis, because it then acts as a first-line defense against particular microorganisms, because it stops the transmission of these infectious agents. Thank you so much for your attention.
And Rev, I will now go straight to Andima, and there's been a change of topic. The previous topic was supposed to be presented by Associate Professor Sam Rwahire, who could not make it, and he got a dangerous substitute in the names of Dr. Andima Moses, who is a lecturer from Busitema University. And he will be presenting a topic which is related to disinfectology, targeting the hard to reach, that is challenges and novel approaches to treatment of intracellular bacterial infections.
Yeah, thank you so much. Moderator, Dr. Andima Moses, a senior lecturer in the Department of Chemistry. And importantly, I am closely associated with the Natural Products Research and Innovation Center at Busitema University, where we are trying to develop natural therapeutics for treatment of infectious diseases. And so I will talk about targeting the hard to reach as an approach to disinfectology. So I will share experiences from some of the recent work that I've done, trying to look at the challenges and then the novel approaches that can be used to treat intracellular bacteria. So we already know from statistics that over 1 million people actually die because of infectious diseases. And if you look at the statistics, more of the deaths actually occur in Africa. And why this is so is because of multi-drug resistance. Whereas we have antimicrobial agents to treat most of the infectious diseases, but then because of illicit use of antimicrobial agents, overuse of antimicrobial agents, unsupervised use of antimicrobial agents, especially in our part of the world, there is overwhelming risk of antimicrobial resistance, so making it challenging to treat some of the microbes. Of particular interest is basically the hard to reach. In this case, those microbes that tend to internalize in the cells. A typical example is Mycobacterium tuberculosis. It tries to evade treatment by hiding in phagosomes and therefore evading treatment, so making it difficult to treat. And this is often a point where a relapse occurs. And then, of course, we already know that bacteria have different resistance mechanisms, but some of these can be overcome when you have drug combinations. But then the intracellular state presents different challenges to drug delivery. For example, you have the cell membrane, which actually prevents some of the drugs to get in. And then even in the phagosome, some of the drugs fail to get in, and therefore making it difficult to treat these hard-to-treat bacteria. I only note Mycobacterium tuberculosis, which is intracellular bacteria, but there are others which are also known as intracellular bacteria. So because of these multiple biobarriers, and then we need to look for alternatives to see that available microbial agents can be able to reach the bacteria. So one of the interesting approaches is to look at what the bacteria actually likes most. So this can be used as a weapon against the bacteria. So I will talk about what we call the iron wars. We already know that iron is an essential nutrient that the cells need. The body needs iron for normal metabolism, as well as bacteria need iron for their virulence. And so iron is highly regulated in the body. And what regulates it actually basically the iron carriers. In the event of an infection, the iron carriers tend to limit the availability of iron to bacteria. But since the bacteria need to survive, they deploy surface receptors that can be able to sequester iron from the iron-carrying protein. And then so this kind of relationship we think can be used to actually target bacteria. So one of the key iron-carrying proteins is actually the transferrin family of proteins. And one particular one which was of interest to me is actually lactoferrin. Now lactoferrin, we get it from milk. The inspiration of this came from earlier traditional treatment. Whenever we would have eye infection, our mothers would actually squeeze breast milk in the eye, and eventually we actually get well. And then so that kind of relationship is what we are trying to use here to target bacteria to deliver anti-infective agents. So our approach is basically a one key for two doors. Because bacteria express receptors similar to that that the cells express to get iron from the iron-carrying protein, and then we can be able to prepare decoy particles loaded with drug that we can be able to use to target intracellular bacteria. So down here is a typical kind of example. So since we are dealing with natural products have also been known to potentiate the activity of other drugs. So one of the important natural products that we have worked on is actually berberine. If I talk about berberine, most of the Ugandans must know about it. It's actually the key molecule that you find in Covidex. So this berberine has broad spectrum antimicrobial activity, but however, it has not been developed further. So my thinking is that if we use a combination of berberine or sanguinarine, which is similar to berberine, with conventional antibiotics, then this could be a possible way to target bacteria. So as a proof of concept, then we here used berberine or sanguinarine in combination with conventional antibiotics, imipenem or vancomycin. Imipenem and vancomycin are last-line antibiotics. But then there's also already reported resistance to these antibiotics in nosocomial infections. So we then looked at potentiating combinations of these drugs, and we found that berberine or sanguinarine is able to potentiate the activity of imipenem or vancomycin. So then the next thing was, how do we then get this combination to target intracellular bacteria? So we then developed lactoferrin nanoparticles. So we get this milk protein and then convert it into a nanoparticle and then log these drugs into it. And then, so this is basically the kind of approach that we have, used. So making this milk protein into nice nanoparticles which actually carry the drug. And then in this way, we cannot be able to target intracellular bacteria. And then the success of this, again, depends on whether we can be able to test these nanoparticles. And then so you have to establish in vitro testing models which can be used for preclinical evaluation. So our main target was pulmonary infections, because then we were battling COVID. And we also know that these viral infections come along with bacterial infections. And sometimes it's the bacterial infection that actually kill people. So we thought then, let's target the bacteria while Covidex is targeting the virus. So in this case here, we had to look at in vitro testing models, which can be used for preclinical evaluation. So here we developed an in vitro testing model using a differentiated macrophage, differentiated THP1 cells. Because for pulmonary infections, a number of intracellular bacteria actually hide in the macrophages. And then apart from developing this, then we have to mimic the lung microenvironment. So in this case, we have to develop a lung liquid kind of interface where we grow cells at the lung, at the air liquid interface, so that we can be able to mimic the lung microenvironment. So in this case, we're able to test our developed nanoparticles. So, one thing that we have to look at is, are these nanoparticles actually taken up by the cells? And then so we actually observed that yes, these nanoparticles are efficiently uptaken by the cells. But then in the pulmonary system, we also have pulmonary surfactant, which actually affects delivery of drugs. So then we need to overcome this pulmonary surfactant. But also the beauty with lactoferrin is it's present, available in the lung surfactant. So we can already see, even in the presence of the lung surfactant, there is nice uptake of the lactoferrin nanoparticles loaded with the drug. And then so this was quite a nice thing that we can be able to use to target intracellular bacteria. So we also already see further that surely the drug-loaded lactoferrin nanoparticles are nicely internalized by the cells as we checked this with confocal microscopy. And then, so we then checked if this kind of platform can be able to eradicate intracellular bacteria in our in vitro testing model. And so here is basically the extracellular bacteria, and we already saw that our drug combinations loaded in lactoferrin nanoparticles, for example, are able to reduce the colony counts for these bacteria extracellular. And then we checked again further if this combination can be able to eliminate intracellular bacteria. And as we see in the next graphs, we actually see that, for example, a combination of berberine with imipenem and then sanguinarin with vancomycin are able to completely eradicate, for example, S. aureus. So S. aureus is one of the model intracellular bacteria that we used. And then this kind of platform caused a bacteriostatic effect against Mycobacterium abscessus. So this kind of platform could be developed further to actually target hard-to-treat bacteria. So if this can be used to treat hard-to-treat bacteria, then the next task was how do we then translate this from the lab bench to the bedside? And then so since my interest is pulmonary application, the nanoparticles as they are will be a little difficult to administer in the pulmonary system. So then the best thing is to make a spray-dried powder that can be used for inhalation. And then so that means to put these nanoparticles in a microparticle so that we have very good aerodynamic properties that can be used for inhalation. So in this case here, down here are quite interesting images, scanning electron microscope images of nano in microparticles, where we have our nanoparticles encapsulated in microparticles. And this actually has some nice aerodynamic properties that can be used for inhalation. And so this is work that is ongoing. So we are hoping that this can actually go into clinical trials to see the effectiveness of this kind of platform. So with that, I will thank you so much.
Wow, thank you so much, Dr. Moses. This is a very good way to wrap up a day like this. And I think we are moving in the right direction. We have saved a few minutes for some questions. We had a talk on disinfectology where we came to understand that actually disinfectology is not only for pathogens, but also dealing with insects and rodents. And one of the things that intrigued me was the fact that these rats have also become resistant to anticoagulants. So it was really quite intriguing, and I think it's research that we need to also think about undertaking in our country, because vaccines are good. We are only targeting the organism, but there are also sources where these organisms are coming from. So we need to look at that. The other thing on the disinfectants, we use them quite a lot, but we haven't taken deliberate effort to assess their effectiveness. I think in hospitals every morning there is use in theaters, but are we really sure that these disinfectants are working? So that's a great point for us to note. And there was also that if, when I first heard about disinfectology, I thought it was just disinfectants. But there is much, much more to disinfectology, and I think we will continue to work together. And that other session on targeting the hard to reach has really a lot for us to learn from, and I think we are glad that we have Dr. Moses, who is in Uganda, because for most of us, we are used to seeing these things from abroad, but at least we have Dr. Moses from Busitema University, who is a chemist, but also doing biology. So we welcome a few questions. Yes, the mic.
Thank you very much. Thank you for that very good presentation. I'm Lamaka Alice Veronica, a senior lecturer at the Department of Pharmacy, Faculty of Medicine, Gulu University, and an innovator of Covilized product that was used in the management of COVID-19, particularly in northern Uganda. And I believe you all heard that Gulu Referral Hospital, which is a teaching hospital for our Faculty of Medicine, performed very well as far as the management of COVID-19 is concerned internationally, and the mortality rate in that facility was very, very low. Now, I'm also carrying out research on natural products in managing both communicable and non-communicable diseases. Your presentation ties up with what we are dealing with, pulmonary conditions. And as far as natural products are concerned, they have very many phytochemicals. And I'm wondering why you picked on to just one little aspect and zeroed onto that, and in managing bacterial infections. And yet, sometimes we have very bad fungal infections due to maybe aflatoxins, and you have not mentioned that. Then, apart from that, we know that lots of combinations of synthetic medicines with natural products also goes along with side effects. So what are you going to do to manage the probable side effects that may come along with it? And also hypersensitivity reactions. Thank you.
I want to thank the last presenter. Your presentation was really, really good. And we want to thank you for where you have reached. I wanted to know why you didn't do monotherapy. Why did you do the combination? Because I think in the trial group, we need to see the effect of the trial medicine other than using also vancomycin. Because, vancomycin should have been one arm, and then the trial group is in another group. So I wanted to know whether you have a control group and then also the study group. Then I wanted to know as well the issue of, because when you make the inhaled product, the environment in the outside the body is different from if you inhale, because the temperature. So did you test also the effects before even you think of coming up with the chemical that you have modified to fit into the aerosol? did you also test the temperature stability? Because in the lab, in the lab, the environment it is in, it can be different when when you inhale it, because when it goes in there, because of the other microenvironment factors, it can degrade it, it can affect it. So did you first look at also the temperature? Because I know that the temperature has also the impact on the stability of that medicine. Thank you very much. But otherwise, really, we will congratulate you, and we hope really that this will progress very fast, and you patent. Don't let other people take this patent, please. Because I know that we have had a challenge. We work with partners. Whatever we do, at the end of the day, I have seen that you are being supported by some other people. I hope that they will not take our patent, and then we stop at that. But also we need to expand this study to look at other natural occurring medicines that have actually active medicinal ingredients that we can actually develop. And so this is something that we can push, and we see in that we are supported so that you create a clinical trial group that you establish not only in Busitema but in other universities, so that you have that interconnectivity in the research, so that we are able to develop more medicines locally. Because we have a lot of knowledge, but we don't get to the end to conclude this. Thank you very much.
Okay, we have 2 more. Okay, 3 more.
Merci beaucoup. Je voudrais m'adresser au premier intervenant, qui est Sergei André, qui a présenté un thème très important par rapport à la désinfectiologie, que nous sommes très intéressés au niveau de notre institution pour voir la possibilité de déterminer les désinfectants naturels qu'on peut extraire des plantes de chez nous. Quand je prends les problématiques des tiques, généralement qui dérangent le monde, et en même temps les punaises. Les punaises en Afrique aujourd'hui, il y a partout les punaises qui fatiguent les gens. Nous voulons travailler dans le sens de trouver les désinfectants naturels et faire
that we could use this and use them for the whole population. I was saying that our institution is interested in this research because we have natural plants that are in our environment, but we have not developed this system of getting disinfectants. So is it possible for us to do some collaboration with your institution and get partners to carry out this work? Thank you.
University, pharmacology and therapeutics. I got interested in the presentation on disinfectology or disinfectionology. It seems it is used interchangeably. But my interest is in regard to the overall ecosystem as regards the food chain, especially the use of herbicides and acaricides, which we know most of them are used to protect animals, to protect plants from the different organisms that may disturb the process of farming in animals and plants. And we know that most of these acaricides and herbicides in the long term, they are harmful to the ecosystem, to the environment, and also to the humans per se. And many problems are attributed to such elements in the ecosystem. So how does that concept, how can it be brought on board as regards the food chain as well, in regards to herbicides and acaricides? Thank you very much.
Last question.
Thank you, Chair. My name is Driwale Alfred. I'm Commissioner Human Resource Development. I want to thank the first presenter for having taken us through disinfectology. With interest, I picked the fact that malaria was also there in Russia and got eliminated. I would just like to know what lessons we can pick from the elimination approaches which they had, and so that we compare whether we're on the same path or not. The second issue is about concepts of disinfection which were raised there. Some where you have antibacterial properties which last for long. Are these at conceptual level, or these are already rolled out into practice? Thank you.
Thank you. Yes, you could start. Dr. Ndima. Okay,
Yes.
Ndima, and then Andrea.
Yeah, thank you so much. So the first question was, have we looked at the side effects? Why only one aspect, not a why one aspect? What is the effect of a combination on, I think, toxicity? We actually did toxicity studies, but this is yet in vitro. And we have also done independently toxicity of some of the herbal extracts that contain the key compounds, berberine and sanguinarine. And we realized that they are somehow toxic at high concentration, but then they profit from the drug combination. And then another thing is that when you have a combination of drugs, it's a little difficult for bacteria to develop resistance simultaneously to two molecules at a go. So our interest is that if we can target one resistance mechanism and then actually target the bacteria with the other, then it will be an effective way of eradicating such intracellular bacteria. So for the toxicity, yes, in vitro we have done toxicity, but at low concentrations, the toxicity is minimized, and in a combination, the toxicity is pretty low. We just recently published part of this study, but not all of it. And then, thank you, Dr. Twine, for the compliment. You asked about why combination and not monotherapy, and actually we did the two studies. So testing the drugs singly and then in combination. And so we realized that the combination was actually better than when you use the drugs singly. And so we will try to pursue this further and see that we can take this to clinical trials. And then the stability of the inhalation powder. Yes, in vitro, we've tried to study the stability of the inhalation powder. under physiological conditions, so that means that we try to mimic physiological conditions. And then also we're trying to look at this mimicking the lung microenvironment in the air liquid cultures. So the early models are those that are actually now currently being used. And then another study that we definitely do not have the resources now, but if resources could permit, is to establish this kind of testing lab where we could develop different testing models. So we could actually have primary cells that we can be able to use to develop these testing models and test some of these kind of products that we are coming up with. Yeah, and I think now that the government is really trying to support research, this is one of the areas that we'll try to push forth to the government and see if we can get support in establishing kind of cell culture labs that we can be able to use to develop in vitro testing models. Yeah, and then in terms of continuity, yes, this project was kind of funded somehow by the German government. But I think now back home, there should be some continuity, and we should be able to develop some of these technologies back home here. If it can be done elsewhere, then we can also do it home here. And all the brains are around. It's possible to do it. Yeah, thank you.
Okay, next.
Okay. I'll be answered in Russian to be more accurately.
What concerns the first question, we are really open to working together in the natural products that can be used in disinfection, and we can always exchange contacts and discuss how to work together on future projects. Concerning the effect on the ecosystem, we look at disinfectology as a science that is on a border between what disturbs the person from living and what disturbs the ecosystem, the environmental ecosystem. So, of course, we do not have an aim of eradicating all microorganisms. We have to be able to look at the risk posed, risk and the threat given to the environmental ecosystem and also to the people or human beings. So this is the basic principle. We have to form that balance. And this is why we are continuously working on new and modern technologies that would allow us to have as little, as minimal effect on the ecosystem as possible. And of course, we cannot kill the ecosystem because it's all around us, but we have to still be in harmony with the ecosystem and be careful with what we used. And I'm aware of the overuse sometimes of pesticides and other chemicals, and we have to always remember these points as we are doing our scientific research. And now about the malaria. In the Soviet Union, when we were working against malaria, there was a complex of measures that were taken. Russia is a very big country. And of course, malaria was not in one place. It was in other places too. It was in Moscow region. So, for example, Moscow is in the center of Russia. And it was considered an endemic area for malaria. So there were complex measures that were taken in architecture. And of course, these measures some of them were geared towards the control of the movement of fish and also the movement of water supply and water sources. And this was one of the first lessons that we could learn from this part. When we put our aim as elimination of malaria, we have to know the scope that we are dealing with, as has been already pointed out with the ecosystem. So we have to take into account the possible risks in our action and effects on the ecosystem. So in my own opinion, we still continue to develop cooperation with African partner states, particularly with malaria. And the main idea that we want to move across is not total elimination in all territories, but we are aiming at eliminating malaria in those places where people stay, where malaria is concentrated, especially in these cities. And we are starting particularly with that. We have already been speaking with our colleagues that it's mostly in tropical climates. And of course, also in Russia, we have elements of tropical climate. And so in Africa, we also want to start these zones that are free of malaria, and slowly by slowly to be able to use different substances. We will have physical substances and elements that we are using in this fight against malaria. But we also plan on applying microbiological elements which act particularly on mosquitoes. They have been well recommended in Russia and we have noticed that they have a less effect on the ecosystem than the chemical elements. We continue to research the combined elements also against this malaria pathogens. And as we have also seen, sometimes we have seen more effective substances against both fungi and other plasmodia. And the second part, we are still looking at a project of materials which we are still creating in the laboratories. We want to relook at the system. So as much as we are looking at disinfectology, it's a complete system of all the measures that we are using and that we are taking. So we want to look at a system whereby our task is put in a complex. The first thing we have to do is to understand to create a system where we understand what things need to be disinfected, and then we can go ahead. You have to also understand that that is the main thing that is going to be based on in the system that we want to do. And we will be very glad, yes, if any of you could join us in this kind of project that we are looking at. It's a big project that involves a lot of resources and time, and we're still working on that. Thank you.
Thank you so much for that question. One of the things that strikes me is this insection, how to deal with these insects and mosquitoes. I believe that if we found a magic bullet to deal with mosquitoes, we would deal with malaria probably more decisively. Because I don't know in Russia if they have mosquitoes like ours. Because the question that was in my head is, if they have imported malaria, why doesn't it spread? Okay, so probably they did something to the mosquitoes, that either the mosquitoes are dormant, docile, they don't bite, or they eliminated them so that even if you have imported cases, the malaria will not be able to spread. So, ladies and gentlemen, thank you so much for listening to us this evening. We have a very great program tomorrow that no one should miss. We have a demonstration for the mobile laboratory. Okay, I think, yes, there's something. Okay, you're very welcome.
Thank you. Dear colleagues, ladies and gentlemen, a small housekeeping reminder. Tomorrow we start at 9 and we start here in this hall. We should not go to the labs first. We start here, and then I will tell you exactly when and how we are going to work. Thank you. Thank you.
Okay, thank you very much. So we meet tomorrow at 9. But there was supposed to be a round table, which I think can continue up to tomorrow at 9. Have a nice day.